हाँ उन्होंने आगे लेटर बनता है हाँ
बिल्कुल बिल्कुल करा देंगे भाई जी आगे नो प्रॉफिट बिल्कुल दे करा देंगे
करूँ जल्दी मैं
ऊपर बैठा है हेलो ठीक है
वो वाइड वाला लगा वही पकड़ लो माइक नहीं लगा
नीचे बैठा है मैं हो गया
कॉपी कर देना ये सभी
Good morning, everyone. The advancements in field of surgery have always been a testament to human determination, creativity, and inherent desire to heal and improve lives. Today, on behalf of Department of Pediatric Surgery, AIIMS Jammu, I, Dr. Vivek Pandita, extend a warm welcome to all the dignitaries and delegates. Today, all of us have gathered here to commence the 9th Annual Conference of Research and Innovation in Pediatric Surgery. It's a great privilege for AIIMS Jammu to host this mega event in collaboration with the Research and Innovation Pediatric Surgery Society. Our goal is to bridge the gaps between the professionals, foster understanding of new discoveries, and shine a spotlight on the innovations that will shape the future of healthcare. Let this conference be a beacon of hope and a platform for sharing the collective wisdom of the global medical community. With this, it will be my honor to invite on stage the esteemed chairpersons for our first session. Please give a big round of applause for Dr. Professor Nisar Ahmed Bhatt sir, who is the professor and head of Pediatric Surgery SKIMS department and is a widely acclaimed researcher with over 80 publications in international and national journals. Thank you, sir, for gracing the occasion. Next, we welcome Dr. Professor Abdul Rashid sir, who is Professor and HOD of Pediatric Surgery Department in GMC Srinagar. We extend a warm welcome to you, sir. Next, I would like to call upon Dr. Professor Shabab El Angurana, who is Associate Dean and Research and is heading the Department of Radiation Oncology in AIIMS Jammu. We welcome you, sir. And last but not least, Dr. Renu Sharma, who is a renowned surgeon and is currently Associate Professor, Department of Gynecology, AIIMS Jammu. We welcome you, ma'am, to preside over this session. I would request our esteemed chairpersons to call upon the first speaker for our first session, Dr. Shilpa Sharma.
May I request the AV section to kindly switch on all the mics, as the panelists may use the mics for calling the participants and the delegates on the stage. This mic we are using? Okay. The mic is not working. Hello? Hello? Okay, thank you.
Good morning to all of you. At the outset, on the behalf of JK chapter of IAPS, I would like to welcome all the delegates for their participation and encouraging us on this maiden event. And I am also pleased to see my mentor, my teacher, DK Gupta, with his Mrs. address on this event. Thank you, sir. So let us call upon our first speaker. We have the Professor Shilpa Sharma from AIIMS Delhi. So she is going to talk about the framing and research question and appropriate methodology. Shilpa.
Good morning, chairpersons and dear delegates. It's an honor to be here today. I've been involved with AIIMS Jammu ever since its inception in 2020 with Professor Shakti Gupta and in the selection committee. So it's really an honor to see it growing brick by brick into buildings. Today we'll be talking about framing a research question and appropriate methodology. They're very big topics, so I'll be just giving you insights into both of them, especially for the students who may be watching online later after their classes finish. What is the definition of research? Research is a systematic process of generating new knowledge and technology. The key word here is new. If you're doing something on audits, that's not research. The 7 key characteristics are logical, analytical, cyclical, critical, replicable, empirical, and methodology. The aim is to improve the existing situation for mankind. The steps of the research process are easy, but they need to be systematic, and one needs to know where to go about. What happens is that some people start in the reverse order. They try to write a paper and then they think, what am I going to write? And it's the reverse order. So that's not the way. First think of a question, do extensive research on it, find the new things, find the gaps in the knowledge, develop a research hypothesis, prepare the design, determine what kind of design it is, collect the data, execute the project, analyze the data, test your hypothesis, generate and interpret the findings, and finally report the results. So today we'll be talking about the initial 5 steps. The objectives would be to frame a research question, the appropriate methodology, hypothesis, objectives, and a talk about study designs because it's important. So what is framing a research question? It is the process of breaking down a research question into its key elements and setting up boundaries for the study. How should it be? Should it be clear? Should it be ambiguous? Should it be complex? A broad scope, narrow scope, difficult to answer, or easy to answer? The answer is it should be focused with appropriate scope and it should be researchable. The analytical questions are much better than the descriptive ones. So how should a research question be? Clear and focused. One needs to state what one needs to do, have an appropriate scope. It should be analytical, feasible in our circumstances, especially with low resources that we have, specific, complex enough to develop an answer over thesis or paper. The acronym FINER MAPS describes it well: feasible, interesting, novel, ethical, relevant. There are some scientists who will not even talk to you if you don't have a novel idea. So the most important thing is it should be novel. Manageable, appropriate, potential value, and publishability, and systematic, of course. So how do you do it? Choose an interesting topic which interests you. You have to have the passion for the research. Do some research. Consider your audience. For whom are you doing that research? Start asking questions and then evaluate the question that you have asked. So these may be based on the prevalence of a condition. For example, what is the incidence of biliary atresia or prevalence of biliary atresia in Jammu? Characteristics of a new test which you want to use. Agreement, correlation, if you have found something in your clinic and you want to do a study on it. Risk factors of an outcome or effect of an intervention. That is especially true for surgeons who want to try their new techniques. What are the components? The participants, the intervention that is going to be done, the comparison, the outcome, and the 5th component is the type of the study. So PCOS is the acronym that should be used, and when you're making the title of your study, All these 5 things should be there preferably. Coming to the methodology, you have to write the protocol, which should be well in advance and it should be sacrosanct. For example, if you throw some colored pencils, you're not going to say how they align, how many blue and green are lined together. So you have to predetermine what you're going to see. So you have to, before throwing the pencils, you should have an idea. Let's see whether they get into a bunch or they are scattered. The protocol document should be outlining the question that one is trying to answer, and it's a very important step. The ingredients of the protocol include the background, why do you want to do it, your specific objectives, the study design, the study population. I'll stop here for the methodology today. So what is a research hypothesis? It is a statement that predicts the outcome of the study and is tested through research. So there are 2 types, null hypothesis, that is there is no difference between the 2 groups of data, and alternative hypothesis that claims that there is a difference between the 2 groups. And then these are tested by statistical methods. The research objectives should be concise statements. So when you're writing a research proposal for grants, this is the main thing that they are going to see. What are your objectives? How clear they are, the scope and the direction of the research. So they should basically be smart, specific, measurable, achievable in Indian circumstances, realistic and time bound. Do not think of research ideas which will take 20 years to complete, because you may not see that happen. The best practices for research objectives are outlined here. One needs to be open to adaptation. So when you go for a research proposal presentation and they give you ideas, do not see it as criticism or they are trying to lower you down. Try and understand each and every point that they are saying, because they are great scientists there. You may have to go back and work on your research proposal. Even if it is rejected, no harm. Just take it the good part and work on it. So what is a study design? It's a design or a protocol that translates the hypothesis into an operational one, how you are going to do it. The study population, you may have observational studies where you pick up a sample from a target population, or you may have experimental studies where you have inclusion criteria that are set in and then you work on those. So this slide is very important. I would like you to focus on it. The points marked with green are yes and the one red is no. So if you have an intervention or an exposure, you are doing a clinical research. It may be experimental or observational. So if you have an exposure, it is an experimental. If you are just observing, then it's an observational study. The observational study may be comparative. If there's a comparison group, then it's an analytical study, if not a descriptive. So right on the right hand corner, you can see case group reports and case studies are the descriptive studies, followed by the cross-sectional studies. And then you have case control study, where you study from the outcome to the exposure, and cohort studies where the exposure has already been done and you go back and see what was there in the exposure. When you have experimental studies, random allocation is done for randomized controlled trials, and if it's not there, then it's a non-RCT. Sample size calculation. This question is very important for all interviews. So for sample size calculation, there is a formula which is given by Dr. Kameshwar Prasad for our easy access. So for dichotomous outcomes, the formula is as given on the left side, and for continuous scale outcomes, it's n is equal to 16s squared by d square. What is a cross-sectional study? It deals with the present. So whether the exposure was there or not, and whether the outcome is present or not. This is known as a 2x2 table. So here the questions ask what's the odd ratio and what's the relative risk ratio. So when you make a 2x2 table, A by B above C by D is the odds ratio, and A upon A plus B divided by C upon C plus D is the relative risk ratio. Case control study, where you are comparing the present outcome with the past exposure. Case control design, where you have 2 groups, where there's a control group and a study group, and you measure the factors, they should be comparable, and then you compare the factors. A cohort study deals with their exposure, a causal effect present or absent, and the outcome. So these cohort studies may be retrospective, when you go back from the past to the present, or they may be prospective, where you have a sample and then you're going to see in future what's going to be the outcome for this. So clinical trial is a prospective study comparing the effect and value of one or more interventions against a control in human subjects with a given medical condition, and this should be done in controlled experimental settings. Everything needs to be controlled with less and less of confounding factors. Randomized controlled trials can be parallel or crossover. Crossover means when the treatment between the two groups is interchanged. So it's a flow diagram for the randomized controlled trials. You assess them for eligibility, exclude that are not included, finally randomize them into the intervention groups. Some may not receive the random interventions and they may have reasons for that. Some may be lost to follow-up. So all these things are evaluated and finally the results are analyzed. So depending on what you want to study, these are the suitable study designs that you may choose. For diagnosis, a cross-sectional study is good. For therapy, RCT and non-RCT. For the cause, these are mainly for medical people, cohort and case control. And what we usually do as students is case reports, case series and cross-section, because that's how we learn and we go into the research process. There's always time to come back and do later things when one grows up with experience. And for prognosis, prospective cohort is a good thing to do. Here you will need the help of your mentor who has a good database with all the material there. To conclude, a good research question provides the framework for a good study. A suitable study design should be chosen. The protocol should be sacrosanct. So do not be scared if your protocol changes when you're doing the study. Go back to the ethics committee and give your revised protocol. Do not try to manipulate any findings or results. Write as you find. So be like an observer and do the things, and do not imagine that, yes, I wanted this intervention to be better than that, but it hasn't come. So every study is a good study. Even if there was no difference between the groups, it's still a study. You have made your mark. Any shortcomings should be identified. Finally, a well-planned study is the crux of soundly conducted research. Thank you.
Thank you very much, Professor Shilpa, for this wonderful presentation. Research methodology itself is a big issue, chapter. People do it in various conferences on this issue, but you made us simple. If somebody from the house has a question, please.
Thank you, sir.
If there are no questions, we can call upon the second speaker.
So I invite the speaker, Dr. Professor Vishal Tandon. So we're going to thesis writing and protocol writing. Dr. Vishal Tandon.
Thank you very much, respected chairpersons. First of all, I would extend my thanks to the organizers for giving me this opportunity. I may be the odd man out here talking on a topic which is very close to my heart, that is thesis writing. So let us see why we want to talk on this topic. It is going to be like any university with which you are affiliated, or the organization with which you are affiliated, they have their specific guidelines. So we need to abide by them. The whole purpose of this topic is that 40 postgraduate, I learned that this institution recently have now in their basket. It's going to grow more also in the future. So uniform thesis writing should be adopted by any institution, number one, that is the reason. And there should be no reason of rejection if we abide by some rules which are prescribed by some authority. And obviously to get IEC and IRB is a very easy clearance. Now, what are the basic guidelines in journal? But I'm again going to say it's going to vary from university to university with which it is affiliated. The first most important thing is these are some important documentation. IEC clearance, board of study clearance is mandatory, and no change of thesis is accepted or guide is accepted until these three conditions are there. One is plan rejected by the board, work cannot be completed which is beyond the control of candidate, and when guide leaves the institution more than 6 months. So these are the only three conditions by large and majority of the universities where the modification in thesis and the guide is permissible. Now, the university guidelines, majority of them, they say that the font should be 12 and 14. Either you can use the new time Roman or Arial with reference as Index Medicus. That is very, very important. The co-guide is no entity as such. Guide has to be prescribed as per the guidelines. But co-guide can be any person from other department, from the same department. He can be a junior, he can be a senior, he can from other institution as well. So there is no as specific guideline as such. And now the new status, the statutes are that the first year only the thesis should be granted. Now what happens to the thesis actually? This is the outcome, what happened to the thesis. Either it is going to be approved. Approved will be if two examiners, they give a favorable report in the favor, and it can be returned for improvement, or third outcome is it can be rejected also if at least among the 4 examiners 2 reject the same. Now these are the necessary certification which are very, very important, I tell you, in the thesis. And majority of the time, many scholars, they make blunders and mistake. I tell you a very good example, glaring example from our own institute. Routine tendency is to go and ask the printer, cut, copy, paste the same certificate, and it can lead to blunder, I can tell you. So be very cautious about the list. HOD certifies the facility in the department, head of the institution certifies the facility in the institution. These certificates are very, very important. Acknowledgements and obviously informed consents in 3 particular languages which are applicable in the region. Now this is the, you see, checklist which constitute of writing of a thesis, very important. So we need to have this IEC certification. Then if the topic require a regulatory approval, then that also. And CTRI, now these days it is recommended that every topic, research topic or thesis topic should be registered with CTRI, though it is mandatory for regulatory trials, not for the academic trial, but still it is recommended. So this is the checklist, we will be talking about this. Now title of the research should be, you see this at the very conception you have to conceive. So I tell you it should be specific, concise, but at the same time informative. It should not be over-claiming anything, number 1. And then most important, grammatically correct. It can depict the study design or the animal species if it is from the animal side. And we should avoid the abbreviations. Most important, it should not be at all repetition of the aim and objective, which is a very common tendency, I tell you. And it should not even conclude the study, should not state the results. Now these are few examples. This is something right and something wrong. If you see, to evaluate the efficacy, when this study will be conceived, and when it will be published, the title is going to remain same, because IEC has given a permission in favor of that. So to evaluate, when you are going to go for a publication of this title research, it will still be a futuristic, you see, representation. So it's wrong. So grammatically it has to be correct. That is very, very important. Just a change of the words, topic remains same. And what is wrong here? Metformin increases the cancer specific survival. So it is concluding actually. So it should not conclude, any title should not conclude. It should not pose any question. Is fasting, so this is the incorrect title. So this is the correct title. Just should not pose a question. And should not overclaim also. Now first study. So you want to glamorize the research, right? But the, you see, editors are very smart. They catch hold of you that how much publication is available in this particular field. So this is also incorrect title writing. Now, you can use these all, you see, designs in your title, observational. These words can be used. These all are catchy words you can use in your, you see, title writing. That make it even interesting and catchy sometimes. Now this is IMARD, which we have to follow even in the thesis writing. Now in the introduction, the major, you see, basis of writing introduction is we never want, this is the section where you should not review the literature. But the tendency of the postgraduate is they review the literature, they write mechanism, chemical structure of the particular drug in picture. So that should not be done. This only should have few components. One, it should reflect the background of the study, number 1. What is the, you see, volume of the problem you are going to research for? that should reflect the epidemiology, mortality, morbidity, the complications related to that. All those issues should be reflected in that first component. Then very, very brief, without reviewing, tell us about what the literature for the Western population, what the literature from the Indian population suggests about this particular topic, but very briefly, within 2-3 lines. And then you should also reflect the gap area, and most important, what is the rationale of choosing this research question or this topic. That should be the bottom of that. And finally, what significance it carries and what clinical addition it is going to do. And it should end, this introduction should end with the purpose of the study, obviously. So this is the crux for writing the introduction, nothing beyond that. See, this is the most, highly impact factor journal, Nature, and see how sweet and the shortest example I could take of writing an introduction. This is a perfect example, I tell you. Now, these all are the problems. Don't do that in introduction. And reviewing the literature, the best practice is electronically review. Go with the keywords, and from wider to narrow, try to, specify what actually you want to write in the review of literature. So for that you need to retrieve. So wide to narrow is the approach in review of the literature. These are some search engines. On this side, they are the free search engines, except the PubMed will give you the only abstract, but rest all are the free search engines. So better is always to explore PubMed Central, but rather than PubMed. That will give you, going to give you access a full article which will help you to write the review. Now, writing the review, never cut, copy, paste, number one. Chronologically write the finding of the previous study. So it has to be year-wise in the thesis, which is unlike in the scientific paper actually. So chronologically you write, but it is not the scenario in case of you writing the introduction. So there you can go random writing of the references, but in the review of literature, it has to be chronologically, right? And most important, good practice is when you review all the literature relevant to your research, conclude at the end of the study. This is very, very important. So this is how we write conclude and write. And objective writing should be very, very specific, I tell you. And best practice is primary should be divided into primary and objective should be like that. Now, in the methodology section, if it is the interventional trial, obviously this is the checklist. You should build upon writing on these factors: study design, randomization, method of blinding, time and duration of the study, place, study of collaborating department, IRC clearance, the clinical trial registry number, informed consent, population detail, explain the protocol clearly, detail of the clinical and the biochemical screening should be indicated, inclusion, exclusion criteria, and then describe the allocation clearly. This is very, very important. And obviously the dose of selection, basis of the dose selection is important to reflect in methodology. The principle of risk minimization taken in the particular protocol is very, very important. Assessment for the outcome, primary and secondary, how will be these outcomes will be met. And obviously the consort diagram should be very, very important. Consolidatory flowchart of your study makes it very, very easy for the readers, for the evaluators as well. So GTRI I have already talked about, and this is result writing. Again, one basic principle in result writing is that never infer in result writing. This is the mistake which postgraduate they do. The result section only should enumerate the results, describe the results, significant finding, and even incidental finding should be reflected, but don't infer in this section. That is very, very important. Now coming to how you're going to use table, the figures, the diagram. Again, it is very, very important. It should have a heading, it should have a bottom line which should describe the statistical procedure clearly, and figures should be very, very clearly depicting the method of statistics used. So this is very, very important. This is the exact way a thesis should depict the table writing. And even in the figures, you should, point out the statistical numerical values which make it very, very easy for the reader to infer your results. That is very, very important. And this is, you should pinpoint findings you are trying to show, if it is a histopathology or any, you see, clinical picture. That is very, very important. Now, in discussion writing, the rule of thumb is very simple. Here, you can take the crux of your study, start building on that. First thing is to compare the result of your study with the previous studies. And now, the two things going to follow. One is that it is going to be in agreement with the study. The other thing is it is going to be contrary to the study. If it is contrary, then you need to depict and elaborate the possible reasons for the contradictions. If it is in agreement, you need not elaborate them. And then after doing so, the hypothesis, possible reasons, mechanisms, and inference of the results, all these things can be done in the discussion. And this is the section where even you can talk about the incidental, rare findings or unexpected findings. You can build upon that with them and create a hypothesis for a future research. This is very, very important. So this is about discussion, and discussion should not depict the repetition of result. For that is very, very important. Now coming to conclusion. The conclusion, again, blunders are done. People write so many things in conclusion, it has not to be done. Simple. The rule is to see and keep your objectives in front of you, right? And in preview of the results of your study, try to answer those objectives, primary as well as secondary. That is all about the conclusion. Nothing more is to be required. No, it has to be specific, no hypothesis. Finally, conclude the results from the major, you see, findings of the study as per the research question. Now, this is just an example. Now, this study was to compare the efficacy and safety of one drug and with other antidepressant drug, right, in combination with that. So, whether it is safe or whether it is effective, that is the only conclusion required, nothing more than that. And it should speak, your results should collaborate with your you see, conclusion, nothing more than that. Now, this is the most critical area, reference writing. I tell you, majority of the universities, they tell you to go with the reference writing, and this is the uniform reference writing for these theses. Now, this is how you should write. I have explained it. If you see, these are the 6 authors you need to depict, not less than 6. And usually somebody do one author and put et al, somebody they do 3 and then et al. The uniform requirement is 6 authors, and if it is more than 6, then you put et al after that. Then full stop, the title if you see has to be in the running title, first word has to be the cap, and then you put a full stop over there. The journal name has to be citable journal name, very, very important. You should not write Pediatric Surgery International. It has to be the citable journal, otherwise the research won't be cited. So year, then semicolon, this 25 is the volume, that means how many years this journal is in inception, and then the page number, that is the thing with which you end the routine reference writing, right? And this is, my dear friends, is the uniform free available check site where you can put, and it gives you, you see, 2 access. One, that whether the reference supporting for the statement is correct or not, and whether the reference written in a correct format or not. So that is the best practice, I tell you, we should adopt even by writing a scientific paper. Now, how you cite the reference in a book style. This is again very, very important and interesting. Again, majority of the things we students, they make mistake. But there are 2 situations. One, the whole book has been written by an editor, and other situation where the chapter has been written by an editor. So now you see, this is a condition where the topic has been written by a few authors. So same format of writing the author's surname first, then the title with the chapter name, and then in which the editor name is Gupta DK, editor, the textbook of neonatology surgery, first edition, New Delhi, modern publisher. So publisher name has to be there, year has to be there, and then the page number has to be reflected P, unlike the routine reference writing. So this is how you write the book reference, right? And the internet reference has to be this available when this was available from, and when you cited it, that time has to be, when you cited that, has to be reflected in the internet. This is going to be very, very common, I tell you. Now, this is, I tell you, these all are the other examples, but these are the most common. Now, this is how in the thesis component of the writing, whether you're writing an introduction or a review, this is how your references should look like. That comma, you can close the bracket. That is how you should, you see. Now, these all are the irritant. I close by one or more 2 slides. Plagiarism, you should check that. That is a good practice. Old references, you should avoid typographical mistake. You should correct them by peer reviewing, very, very important. References to be written in uniform style. Tables, figures not cited in the text. This is the biggest, you see, irritant. Wrong citations and results repeated in discussion, conclusions not in accordance to results. So how to improve? Simple. Peer review the thesis component after a gap of some time. You will going to find some mistake in your own work. Then the grammar check and the plagiarism check. The legal softwares are available as well as free softwares are available. They are going to help you to reform your scientific writing. That is, you see, these all are the guidelines, and this is the check reference site. So these all to be avoided when you convert this thesis into a publication. It is totally unethical on these grounds. This is not the preview of the today's talk. So, my dear friend, I say the scientific writing or the thesis writing is an art, right? You will learn when you grow in the field of research. So I say abide by the guidelines which are available to which the university to which you are affiliated. That is very, very important. And the idea is that you should not get rejected on just on this ground that you have not properly written the thesis. Thank you very much.
Thank you so much, Professor, for enlightening talk. I think in the interest of time, we'll take the questions after we finish the session. Thank you so much.
Thank you.
And we go on to invite the next speaker.
Good morning to all of you. Now I would like to invite our next speaker, Dr. Anup Kumar from SGIPGMS Lucknow. He will talk on the topic Biostatistical Concepts in Pediatric Surgery. Welcome, sir.
So, this is the talk on which I will going to speak, Biostatistical Concept in Pediatric Surgery. So, the first question, which usually wherever I go to discuss biostatistics with my clinician friend, I ask them, why do we need statistical calculation? What is the fundamental thing because of which a biostatistics department or you need a biostatistician? What is the answer which is coming to your mind? And the answer is very rightly written over there, variability. What is this term variability is that whenever you measure something for the research, you put a research question and for answering that research question, you measure an outcome variable. Okay, and that outcome variable is going to vary from patient to patient. To understand the pattern of variability in that outcome variable, we need statistical calculation, otherwise the use of this subject is not there. So, once you understand this variability, then the research or the biostatistics or statistical calculation, you are going to start understanding in a more deeper way. So, to think upon this, we have to understand that whenever we measure something, what are the sources from where the variability comes from? Let us take a very simple example. Most of the time, we measure the blood pressure of the patient. Okay, so when we measure the blood pressure of the patient, so obviously the values which we are going to note down, they are going to vary from patient to patient. So you have to understand that what are the sources, reasons because of which that variation is there. So one source which is there, that is the conditional factor of interest, It means that will be your research question. You know that a patient who is hypertensive, his blood pressure is on a higher load, but patient who is on a not hypertensive, his blood pressure will be on a lower load. So this is the variation is there because of the conditional factor of interest, you know. Second variation will be there into the blood pressure because of the measurement process. How you are going to measure the blood pressure of the patient. This is the thing which as a researcher you people have to keep in mind, that the measurement process is something which you should follow in a very strict or in a very defined protocol way. The way our previous speaker have said that everything should be well defined, that this is the way I am going to measure the blood pressure of the patient. It is not something that the patient is running to the OPD, just measure my blood pressure so that I have to go to the consultant to consult him. Okay, so you should follow, or everybody should follow, that how is going to measure that blood pressure. And third important aspect, that what are the materials you are going to use to measure that blood pressure, whether it is electronic or manual, that should be uniform in your study. You send the same blood sample to the different lab and you are going to get the different values. So that is what this experimental material is very much important. So whenever you are going to collect the data on the outcome variable, your objective is that you try to minimize the variation because of the point number 2 and 3, so that as a researcher you are able to focus on the basic research question, that is the conditional factor of interest. So once you understand that these are the sources of variation, so in statistics we define that there are 3 kinds of variation. Let me tell you this, statistics or biostatistics, variability is the mother of statistics. That is what I feel. If there is no variation, that's why I am so much focusing on this term variation. One is the planned systematic. So one is the planned systematic, for example, is 5-day treatment with injectable ampicillin plus gentamicin more effective than chloromamcillin. So this is what you have planned. Okay, this is something which you have planned, that the second is the chance or the random. You measure your own blood pressure 3 times and you are going to get 3 different values at the same time with the same instrument. So this variation is something which is usually we say in statistics that this variation is a chance or a random variation. And third, which is very much important, unplanned or systematic. So just you are going to measure the blood pressure of the patient, and there are various other factors because of which also the variation is there. It may be the age, it may be his BMI. So whenever you are doing the research, you should also take care of this unplanned. That's why the literature review is very much important, that you should know that these are the factors. One which is I am taking care in my research question, this is the factor which is going to affect the outcome variable. But there are various other factors also which are going to affect the outcome variable. So those are termed as confounders, or here I am writing it unplanned systematic. So you have to take care of all the things which are going to affect your outcome variable or the variation which is there. So with this introduction, let us move to what actually we do in biostatistics. That there is a population, and from that population we draw a random sample, and on the basis of this random sample we infer about the population. That is, in a nutshell, we do. Okay. So what that arrow is showing, that we are taking a random sample from the population. It simply says that you are going to collect some data from the population in terms of samples. So data is the only weapon, and the quality of data is very much important. That's why I told you that you have to take care of your data, because on the basis of this data only you are going to infer about the population. So now, what is data? You people might have heard in various research methodology courses, nominal, ordinal, interval, and ratio. I feel that it should not be like that. How we discuss data is that data is primarily, you should think data in 2 types. One which have got a unit, and another data which do not have got a unit. You measure something, if there is a unit associated with it, we term it is a metric variable. If you are not able to associate a unit with it, we term it as a non-metric variable or a categorical variable. For example, a patient who is coming to your OPD is just outside your room. What is the gender of the patient? You don't know. So what are the possible outcome? You say it may be male, female or transgender. You are not able to associate any unit with it. Okay? So it is a, you can say non-metric variable or a categorical variable. Now what is the height of the patient? So you are going to say that height, you are going to associate a unit with it. So it is a metric variable. So this is the first way how we divide the data, that it is whether it is a metric variable or non-metric variable. If it is a non-metric variable, or you can say categorical variable, whether you are able to arrange the categories in an ascending or descending order, it has some use.
Dr. Kumar, you have different tone. Just 2 minutes more. 2 minutes, last 2 minutes.
Okay. So category, if you are able to, so otherwise it is a metric variable, then we usually do statistical reasoning in 4 general approaches. One is the descriptive statistics, we describe the data, and another part is we draw the inference from the data. So this is, once we have the data, how we are going to put the descriptive in the terms of number and percentage, and if we have some, you can say the metric variable, for example, you can see the marker level and the unit is written over here, then we have the values in terms of median and ranges. Again, we can add the p-values if we have the groupings, so that we are able to understand whether there is a significant difference between these two groups or not. So another so since time is not there, so this is a very last concept which I would like to discuss with you people, that you see that there is sometime we use standard deviation with the mean. So mean, and in bracket the term standard deviation is written. It is the gestation age in weeks, 37.34 is the mean. In bracket the standard deviation is there. So as a researcher or as a reader of the research article, you should be able to understand, okay, the mean is 37.34 along with the data which is the sample, how much variability is there. So around 1.64, or you can say around 2 week variation is there, plus or minus, in the sample itself. But when you report, or when the research article report standard error with the mean, then what do you think of that? This is the earlier part was the descriptive statistics, or which describe your data in the sample. The later part, standard error, it means in your sample it is coming to be 37.34, but the standard error is 0.23. If the same study is being done by some another person, how much variation can be there into the estimate of the mean of the gestation age? So this standard error actually tell you that it is 0.23. So accordingly, the formula for confidence interval also creeps in. This is the, and that is how 36.88 and 37.7, and this is the confidence interval. It means 95% of the time, if the study is done for estimating the mean of the gestation age, the values are going to lie in this interval. So thank you.
Thank you so much, sir, for your wonderful talk. Now we will like to invite our next speaker.
I request all the people to kindly in the the people and the delegates, students, nursing officers who are sitting in the side, I request all of you to kindly sit in the center rows. I know the students have arrived and their designated place were there. I request all of you to come in the center rows, please. We'll have wonderful photographs then, please. Yes, hurriedly. Thank you.
Okay, let me next call upon next speaker, Dr. Prabodh Goyal from IMS Delhi, and he is going to tell us about the RIPSS guidelines from manuscript to submission. This is the very important topic, and most of us get these offers when you review our topic. So he's going to tell us how to review these, these research papers.
Respected chairpersons, seniors, and my dear colleagues, a very good morning to all of you and greetings from the All India Institute of Medical Sciences, New Delhi. At the outset, I want to congratulate the chairman, Professor Shilpa Sharma, the organizers, Professor Vijay Kundal, and everybody here for organizing such a wonderful academic feast. I also thank the organizers for giving me this opportunity to speak on this vital topic. I'm feeling fortunate today that while I'm speaking on this topic, my boss, Professor D.K. Gupta, whom I joined as an MCA student for the first time, the person who has shaped my life, and in fact, my first manuscript was mentored by him. So, greetings and respect to you, sir. So, Dr. Vivek Tandon has covered a large part of this. In fact, he has taken good care of the scientific part. So, he has let me free to talk on the art of crafting a manuscript. So, basically, when I wrote the first manuscript, the moment when I finished writing the conclusion, I thought it was ready for submission. But as time passed, as I grew senior, as I became more and more mature, I realized that the point from completion of manuscript to the point of submission is a long journey. So that is what is shown here. So it requires careful attention to detail and adherence to the prescribed guidelines. And mind it, there are no standard guidelines. So you have to adhere to the guidelines of the journal to which you are submitting. So this journey requires selecting a journal, then formatting your manuscript as per the guidelines of the journal, running the final quality checks, and of course submission. Now, how do you select a journal? So this is something we all know. We have to align the scope of our research with the focus of the journal. We are all concerned if the journal is indexed. We are concerned what is the impact factor of the journal. Of course, if the journal is published more frequently, there are more chances my paper would get accepted there. The processing time from submission to first acceptance or first response. Then it matters if it is an open access journal, I have to pay for it, or it's a subscription model. And the editor is concerned if my subject is aligning with their target audience. Once I have decided on the journal, I have to read the instruction for authors to see what all are the journal requirements. Has been discussed in detail already. Then most of the journals, in fact all of the journals would give you a list of the type of manuscript that they accept, and you have to figure out what is best for you. The nomenclature may be different, but largely it is case report, case series, original articles, review articles. Nowadays they have separated systematic reviews from review articles. How I understand is that each part of a manuscript is important and it functions together for a cohesive whole. So this is just like a human body. So a manuscript has many components and every part is playing its own role. Now, to make the topic simple and to focus mostly on the art of it, I thought let me discover an analogy for the manuscript, and the most interesting I found is a love story. So I compare the cover letter to the first move, the title and abstract to the miniskirt, introduction to the first date, and so on. So we'll discuss one by one. The research title first. A research title is like the headline of your dating profile. Your title must catch attention instantly. It should accurately represent what's inside your manuscript, avoid any clickbait, and be memorable enough to stand out amongst thousands of others. So like a good dating bio, it should neither be too mysterious, nor it should be too revealing. So essentially, your title is good when it's a direct approach with a clear intention of what you're going to present. It should engage curiosity, and it should provide a comprehensive overview of the full story. These points have been discussed. The title should be specific and informative. It should reflect the scope and focus of the study. The choice of keywords should be thoughtful. Essentially, you have to imagine if somebody is going to search and you want this manuscript to reflect, what search terms would that person be using? It should be concise and avoid terms which are incomprehensible to the target audience. Titles could be three types. This is interesting. It could be descriptive titles like role of waterproofing layers in Hypospadias, a simple standard line. Or you can frame a question out of it. Is a waterproofing layer effective in reducing urethral-cutaneous fistula formation after Hypospadias repair? Or you can split it into two parts separated by a column. So waterproofing layers and Hypospadias repair. A reduction in the rate of UCF formation. So it's up to you to decide which works best for your manuscript. You should avoid ambiguity and adhere to the journal guidelines. I just summarized the do's and don'ts of it. We have already discussed them in detail. Coming to the next part, which is the abstract of the manuscript. So a good abstract is like a mini skirt. It should be long enough to cover the essentials and short enough to maintain interest. So a good abstract gives you a structured background or context, followed by your objectives, methodology, the key findings, and conclusion. So this is what you have to look for while you're writing your abstract. I'll share this PPT in the group so all of you can have these points with you. After the abstract, coming to the introduction. Now introduction is key to framing your research, engaging your readers, and setting the stage for the rest of your paper. So a good introduction is like a good first date. So to start with a captivating opening, provide interesting background without overwhelming details, clearly state your intentions, and end with a promise of what's next to come. So giving a background is the opening, which you say that you have to take a global context, like you start with a broad thing, then you go to the background, state your intent in the form of study objectives or hypothesis, and then the promise in the form of what is expected next. So essentially the introduction should provide a research context before the objectives. These are the four things we are covering in the introduction part. Then the methods. So now method section is again very important because it should be detailed, transparent, and logically organized. Essentially, with your methods, the study should be reproducible. So a method section is like planning the perfect romantic evening. Every detail must be carefully orchestrated, one thing. The sequence matters, so you have to put down things in the right sequence, leaving nothing to chance, and yet describe with elegance rather than awkward explicitness. So you describe the settings, for example, population chosen, selection criteria, study location, followed by the sequence, how the procedures was done, the timing, and finally your evaluation techniques, the statistical part. The most important line in this slide is the last one, which says that you have to give sufficient details for replication. So this summarizes the entire things about the method section. Coming to the results. The result section is like revealing your dating success story to your friends when you come back. So you have to present the facts without exaggeration. Let the data speak for itself. You can highlight the significant moments, but save the deeper interpretation for the discussion. And like you share photographs with your friends, here you have to share the tables and figures which tell the story about the manuscript. So the result section, you have the characters, the highlights, the evidence, and the details. Essentially, when you write the result section, you start with the demographics, then you talk about the primary outcomes, and then the secondary outcomes. This is a summary of this most important lines in the last box: no interpretation of your results in this section, no discussion, and don't try to conclude. I've just given a sample of the results. Here, read out. Baseline characteristics of the study population are summarized in table 1. Median age, gender ratio. The intervention group showed a significant improvement in quality of life scores compared to the control group, giving the statistics. No significant difference was observed in secondary outcomes. And adverse events were encountered in 15% of the participants in the intervention group. A very small summary of the result section. It is important because a well-written section on discussion will lay the foundation for your discussion section. Now, what is discussion about? Now, the discussion is like reflecting on a relationship. Analyze what worked, why did it work, compare with your past experiences, acknowledge the limitations, discuss the future possibilities, and conclude the key lessons that you've learned. It's like a relationship counselor. You need to interpret the signals, explore the deeper meanings, and provide valuable insights. Finally, the conclusion, which is like the end of a perfect date, just summarizing the best moments, not every moment, just summarizing the best moments, reinforce why this connection matters, hint at the future possibilities, but know when to end gracefully without dragging on. You need to leave a lasting impression without overstaying its welcome. So this is about the conclusion or the perfect farewell. Best moments, why it matters, future promise, and graceful exit. Okay, I'll focus on the technical requirements of the manuscript. The first thing, which is very important, always check the journal specific guidelines before submission. You have to focus on 3 aspects. Number 1 is formatting of the manuscript, formatting of the references, and the format and number of figures and tables. Then you have to dwell on the ethical considerations. 2 aspects are important. First is authorship. I know there is a gray area in the authorship criteria. It varies from researcher to researcher, research team to other team, and institution to institution. But whatever is good in your setup, give it a due thought and do what is justified. Secondly, your study should be cleared by your research ethics committee. Lastly, the cover letter. So although this is submitted first, but we generally write it the last, which introduces your work to the editor. A cover letter is like making a first move in dating. You need to show genuine interest, highlight your best qualities without bragging, demonstrate why you are a perfect match, and make them want to know more. Like a thoughtful first message, it should be personal, should be specific, and strike the right tone. A well-crafted cover letter makes a good first impression and helps your manuscript to stand out to the editor. Here, the most important part is that try to finish your cover letter in 1 page. Then last thing in this presentation today, you need to have an author information checklist. So before you start your submission, you need to gather some information about your colleague authors, like their full name, affiliation, email, mobile number, and maybe their Oration IDs and so on. So that again can be journal specific. There are a lot of resources and supports in the market these days, lot of software tools, AI tools, professional services available, and you have to decide what is optimal in your setup. And with this, I conclude by the message: write, revise, and then submit, so that you publish and prosper. Thank you very much.
Yeah, thank you so much. I think again we are short of time, so we can take the questions later on. So I would like to invite the next speaker, Professor Dr. Saurabh Kumar Gupta. He's going to talk on publication ethics.
distinguished dignitaries of the field from India and even outside India. So, good morning, respected chairpersons, distinguished dignitaries, esteemed faculties, respected delegates, and my dear students. In case, if it's okay, sir, I can present it. You have.
Thank you, sir. I request Ankush. Is he there? Please come. Then leave that. Ankush, when I'll say to change the slide. So greetings from AIMS Jammu and Jammu as well, as I just came to know that many people have come to Jammu for the first time. So you are welcome at AIMS Jammu, and Jammu, enjoy your visit. This is what I have learned in my life. Every journey starts with a step, single step, and every achievement starts with a dream. And the dream turns into reality if you have a clear vision and a roadmap. Next slide, please. Despite putting your best efforts, trying with all your heart, sometimes things don't work out, and there is no clear reason why. But that's life. Maybe I ask you, who is you? Come back to this. Where is next slide? पीछे वापस मैं बोलूँगा. Next slide, please. So what matters when you fail? It is about holding values, high morals, and the right attitude that will keep you moving forward in the right direction to achieve the path of success. Next slide. All this makes ethics. Ethics is basically, when we're talking about publication ethics is basically are the guidelines or the standards which are set not only for the author but for the reviewer, for the editor, and even for the publication houses, so that whatever submission they are doing, whatever articles they are publishing, that should be trustworthy, contain integrity, transparent, and should be accountable. Next, please. Yeah, previous one. Yeah. So when it coming to research publications or publication ethics, we are having 6 things to take care of. First thing is, there should not be any breach of confidentiality. There should be honesty, like there should not be any data falsification or fabrication. It should be data integrity. Then we are having the authorship criteria that needs to be very clear. As Sir said in the last lecture, we should avoid plagiarism, and there has to be transparency when you are submitting your manuscript. And the last is the conflict of interest that needs to be met. Next slide. So what I tried to do is, I have tried simulating these ethics with the real life situations so that no one has to mug it up and they can correlate it with what the life they are living. Next slide, please. Now when it comes to ethics, so we are assuming that you have lived, you have done your thesis or you have done your research with a commitment, with all the religious intentions. So I have tried comparing it with a relation. It is very difficult to stay committed in a relation. What happens when two people meet for the first time? They always put their brighter side up. So when it starts on terms of excitement, optimism, and trust. But as the time passes, this trust erodes, and the hidden flaws begin to emerge. And the lesson is clear many a times. In case if your commitment or your relationship or your research work is not having honesty, transparency, or integrity, even the most promising starts can lead to broken ends. On the same text, if a researcher has started its study with so much of passion for
countries. It is not only in India, data has been fabricated and it has been falsified also across the globe. And now this data, because of your reputation, gets published in journals like Lancet. कहाँ है? निकाल दे. That leads to not only harm to the patient, but people lose interest in science. They lose the trust in science. Second publication ethics is we are believing that the manuscript you are submitting and the data it is having is honest enough. You have maintained the integrity of the data with no creation of data that you have not studied and you have created it, and with no manipulation of data to get the favorable results. And for that, you need to preserve your data at least for 5 years, either in the physical form or in the electronic form. Next slide. Authorship criteria. Next slide. I want to imagine the organizing secretary of this prestigious conference starts distributing attendance and paper presentation certificates to his friends, even though these individuals neither attended the conference nor presented any work. These certificates are then added to their profiles, boosting their academic and professional record without any actual efforts or participation. Would such behavior be celebrated as his generosity? Or would it instead raise serious ethical concerns? Next. The answer is this practically will harm the integrity of the academic community, undermining the credibility of the conference and the value of its certification. Next. This I am talking about the gift authorship, host authorship, and the guest authorship. Next. Similarly, when it comes to authorship, it basically confers not only the credit but also the responsibility. So you have to declare what job that author has done. That if you have placed someone's name, you have to describe the job as per the International Council of Medical Journals, editors of medical journals. Then it has to be the author you have given name. Either should be involved in significant contribution in doing the research or manuscript development, or gave the final approval for the version to be published, or accepts responsibility for the work's accuracy and integrity. Next slide. Plagiarism. Imagine visiting a friend's house with your child. During the visit, your child comes across a toy that they really like. Your child refuses to let it go, insisting they want to take it home. Now, as a parent, what would you do? Would you let your child take the toy home without the owner's permission? Or would you gently explain to your child that the toy belongs to someone else and must be returned? Next slide. The ethical answer is you return the toy because it rightfully belongs to the other child. Taking it without permission would not only be disrespectful but also a form of theft or kidnapping. Next. So this is what is plagiarism. When we are using previously published work or ideas without proper consent, credit or acknowledgement, this is considered theft and it is unethical. Now you can have types of plagiarism that can be direct, that is copy paste or even paraphrasing. Then can be self-plagiarism, in which you just republish your own work again and again, and then it can be dependent on Islamic publication, like you have done a thesis and then later on you are publishing it in 3 to 4 volumes. Next. So how to avoid it? To avoid it, it is better when you avoid copy paste. You write it in your own words by spending more time and understanding it thoroughly. You acknowledge the original resource, cite references accurately, avoid redundant publications, and use anti-plagiarism softwares, that is Drillbit, Authenticate, Turnitin. Next. Ethics related to submission or the transparency. Think of an experience when you call a mason or a plumber for a small job. They might start with a small task, but immediately when with a budget of some 2,000 rupees, and finally you landed up to giving them 10,000 rupees, and that too the project was of 2 to 3 days, and it took almost 2 to 3 weeks. This happens very, very routinely.
You have to wrap up, Dr. Saurabh. The time is up.
So this is ethics way to submission, simultaneous submission. You are presenting your work at two different places at one time. You are duplicating your publication. You are just citing your own studies every time, and then creating errors. Next. So this is the last conflict of interest. Next. Imagine a selection committee is appointing a faculty for a reputed institution. Unknown to others, one of the candidates appearing for the interview is the chairperson's close relative. The chairperson doesn't disclose the relationship and proceeds with the task. What do you think? Will assessment be fair or will it raise doubts? And to ensure impartiality, such individuals with potential conflicts of interest should be excluded. Next. The undisclosed relationship creates suspicion about bias and favoritism. It compromises with the credibility of the process and undermines the trust of other students and faculty. Same goes with the research. In case if the research is being funded by someone, you should mention it when you are submitting your manuscript that the research was funded by this agency. Next. So this can be financial, personal or social interest that may directly or indirectly influence the author's conduct. Next. This was a story which I was writing, but I think we are leaving less time. Two friends going from Jammu to Srinagar, they were enjoying. Suddenly a red light comes. The one who was driving has stopped the car. The other one asked, there is no one. Why have you stopped the car? Next slide, please. He said, look, the two kids, they are watching us. He said, so what happens? Kids, they don't know about the red light. Then he said, yes, that's exactly why it is important to stop. Kids don't just listen to what we say, they mimic what they see. If I break this red light now, I might as well tell them it's okay to ignore rules when no one is around. Next. So the lesson is integrity is not about following rules when someone is watching. It is about doing the right thing even when no one is. And the last thing is, don't believe that the rules are about avoiding punishment, but they are to make or shape the world around us a better one. Next. So every action, no matter how small, has the power to inspire or mislead. So let's always choose to inspire. Integrity is doing the right thing when even no one is watching. Next. One thing at the end I would like to say is, we all are here not to stay forever, but we are trying to create something that will stay. In the next slide you will see, next. None of you know about how many publications these people have made. One has given the polio vaccine, the other MRI, the one man-to-man transplant, heart transplant, and the one has given this DNA and mRNA viruses. So people know about your contribution that is going to last forever. No one knows about their publications. Please, for such a small thing, don't be unethical. Next. So this is a quick revision. Next. All my respect to all the elders and the teachers sitting over here, and all my best wishes of love, luck and happiness to all my friends sitting at the back. Everyone wants to do big things in life, but the most important thing is, if we do the small things extraordinarily well, it will look like an achievement. Open for questions.
Any one or two questions from the audiences?
Yes, Dr. Please.
Good morning everyone, I'm Dr. Raksha, consultant in SCPA. My question is to Shilpa ma'am. It's regarding the frame to second mic. So I wanted to ask ma'am, when we are framing the research question for PG thesis, the question which is in our mind, should it be given to the PG, or the question which is the acquisitiveness of the PG's mind should be given as the thesis?
Very good question. It depends on your thesis student. You ask him explore. They always have ideas and time to think about a topic which interests them. I'll give you an example. When I did my So I'll give you an example. When I started my MS in 1996, my thesis, I asked a question on the rounds, like the common bile duct was dilated even post cholecystectomy. And then that kept my the professors thinking. She's asking us a question, why not we ask her to answer it? And that became my thesis topic. That time there was no internet, so I went to the library, took down so many articles. I went to the cadaver to see what is the actual size of the CBD, because nobody had actually measured it in human beings. Everything was just ultrasound or something. So after that, the size can go up to 10 mm. So all these things are important. It depends on the candidate. It's always good to make them think and come up with a question. But if some people are slow, it's taking months, 4 months, 5 months, 6 months, you can give them idea. At least the topic of interest should be of their choice, hepatobiliary or thoracic or whatever. So that they also feel involved. Then only the passion will develop.
Dr. Shilpa, I think NMC guidelines, when I joined as MC, Dr. Bhatnagar told me, now you are matured enough. Now you must have seen, you take few months to see the patients around and then choose your topic. Ultimately, he gave me the topic. But nowadays, NMC guidelines are that when the session starts, before the students join, you have to already fix the, because you are as a faculty, you know what are the, different type of cases you are getting. So you have to actually, plan your this thesis topic. So by the time the child, student joins, next day he must have topic.
So when you're planning, you can always keep a choice of 5, 6 topics.
Yeah,
and then tell them if you're interested in this topic.
It is not like they're wasting 6 months in selecting the topic. Now the things are changing already. Thank you.
Students are quite smart. I have got many MBBS students all over the country who I'm mentoring. So they're doing all those research from their ideas. There are many now who don't want to take up clinical work. They want to do only PhD, MBBS,
May not be true
PhD.
every student, may not be true, but then these are the guidelines.
Yeah, so it all depends on the work, and you have to give them time for the thesis. So always, I'll request the head of departments, keep some time slots for thesis for the candidate. At least few hours in the week should be there, 2 hours thesis time, so that they don't neglect on the clinical work and go to do thesis work, or they don't get tensed up in the end.
The things that previously we used to take, our own time in submitting assignments. NMC by this time.
Deadline is there, but it's not followed. People don't give them time. If some candidate asks in the OPD, I want to go and do my thesis, obviously the faculty gets annoyed because the patients are sitting there. So there should be somebody else in his place.
I think
all these can be
the rules are going to be tougher. We have to follow all those things. Thank you very much.
Thank you.
Another question? Then we can close the session. Thank you very much.
So the first session of our conference was full of enthusiasm and valuable knowledge. I thank all the brilliant speakers for this enlightening and exhilarating session. And our humble thanks for our esteemed chairpersons to preside over this session. So we would want you to felicitate our speakers for this session. I would like to call upon our speakers, Professor Dr. Shilpa Sharma, like to call upon Dr. Vishal Tandon, sir. I would like to call upon Dr. Anup Kumar, sir. Dr. Prabodh Goel, sir. A big round of applause for Dr. Saurabh Gupta, sir. Now I'd request Dr. Shilpa Sharma, ma'am, to please honor our chairpersons for this session. Thank you everyone for your patient hearing. It's time for Amita Sen RIPSS Oration 2024. So I'd like to call upon the stage our chairpersons for this oration, Dr. Professor Nisar Ahmed Bhatt sir, Professor in Head Pediatric Surgery SKIMS, Dr. Professor Sumitra Kumar Vishwas sir, President IPS, and I would like to invite Dr. Shilpa Sharma, Chairperson RIPSS, Professor, Department of Pediatric Surgery, AIMS Delhi, to introduce our guest speaker for this oration.
May I request Dr. Har Prakash Miglani to kindly come up on stage when I start the introduction. As chairman of the RIPSS, in presence of the President of the Indian Association of Pediatric Surgeons, Professor S.K. Biswas, and President J&K Chapter of IAPS, Professor Nisar A. Bhatt, Director AIMS, Professor Shakti Gupta, Founder President RIPSS, Professor D.K. Gupta, it is a kind privilege to introduce the orator for the Amita Sen RIPSS Oration 2024. Dr. Har Prakash Miglani is a consultant pediatric surgeon at Miglani Hospital, Amritsar, Punjab. He is a very popular pediatric surgeon and holds the position of the President-elect of IAPS 2024-25. He acquired his MCH pediatric surgery degree from the prestigious PGI-MER Chandigarh way back in 1996. He also obtained the prestigious Doctorate of National Board. He held an academic position for 15 years at Sri Guru Ram Das Institute of Medical Sciences and then started his own hospital in 2025. That did not stop him. Despite being busy with pediatric private practice, he has been regularly attending all the international conferences, IPSCON, and presenting good papers and posters with good discussions. That's how I have known him since last 20 years. He has been honored with the Karl Stotz Visiting Professor Fellowship and the Ethicon Travel Fellowship of the IAPS. He has contributed to various presentations and publications. Of late, he has been very active in sharing his clinical skills and scientific observations on hypospadias repair with pediatric surgeons, which have benefited the juniors the most, on which topic he will be delivering the oration today. May I request President IAPS and President JNK chapter to join us to honor Professor Miglani. And may I please request the audience to kindly keep clapping throughout the honor. May I request Professor Miglani to kindly deliver the oration.
Thank you very much. At the outset, I am overwhelmed by the love, affection, and honor that RIPSS has bestowed upon me in inviting me for this prestigious oration, which we are holding for in the memory of one of our own colleagues who left us abruptly some time ago, and in front of so many dignitaries of the dais and on the dais, I feel that I work in a very small self-owned nursing home in Amritsar, and talking in front of dignitaries who work in big institutes is already giving me some goosebumps. And please bear with me if I speak something that may be a little bit controversial or could be not suiting somebody's practice, but I only speak my own mind. I am not a big avid fan of literature, especially in hypospadias. Before I go on to the topic, few words of introduction in whose memory we are sitting here and I am delivering this oration. Dr. Amita Sen was a very popular pediatric surgeon in Delhi, born in a Bengali family in August 1959 and educated from Delhi. Most of her education is from Lady Hardinge Medical College or RML Hospital, Delhi, and then she trained for MCH under legendary Professor Mridula Rohtgi from AIIMS, Delhi, and she was a lady full of life, wanted to enjoy life, and her tryst with education doesn't end with MCH. In 2008, while working in RML Hospital, she went for her PhD in Conservation and Preservation of Heritage, that's archaeology, from Guru Gobind Singh Indraprastha University, Delhi. After MCH, Dr. Amita Sen again worked in AIIMS for some time and then joined RML Hospital as pediatric surgeon in the Department of General Surgery. And practically she was the only faculty from 1995 till 2008. A dedicated, punctual, upright and smiling personality. She strived hard to have an independent department of pediatric surgery, and meanwhile, being in general surgery, inspired hundreds of young general surgeons in the making, and many of them were inspired to join pediatric surgery later on. And she also conducted several teaching and training activities, and which also included the third RIPSS conference as well in 2011. Her vibrant, lively and loving persona and astute professional leadership qualities made her a loving and respectable figure amongst colleagues and students alike. In 2009, her efforts bore fruit, and a department of pediatric surgery was born in Dr. RML Hospital, Delhi, and when other teaching faculties also joined her to establish the department. And she was heading the department from 2009 to 2021, and the department also started MCH somewhere in 2019, I think. Her presence at all academic events was gracious and exuded with love, warmth for all her colleagues and everyone around her. And she actually had a very magnetic personality, and everybody would feel attracted towards her because of her warmth. Apart from pediatric surgery, her students have imbibed human qualities like dedication, truthfulness, honesty, seriousness in performing duties, uprightness, and she led by example and as a true role model. She was a true professional, yet she was jovial and always smiling. And she also had a very nice family life, and with the points which I have not put in this slide. She was very well loved by her niece and nephews, although both her husband and herself were single children of their parents and did not have any issues of their own. She suddenly left us on 14 September 2023, did not give much time for resuscitation or something, and everybody was in disbelief and shock when she left. In her memory, her husband, Dr. Surajit Sen, and research and innovative chapter of pediatric surgery have started this oration from 2023, and last year Professor Minu Bajpai, a towering personality from AIMS, another towering personality, had delivered this oration chaired by Professor Meera Luthra, who is a close friend of Dr. Amita Sen. And I am feeling a little, after this Professor Minu Bajpai, I am being chosen for this oration. So I am feeling those, difference in the levels. So kindly bear with me. Coming to the topic which I hold very dear to my heart and I am passionate about, Hypospadias penile skin landmarks repair for better cosmetic and functional outcomes. Now, before I go on with the topic, the details of the slides and everything, there are certain things which I want to clarify. Cosmesis, beauty lies in the eyes of the beholder, and beauty is never skin deep only. So unless the function is good, the beauty is short-lived. So is cosmesis. So when we talk of cosmesis in a penis, so we are talking about not only the look of the penis should look like normal, and the functionally also it should be able to perform its duties as the nature has designed it for. So this is one of the slides which is not my own slide. One of my co-authors who is writing this paper has given this slide to me where art meets science, but it's purely science. If you can call it work of art, because the end result might resemble what the Almighty ought to have made. Now, during the journey of this development of this type of repair, I found that we have reduced the complications which are normally associated with a TIP repair to quite a large extent. Now, tip repair, as you know, this whole work is about modification of a TIP repair. And in my own setup, I have been, working on this improving my own results only over the years. This is not the 1 year or 2 years of experience, it's about 15, 20 years of experience that I have been, learning to do this repair in a better and better way, improving upon my own mistakes that I have been made in previous cases, and then analyzing and then thinking over it that how should I improve over it in the next case. And by as time passed and more cases I did, I realized a technique that I could almost reconstruct the prepuce to the normal extent and cover the penis with adequate tissues so that there are no fistulas or there are no meatal stenosis. And all this has been developed by watching the videos of Professor Snodgrass, who is the pioneer of tip technique. And in 1994, somewhere he published his first paper, and that was when the workshop at Agra had happened, and Professor Sopa had invited all the big surgeons, including Duckett. And we were pushed from PGI by Professor S.K. Mitra that you must go and see that because Duckett is coming, and he knew Duckett personally. And that was the beginning of understanding of hypospadias that started when I was a resident in PGI. So we have analyzed a couple of patients done lately, few patients, and there were 2 additional cases which were redo cases which had been done elsewhere, but then they had come to us with some complications. And we have a follow-up of reasonable time, 1 month to 4 years. Another thing that struck me was the changing standards of care in hypospadias. Depending upon the regions in the world, or I would go further, depending upon the religions of the world, the normal appearance of a penis is variable. Most of the people who belong to the Mohammedan section, the circumcised look is an acceptable standard. Until a few years back, even the repairs were not so well developed. A few decades back, I would say, even a subcoronal meatus was an acceptable standard. But nowadays, as we are evolving in the care of hypospadias, people are demanding more like a natural looking penis with complete prepuce. Now, these standards are determined by the surgeons. What we have to offer, what we have in our armamentarium, that we can tell the patient that, okay, you can get a look like this. Unless we do that, patients will have to, swallow whatever they are offered. They don't have a choice actually, they are at the receiving end. In the lately held one conference in Abu Dhabi, where Professor Shilpa was also with me there, one of the prominent surgeons from Great Ormond Street raised a pertinent question. Does minimal hypospadias require surgery? I mean, that question is very valid from one point of view, that this hypospadia surgery is not a simple surgery. It requires a lot of lot of care, and then the results are suboptimal. This is notorious for complications. So is it advisable that we do surgery in minimal hypospadias when the patient is not really having a backward bend of the stream or not having really a cording? We will address this question as we go on in the talk. It will be automatically addressed, and you will also be able to answer this question. And distal hypospadias, is it a simple case or a masquerader? The chairman, Professor Subhitra Biswas, our president IAPS, raised this question, rather suggested this name masquerader, because he also has experience with this type of hypospadias cases. And we are writing on this also, and maybe in the journals after some time. Now this is what was available earlier. A circumcised look is comfortable and acceptable to most of the people, and still it is the accepted standard around the world. Now distal hypospadias with prepuceplasty. This is the emerging standard that people, at least in our part of the country, even in Jammu and even in Punjab, Haryana, North India mostly, they want that we want a complete look. If it's possible, please do that. unless we educate the patients, they may not be able to ask this pointed question or make this pertinent request that we want an intact prepuce. But this is what is being practiced in our part of the country, and many people are now aware that such repairs are available and can be done comfortably and with minimal of complications, if at all. So this is a typical example of distal hypospadias. You can see so this is a typical distal hypospadias case. If somebody says it doesn't need any required because of the complication or the pain or the hospitalization or the cost involved, and it doesn't require any surgery, then I think patients are not fools that they are approaching the doctor for something that they find abnormal in their child, and they have a right to adequate treatment. It's a different question that we are able to answer to address this problem or not because of our own limitations or competence or availability of facilities. Now, whenever a patient comes to you, most of us are deeply involved in hypospadias, surgery, and many of people I know around here are doing this surgery day in and day out. And we generally take all the four views, dorsal, ventral, lateral, and then the glans tilt also is visible in most of the patients. Nothing special about it. What I have found mostly is that there are many landmarks on the ventral side as well as on the dorsal side. On the ventral side, there is the median raphe and the median frenulum at the glans, which is prominent, whereas the dorsal prepuce lines, nobody has looked at them seriously, so I don't find any reference in the literature so far that these dorsal lines, what are these called or what are these for. But while tinkering with the, some innovations I was doing at my own level in the hospital in the last many years, not only my hospital, in other places also, when I was in institute also, since then I have been, trying to decipher what these lines are for and how can they be helpful. So today we'll be answering that question most of the times. So these are also valuable landmarks on the dorsal side of the penis also. And as another patient which had very prominent dorsal landmarks of penile skin, you can see these lines, very prominent landmarks. So what are these for? We will see in the next couple of slides. Now these are the ventral landmarks. Now if I mark them during surgery, they are kind of weird. They go either deviated to one side or deviated to the other side, and sometimes they have a different orientation, and we can classify them easily into deviated or into the median landmarks, and then they bifurcate also at various levels on the ventral side. They are all natural. I have not done anything extra. I have just only marked with the marking pencil over them. And these are the ventral landmarks which are a guide to follow. I base my incisions on these lines only. They are natural lines. I don't make any abnormal incision over the prepuce and will try to do the surgery through these natural lines only. And when I am marking these, I am in my mind planning a reconstruction where Mother Nature went wrong, why it went wrong. During formation, tubularization of the penile urethra, something happened, some connection snapped, and things just fell down to wherever they were during the embryogenesis and the formation of the penis. And somehow the skin reached distally, but the other tissues remained behind, and these landmarks are somewhat a marker of what lies underneath. That is what the experience shows till now. So while we are degloving the penis ventrally, and one thing more the distal penile hypospadias, very few patients have got a proper chordae. Most of them are straight penises, they don't have chordae. But if even a chordae is present, that chordae means a ventral band of penis, it is because of the skin adherence to abnormal locations. And if a normal embryogenesis of the penis would have happened, it would have gone to, it would not have formed a chordae. So incisions just follow the natural tracings and then declave the penis very carefully in the right planes without much bleeding, and then you will find that the flaps which are towards the meatus, once you remove that, you just unfold that flap, it comes back and probably attains a position where it would have been had the hypospadias not formed. So you can see in this, the flaps I have marked with the arrows, with the yellow arrow. The flap which was going across onto the right, to the left side of the penis has come back and is come somewhere near the middle of the penile shaft. And then there is the distal part which is marked for the tip incision, which is popularized by Snodgrass. I am sure every one of you knows about it, but we will go a little further than what is already written there and the way I do it myself. Now, hypospadias is a surgery of repetition. Almost every case has the same steps, have to have the same results, and can be replicated in everybody's hands. I call it ABCD. Like we learn the alphabets and keep on repeating and then learn it, memorize it. So is hypospadia surgery. You will learn it. If you keep on repeating the steps in your mind and in your patients meticulously, everybody can, do this surgery. This is not a difficult surgery. Yeah, it is difficult to learn, but once you master those steps, then it's a repetition over and over. And in this talk also, we'll have some repetitions for which you will bear with me. And then the urethroplasty and spongioplasty. You can see I am starting the urethroplasty from near the tip and coming back till up to which level the urethra is not tubularized, so I am tubularizing it. And then over it, we are reconstructing the glands as propagated by Snodgrass. I am just following this part of the operation as taught by Professor Warren Snodgrass and Nicole Bush. And I have seen them operating in Agra and in other places also a couple of times over their shoulders and seeing what exactly are they doing and how they are doing, and I am just following that. There is nothing new innovation in this part of the technique at least. So I acknowledge their contribution to the development of the science of hypospadias. So the next part comes the development of ventral frenulum. If your incisions are in the correct lines according to the natural creases, the ventral frenulum, the flaps will just fall into place without tension, and you can just approximate in the midline and a ventral frenulum will be formed for reconstruction. And then the ventral frenulum is lifted upwards, and underneath that ventral frenulum, after 2 layers of urethroplasty, doing after tip incision, I'll come back to that again in a couple of slides next. We approximate the dartos. Now dartos is another very important layer of the penis. It surrounds the entire thing. It's just under the skin. It has got a reasonable flexibility. It allows the penile skin to move over the penile shaft, because penile shaft is made of corpus cavernosum and corpus spongiosum, which are relatively stiff tissues which give the stiffness to the organ, and over that the skin has to move depending upon the stage of erection and depending upon what function is being done. You have to pull back the prepuce during peeing also, and even of course during sexual activity the prepuce is pulled back. So this dartos has that mobility, and it has to be all around, which is not there in cases of hypospadias. The ventrally all the tissues are missing because the urethra has failed to tubularize. So this dartosplasty is again of utmost importance and gives you that flexibility of the prepuce. Now once that dartosplasty, the ventral frenulum carries on and comes back to the ventral side from inside outside, then you can just simply suture the midline suture. Those sutures carry on till the midline, till the bottom of the penis, and we have a very nice, simple median raphe, which goes up to the tip of the prepuce and then forms as a frenulum inside and then goes on to the glans. This is how natural penis looks like, and I'm sure all of you have looked at that carefully. Now, again coming to the repetition, incision, ventral degloving, look at the divergent corpus spongiosum. Most of the hypospadic patients have got two pillars of corpus spongiosum going on either side, and there's a thin hypoplastic urethra underlying, which is often not addressed by surgeons, and most of the surgeons land up in complications because they are not aware of this fact and they ignore this. And I feel this operation is notorious because of this reason only, that we don't follow those technical steps which are desirable, and we just try to do a minimalistic operation for something which is actually not minimalistic, and that is why sir had coined the term masquerader. The distal penile hypospadias is often a masquerader rather than just a distal penile hypospadias. Now, this is again one of those cases where hardly any urethroplasty is required, but a glandsplasty has been done so that ventrally also the urethra is supported on the distal aspect by the glands and proximal aspect by the divergent corpus spongiosum. And this is the final outcome. Now, when I was marking the dorsal flaps, the dorsal landmarks on the prepuce, this is the reason why those dorsal marks are there. If you see this picture, you will see those dorsal landmarks converging ventrally in the midline, and that is when I know, okay, this is how it should have been had hypospadias not formed. So these are our tracings, the nature's tracing that God has given, that we have to recognize, and when we are reconstructing, if our repair is correct and without tension, these landmarks will converge onto the midline, and that is called that is what makes it more cosmetic. So natural landmarks do give us an indication what lies underneath, and when we deglove, like in this case also you can see how I have degloved, just the thin skin is there, a flap which was going towards the right side of the penis up to the meatus and beyond comes back to lie in the middle of the phallus. So this has to be reconstructed like that. Then I see what the mind knows. If you know that there is a hypoplastic urethra lurking underneath and you are going to address that adequately by splitting it ventrally or doing a TVIP of adequate length and then tubularizing without tension over the feeding tube. The feeding tube is not the standard for approximation. Feeding tube is just a drainage catheter. It may be 6 French, maybe 8 French. The actual urethra after TIP is much larger than that, and the feeding tube should be able to glide freely in and out of the bladder without any resistance. And the suturing should be without tension. Wherever there is tension, there is going to be a fistula, take it from me. So sometimes the length of the hypoplastic urethra is quite long, and unless you address that, you will never have a proper result. There are people who say there is a functional obstruction after TIP repair. Could be, if you are not addressing the urethra, probably that is the reason that that is not expanding properly, because it's not ventrally supported, it's not like a natural urethra, and there could be a functional obstruction. But at least in our cases, if we are doing it back to the normal level from where the normal urethra starts and reconstruct the entire urethra from there onwards, these functional obstructions are not seen in our practice. And we have to do the TIP as deep as possible, right up to the level of the depth of the body of the corpus spongiosum, and only then your TIP will be successful. And then again, repetition, urethroplasty and dartosplasty, 2 layers of urethroplasty. First is a continuous layer starting from the meatus, 2 to 3 millimeter of the distal urethra is left, and then tubularized right up to from where the hypospadias is there, hypospadic meatus is there, and then another layer over it with interrupted sutures, and then dartosplasty over it as the third waterproofing layer, which earlier one of my speakers had already pointed that should there be a waterproofing, is it adequate? Dartos is a very, very robust tissue, and it is fully seals the repair and does not allow fistula to form. But the only condition is there should be no tension in the repair at all. and then the glandsplasty and similar frenuloplasty follows, because the flaps, once mobilized adequately, they come back to lie where they ought to lie, and the dorsal landmarks, they are approximated ventrally, which gives us the reassurance that we have done the correction in the right planes. And this is the final appearance, fully covered prepuce, fully covered glands with the prepuce, and it can be retracted back and then again pulled back to give us a cosmetic looking, normal looking, nearly normal looking penis after complete reconstruction. Now, is the distal hypospadia simple? I don't think by any standards we should call this repair a simple repair, because once you deglove and you realize that the distal tip is not actually a distal one, so it doesn't matter. The classification of calling it a distal or a mid-penile becomes redundant once you know that a distal is not actually distal, and no repair of hypospadias is a simple repair that I can do a little bit of repair at the tip of the penis and come out with it and expect a good result. Patient is going to come back or go to some other surgeon for abnormal results, and then somebody has to do a redo provided he knows that. So if all of us know how to do a primary repair, the chances of a redo are much less. So never judge a book by its cover, always deglove first adequately. Adequate exposure for any surgery. We have been taught by our teachers, Professor D.K. Gupta is here, Professor Shamitra Viswas is here, so many other senior teachers. They always teach us adequate exposure for any surgery that matter. Unless you have adequate exposure, either by laparoscopy or by open surgery, you will never do a proper job. So you should start the repair where the defect is there, from where the defect starts. Build a foundation, and then over that you can raise a tall building. You can never raise a tall building just in the air from the tip only. So it's not necessarily a minor case, and extent of hypoplastic urethra has to be addressed. Like in this case, it could be a cause of meatal stenosis or a stricture and failure, but if tipped adequately, the problems seem to be rare, if at all. That is in our hands. I will share with you the problems also that we have encountered during our journey of learning this hypospadias repair. And we are still learning actually. Still many modifications will come in coming times, and we are all learning the hypospadias repair. Nobody has said the last word about hypospadias till date. So again the same things, glandsplasty, frenuloplasty, dartosplasty. And you can see if this dartosplasty is there, I don't think there's any chance of any fistula formation. And if it is there, then definitely it's a technical failure rather than anything to blame with the tissue or the patient. It's a technical failure, take it from me. And then the prepuceplasty, giving it a near normal look. Now coming to another part, technical aspect, the narrow urethral plate. Now many people classify this patient is not suitable for TIP, this patient is suitable for TIP. If there is a urethral plate distally visible, then probably we can get away with a TIP. I have in my own practice till date never measured the width of the urethral plate that is present distally. It is visible. I mean, I have never bothered to put a scale that it's 3 mm, 5 mm, 8 mm or 10 mm. If a visible urethral plate is there, I have been able to do a TIP, and that too successfully. And I am not sure if some people say that some patients are not suitable for TIP. Maybe their experience could be different from mine, and I am not an authority to say that no, this is the way it should be done. I can only suggest. It's up to you or to them to follow or not to follow. No issues with that. And again, adequate exposure and point-to-point closure. Now this is a repair of finis. You have to be very meticulous in your suturing, and point to point. You have to see the points which are landmarks on both the sides of the degloved penis, and then approximate those points in the midline, starting from the urethra, then to the glands, and then to the dartos, and then to the skin, the prepuce. So that is what we'll give. Now sometimes we get a surprise that, especially in this case, I thought there is no cordy, but once I did the Gitti's test, artificial erection test during surgery, I found, oh my God, this patient has got more than 30 degrees bend. So now what to do? I have already done the urethroplasty and the glandsplasty. So, but then I devised a way that, okay, if I have not done it at the right time, I forgot. And these are the reasons why we get complications. So, but this is There is a plane that you can easily develop while degloving. You don't have to dismantle the furlet's collar from the top, because otherwise you will not be able to replace it back. So retain it there and go around in the middle part from where you can correct the cardi, reach the dorsum part, retract the prepuce away with the help of a retractor or a feeding tube which I put there, and do a Heineck Maculix type of reconstruction in the midline or on both sides, depending upon what you are conversant with. You can do any of those stitches on the dorsal side and then have a completely erect straight penis as is desirable after hypospadias repair. So after this we could see the penis has straightened completely, just like a missile ready to be launched. And if we understand the natural landmarks, we can always do a better job. So even the last bit of prepuce we don't waste, because many people have seen that they are very chop of the prepuce. Even Snodgrass chops off a lot of prepuce which he thinks is redundant or is not suitable for repair. But we find that even the last bit of prepuce is there for a purpose, and we try to retain every bit unless it's actually redundant and it is not required for a tensionless closure of the prepuce. Only then we little bit resect it. Otherwise, even this, you can see the flap here, it has come nicely. There's just 2 or 3 sutures on the side, and there's a midline rafe that has been formed. And then another innovation that we have had is this dressing. As many repairs are there, almost the same number of dressings are also published in the literature, one dressing claiming to be better over the other. And this dressing is the Amritsar dressing. I don't mind calling it the Amritsar because this is purely a cross-specialty innovation that I have used in Hypospadias. It is not described yet in the journals or the books. It will come shortly in our own journal. This is a polyolefin dressing, which is a mesh dressing, and you just have to wrap around the penis, very simple to do, and then occlude it with the cotton pads and absorptive pads and put it in Dynaplast so that it's a compressive, occlusive dressing which remains dry. And dry field is always conducive to healing. It prevents infections, and it's just like a diaper in a newborn. When you wear a diaper, the child doesn't get wet even when he pees. So even if some exudate comes out, these pores in this dressing, they allow it to be absorbed by the absorptive pads around. And this dressing gives you wonderful results by preventing the edema. It's a compressive dressing, does hemostasis and prevents infection also, and allows wonderful healing. This is how it looks when you open the dressing after a few days, and almost a nicely healed suture line, completely dry, edema-free appearance, and that's what a surgeon loves. Now coming to redo cases, is it possible to reconstruct the prepuce and redo? Some cases, yes. If the surgeon has not destroyed the prepuce entirely, the first surgeon, it is very much possible, and we have done that successfully in 2 cases where we had to do a redo because the patient had been operated elsewhere but was not satisfied and came to us. And we found that the previous surgeon, again trying to have a minimalistic approach, has addressed the meatus a little bit but has forgotten to address the entire penis. So we did the degloving and we found that there is a hypoplastic urethra also, and there is a divergent corpus spongiosum also. So since the meatus was at the tip, we just preferred to restore the corpus spongiosum back over the urethra in the midline and then refashion the prepuce. We conducted a Gitti's test. It was quite well, straight penis. But look at the repair that has gone to correct the divergent corpus. It has gone almost up to the proximal penile region. So this was a distal penile repaired by somebody else, but inside story is that the corpus spongiosum had not even been touched, and so we got a virgin field there and we could do. And then you can see the dartos flaps, so healthy dartos flaps that we could easily approximate in the midline, and then we could give it this waterproofing layer with the dartos again, and then the complete prepuce has been reconstructed. And look at the suture line. What was a distal repair has come back to the penoscrotal junction almost. So there is a mid-penile patient with the deviated surface landmarks. You can see where the median raphe goes, and then it turns midway, and you have to plan the incisions accordingly so that you can do approximation in the midline. Again, the repetition standard steps. You can see the flap from the left side, it has come back to right side where it should have been had the normal embryogenesis taken place. Then glandsplasty, frenuloplasty, prepuceplasty, same steps. And you can see the tip of the prepuce is going towards one side, because one side it's more, the other side it's less, and I am not sacrificing any prepuce because I have to reconstruct it. And then once those landmarks are met, I am sure I have done good repair, because these two landmarks tell me that okay, we should be meeting here, this is the meeting point. They are not one there and one there, otherwise it will cause some torsion or something. So this is what the dorsal landmarks of the prepuce are for, and probably it gives you a better cosmetic appearance, and then the same dressing gives you a better healing. Another deviated natural landmarks case, they are telling what is to be expected underneath. The earlier the landmarks start deviating, the more complicated that case becomes, and you have to do adequate exposure in all the cases, so irrespective of where it starts. But if you use the natural landmarks for incisions, you at least end up without any unnatural incisions or unnatural scars over the penis. So then distal hypospadias becomes proximal, and degloved prepuce falls back to its original place where it should have been. And this is the final result after the complete repair. Unless fully reconstructed, you may not do justice to the patient in hypospadias. And ventral markings and incisions and dartos flaps again in some other cases, which I am showing just for interest. And then how to raise the glans flaps, glans wings, just over the body of the corpus spongiosum, over the buccal fascia, and it goes into the glans, and then you can make an incision and raise the glans wings. And then the tip incision is again marked in the midline. Such a wide plate happens, and we generally, I have never put a graft into it. Many people put an artificial graft, it's a very raw area. I don't think it scars that much that it will cause a metal stenosis later on if done properly. And all those things I feel are superfluous, because I have never had the need to do in my hands. And even Snodgrass, who is the proponent of this repair, has never done a snod graft. It's not his repair actually. Somebody has put a graft over it and called it snod graft. That's not his. So again, urethroplasty in 2 layers, and glandsplasty, and glandsplasty and frenuloplasty, and then frenuloplasty, and you have to have, during the repair you have to check that this frenulum doesn't give way at the time of actual function, and it is strong enough to withstand all challenges in the coming life. And this is the final appearance after polyolefin and mesh dressing afterwards. After the final appearance, you do the mesh dressing. And another video, you can see the prepuce after completion of the repair. The prepuce should be fully retractable over the glands, comfortable, loose enough that it is not a phimosis later on. And this is actually, for a hypospadic patient at least, this is a dream come true. Most of the people who are normal, they never realize that this is a blessing that you have received from Mother Nature. It keeps the sensitivity of the glands intact. It covers the glands properly. It doesn't allow it to cornify like in circumcised penises. And the sensation and the pleasure that it's supposed to give to the patient is kept intact. Now I would be missing some things or lying if I tell you that we don't have any complications or problems. Yes, we do have. Now we do a post-operative calibration in almost all our patients after 1 month of the completion of the repair, 1 to 1.5 months. We call the patient back, give him some ketamine into the OT and put a metallic sound, and if it's one size more than the normal for his age, we consider this as a success. And we have not had any metal stenosis, believe you me, in the last many years. I have not seen metal stenosis maybe for the last 10 years. And because of this, probably we avoid all those things, and we are reassured of ourselves, and the patient is also reassured that my repair is standing fine. And then there is a concern about the hypertrophic scar in the prepuce. This we are having in some patients. All patients don't heal like that, but some patients do get a contracture in the prepuce. And we, in the next picture, you will see, you can see that there's a big size metal sound in the urethra. Urethra is all right, no problem, but the skin over that looks like a crumpled up skin. And we then give some, antifibrotic creams. So far, I have not had the opportunity to do a Z-plasty or required anything that patient has come back with a real problem. But yes, this is a concern that we are having and we are noticing. And in all those patients, we are keeping a close follow-up. Now, we had some postoperative complications, a prepuce fistula in 3 cases. Sometimes the prepuce becomes a bit avascular at times, but now we know how to avoid that also. And so we are careful during incisions and during dissection that we don't devascularize the prepuce carefully. We don't devascularize the prepuce enough that it leads us to prepuce fistula or any healing problems. So we had 3 patients, out of which 2 have been repaired successfully, and 1 patient remains, which is still done recently only, which will repair after 6 months. So then another dreaded complication, most dreaded complication in the last couple of years. I have not seen a fistula in my practice for the last many years, but this was one which happened earlier, just 2-3 years ago. So actually, just to go into the story of this case, this patient happened to be a relative of a Patwari, and the Patwari was troubling me with some land registration, and he came with this patient, and this patient had a fistula. So we have repaired this fistula also successfully. So complications I call as lessons learned, because these are all in my hands. So these are the lessons that I have learned the hard way and taken those complications on the chin. And metastenosis I have not seen more than 10 years since our practice, and none in this series. And 3 prepuce fistulas, 1 urethropedialis fistula, prepuce scarring and hypertrophic suture line, seen in a few. We are using the Contractupex or the Hexilac Ultra Gels and coconut oil also. And some may require Z-plasty, but so far none has come back to that asking for it. And phimosis in some patients, yes, prepuce does become a bit tight because patients don't generally retract it himself, and we don't encourage that also, lest the prepuce may give way. So we don't mind, like a normal phimosis patient in pediatric practice, where we don't advocate forcible retraction or forcible dilatation of the prepuce. Similarly, in post-repair cases, we don't advise any forcible retraction, and they are not having any urinary complaints as such, and meatus is easily visible in all the cases, and no patient has approached us yet for a circumcision or a prepuce plasty, redo prepuce plasty. So we have not seen any strictures in the urethra so far, probably because we do a very wide tip even when the urethral plate is small. Even if fibrosis has to happen, it will epithelize before the complete fibrosis or before it strictures. So once it is epithelialized, it will have a limitation where it will stop, and that is enough for for the child to have a normal, near normal like urethra. And we don't have urodynamic studies in our place, and our patients are not complaining either. If at all patient complains, I have always the institutions where I can refer, but so far I have not referred a single patient of hypospadias for urodynamic studies because no complaints are forthcoming from the patients. And long-term results are being awaited. Now long-term means post 4 year, 5 year, or maybe many of my patients have got married also, and many are abroad also, which are very much aware about their genitals and their results, and they keep communicating with me. Many patients come to me, sir, should we marry this boy? You had operated so many years ago. So most of them are doing fine in their married life also. So I don't know what is the long term or how long it takes complications to happen in hypospadias. There are reports that it can happen even after 15 years. So we are just waiting. We are not bothered if it happens after 1 year, 2 years, 5 years. So we will take them when they come. So to conclude, prepuce is a great piece of tissue that moderates the urinary stream and directs it near your feet or inside the toilet seat. And in uncircumcised penises, with due apologies to those who have, probably the stream is a little sharp, and it has to be directed manually to where it should be. And our patients don't sprinkle everywhere in the bathroom. And hypospadias penile skin landmarks, the HPS landmarks, that resonates with my name also. It's HPS Miglani, but it's hypospadias penile skin landmarks. They are valuable tools in complete reconstruction of the penis. And tubularized incised plate urethroplasty is not a bad operation, believe you me. Let's just learn it right. That is like ABCD. ABCD here means anybody can do. You just have to repeat it over and over and learn it right. And we looked at the literature also. If somebody else is doing the work which we are doing in our small nursing home in Amritsar, yes, we did find a couple of papers who are doing similar work, if not exactly the same. They are not using the dorsal landmarks anyways, but they are looking at the glands very nicely, and I've got good pictures in the papers which I have gone through, and topographic labeling of glands, penis and corpus sponging. Both the papers are from Egypt, from Tanta University. And recently in Abu Dhabi, in Tunisia, I met one of those residents of one of these authors who presented this paper there. And this GFC technique they have described, it's almost similar to what we are doing in Amritsar. So, thank you very much. Follow the natural curves and creases to achieve your goal. A normal looking, easily retracting prepuce is essential for a complete penis. Thank you very much for the patience listening.
The house is open for questions. Any questions, anybody? Okay. Yes, sir.
The chairpersons can make remarks.
Sir, it was so enlightening and everybody was so engrossed in it. So I thought somebody must be thinking, let me capture sir and ask some questions. Sir.
Thank you very much, everyone.
So everybody had a wonderful enlightening session since morning. We're in the afternoon and the tea is being served for your refreshing mood. We're starting our next session. Now I would like to request our chairpersons for the session, please. Professor Dr. Sumitra Kumar Biswas, sir, request you to kindly come on the stage, please, sir. Professor Dr. Abdul Rashid, sir. Professor Dr. Narendra Singh, sir. Request all of you to kindly come on the stage, please, sir. As chairpersons, please. The speakers for the sessions are Professor Dr. Dhruv Ghosh, Professor Dr. Archana Puri, Professor Dr. Shilpa Sharma. I request all of you to kindly be ready, please, with the presentations. Thank you. I request our AV team to kindly check the mics of the chairpersons, please, before we start the session. Check. Due to some reasons, Professor Abdul sir is not able to join us. We shall start the session, sir. I hope the AV team has checked the mics. Can we start the session, AV team? Sir, please check it.
Hello.
Okay, thank you. Sir, just a kind request to the chairpersons. So there is a small technical issue that whenever you speak, sir, if the mic is close by, sir, it will give the tone of that thing. Request you to kindly keep the mobiles at the side, sir. I'm so sorry for the inconvenience, but this is an issue. Thank you so much, sir. Over to the chairpersons. Thank you, sir.
So we will start with the session, and the first speaker is Dr. Dhruv Ghosh, and he will be speaking on delivering and affecting research collaboration. Please.
Good morning, ladies and gentlemen, honorable dignitaries and chairpersons. I bring you greetings from CMC Ludhiana. And thank you, Dr. Shilpa, for having me here, Dr. Vijay Kundal, and I think Dr. Vijay Upadhyay, who is here somewhere. Thanks a lot for having me, and it's an absolute honor. We've had a very nice first session where everybody was talking about girlfriends and relationships and romantic liaisons. My session is more of group love rather than individual romances. I will be talking to you about multicentric research and something that we do. And again, this talk is sort of directed to smaller institutions like mine rather than big hospitals across our country. That's just me. Thank you. We talk about delivering an effective research collaboration. A lot of my research work has been in global surgery and global surgical research across what we call the global south now, or low and middle income countries according to the WHO. Research is always a demand and supply thing. It is a demand for better quality of work that drives research. Unfortunately, in many parts of the world, the demand is there, the supply is not there, and that is what something people in India and many of the other countries are now trying to address. And India is sort of leading this forefront, and it's not now just located only in big institutions in our country, but also towards smaller institutions, because there's a huge appetite for research across our country, and especially amongst surgeons, especially amongst pediatric surgeons. The Lancet Commission on Global Surgery, which came out in 2015, basically told us that 5 billion people lack adequate resources and adequate access to surgery. Now that was 2015. Since then we've had a pandemic, so you can imagine the number of people who have not got access to adequate and proper surgery. 5 billion people, like I said, there has been a massive growth in surgical infrastructure. There's rapid growth in surgical practitioners, but a lot of those surgical practitioners have sort of moved to the Western countries or the global north. And again, we're left in a similar situation where we have the patients, but we don't have the people who will treat them. In terms of increasing our resources, there's always a risk of overstretching them, which lowers standards of care and increase patient harm. Patient safety was never a huge concern in our countries for a long time, and it's only the recent past that countries like ours have started putting a lot of effort into good patient safety. There needs to be quality assurance in surgical care. Surgical teams are teams, it's not just surgeons, and most surgeons feel that they can do everything, which is not really true. It needs surgical teams. You need the anesthetists, and more importantly, you need your surgical nurses to work with you. And we need to engage the surgical community. I'm 50 years old, I've lost all of my hair. I am not the future. The future is sitting behind there, and those are the people who need to be engaged for us to give proper surgical care, and creating for future surgical leaders, and reaching out to our communities where it really matters. Post-operative complications is the third highest killer around the world after heart disease and stroke. So you can imagine what needs to be done to improve surgical care. Our ward is our lab. We learn our questions from there. We try to answer questions from there, but the community is also our lab. And if smaller hospitals across our country give us a lot of answers, which unfortunately for a long time we have refused to listen to. And so global surgery research is what we are doing now, and in global surgery research, a lot of things are new. Not everything anymore, but a lot of things are new. And that's where we come into multicentric or collaborative research. Collaborative research can be within your communities, within your country, within your states, but also between countries. And especially Global South countries need to come together to work together in research. The advantages being you can have attractive methodologies. We were listening to Dr. Shilpa's lecture, I think, about different types of trials that we do. While we used ourselves to do sort of randomized control trials, multicentric and multinational trials now work on cluster trials where they deliver results faster, platform trials where they test more than one intervention at the same time, again delivering results fast. So there's no point in doing a trial and giving the results after 10 years. The world has moved on, diseases have moved on. You can generalize your studies, you can have team diversity, you can build teams, you can make collaborative decisions. There will be a structured implementation across countries which improves healthcare across countries. And there's better external validity, less personal bias. What I think is not important, what the world thinks is. And there we land up with large sample sizes, with less data manipulation, and detect all sorts of variations across the world. Building a collaborative means building a team. When we started back in Ludhiana, we started in 2018-19 with about 5 people. I asked different surgeons, would you join me? Nobody was really interested. They were thinking I was talking out of my hat. The guy is mad. But over time, when you start building teams, people start getting interested. Those are the 3 people down there who sort of worked with me right from the beginning. And over the years, we have built teams. We started with us. We started with 5 hospitals across the country. And today we work with more than 100 hospitals in our collaborative research in India. The NIHR unit on global surgery from the unit of Birmingham, the India hub is in Ludhiana. And it is the largest and the most effective hub across the world now. And that has been due to the effort of all people working in different hospitals, large, big, medical schools, small hospitals, rural hospitals across India. So choosing a team is very important. Independent decision making, allowing people to make decisions is very important. We have a horizontal structure. There is no boss. Everybody is allowed to make decisions. Everybody is allowed to have opinions, including the junior most research associate. And you start with small steps. You do good administrative planning. Communication is the key. You talk to everybody. There should not be any barriers between senior and junior people when you talk about communication. And that's how it is in surgery as well. And you choose a motivated team. Very important to understand rules. When we started, we did not understand rules. We made big mess ups. The Indian Council of Medical Research has been very, very kind to us, and they listened to us, and they allowed us to correct ourselves. And so it's very important when you're starting on research, especially for our younger colleagues here, when you're starting on research, to understand national rules. Very important to understand your funders' obligations as well. Due diligence, data protection, very important. Your patient, their safety, their privacy is extremely, extremely important. Most important, financial administration. Do not get caught in financial administration. Make sure your finances are strong, structured, so that you do not run foul with the authorities in the country. And it's always a team. Again, when I started in surgery and in pediatric surgery, I thought I was the most important person. The surgeon is the most important person. No. It is a team that matters. The more people you involve, the better results you get, the better outcomes you get. And across India now, we have teams from different specialties working towards improving access in care, improving quality of care, improving results in surgical care. And those are not necessarily surgeons. When I started, I missed a trick. I did not involve our nurses. Over the years, I realized I can't do anything without my nurses being part of the team. And so they are a very, very important part of our teams. Oh, thank you very much. I don't know the nurses are here. In total, in our model, we have now sort of recruited over 200,000 patients across 100 countries. And with this research, we have tried to change lives. Our research is based on low-cost interventions, not very hi-fi stuff, not very expensive stuff, because health economics is very important when we work. Our research has health economics driven into it. Without health economics, we do not start our studies. Our first study was Falcon, which was comparing medicated versus non-medicated sutures in betadine prep versus chlorhexidine prep for 5,788 patients over a year and a half, was recruited across the world. The corporates did not like us because we said that there is no difference between medicated sutures and non-medicated sutures when it comes to contaminated and dirty surgery in terms of surgical site infections. And then we started gathering pace. We started with our cluster trial, which recruited more than 13,000 patients, which we published in the Lancet. And then we have a whole bouquet of trials. And this has been the effort of a lot of young people across this country, a lot of people in smaller hospitals. Some of them are sitting here who have been part of our studies, both cohort and trials. And I'm very grateful to them for what they have done. Our research now covers a lot of things which are relevant in global surgery, which includes surgical technology, sustainable and green surgery research. We are now going into the trial called Dragon, which is going to compare disposables versus non-disposables and see whether sustainability can be done in countries like that. Ours, I'm sure it can be. We need to prove it. Safe and timely surgery. Early surgery is a good option. Late surgery is a bad option. Early surgery saves more lives than vaccinations can save. So keep that in your mind. Wound infection, perioperative care, cancer, and we work with communities. Again, with research, it is important to have sustainability. Sustainability is equivalent to employability. Today, we have a data center in a couple of our centers where we train people as data managers, research associates. So if you want to start a trial here in Jammu, you don't need to train them again. You can get people who are trained data managers. What we found when we started, getting good data managers is a struggle and can be a challenge. We have made an education center. These resources in research, for especially surgical research, are now free to access for anybody, and you get a certification after that, and you could then use these resources to develop your research. Advocacy, very important. Again, we lost a few years because we were not good advocates. It's very important to do advocacy because your research should not stay inside papers in PubMed or PubMed Central, but should come back to the community. It's the community which should benefit from your research. If the research is only for my CV, then that research is completely useless. Communities are very important. We started a program called the Community and Engagement Initiative, where we work with communities to find out from them what are their research questions, what is important to them, rather than what is important to me or my team. It is all about the community at the end. And then we go back to the community with our results and train them in what we can do. We are training now ASHA workers in Punjab, in the Ludhiana district, to take care of surgical site wounds, and so that those patients don't have to come back to the hospital, so that decreases costs to patients and loss of work. We are now training our medical students and our surgical trainees, but especially medical students, to try especially minimal access surgery. Our surgical workforce has to come from our medical students. When I started surgery, it was the top specialty. Everybody wanted to do surgery. Today, nobody wants to do surgery. Pediatric surgery, I don't even have to talk about it anymore. So we're trying to get them there at the beginning, innovate them. We are building in gaming technology. Now we are building in gaming technology through our Welcome Leap project into simulation training, so that these guys and these girls are going to be the future surgeons, and I hope some of them will get interested and do some of the work that all of us have been doing over the years. Nurses, extremely important, like I said. We have a surgical nurses research network. If anybody is interested, please contact me. It's a very, very vibrant and strong network across the world now who are doing their own innovative and independent research. Evolution is always about listening to voices. All of us do a lot of quantitative research. Not many of us go into qualitative research. Listening to the voices behind the numbers is extremely important. And that's where we are working on. We're developing qualitative research, both in surgery as well as in pediatric surgery. And hopefully this is something that will drive our research in the future. Evolution is always to encourage the future. I work with the University of Birmingham and the University of Edinburgh. I work with Stanford University. They are not important. What is important is what we built here in India. And so now that we've learned from them, we now develop our own research. These are 3 projects which are coming up in 2025. Elephant, for some reason, all our projects are named after animals, which is looking at the barriers we face in using the WHO's safety checklist. I know there's a talk about this later. In India, about 25% Full compliance to the surgical safety checklist, very poor. And that is what we are trying to look. And there are barriers, there are practical barriers to this. And that's what we are going to look at with our researchers here in India. Our nurses have developed a trial called Phoenix, which is looking at perioperative handover. Many of us in our many institutes don't go after the patient to hand over to the recovery room or to the ICU. We stay in our theaters, so there is a big communication gap. We're trying to improve that. And the clean cut, the modified clean cut trial, which we are working with Lifebox to improve practices within the operating room to decrease SSIs. Like I said, the Lancet Commission said over 5 billion people lack access to surgery. The answer is good research which is transmitted into practice and implementation and advocacy. Advocacy from our part of the world to the WHO. There are a lot of people who sit in the WHO and talk a lot of stuff. They have no idea what goes on in our countries. It is for us to decide what is to be done for our countries, and our voices have to be strong in the WHO. I was at Geneva, the World Health Assembly last year, and I'm sure, I can tell you, they have no idea what's happening in India. I love this slide. When I started in research, and I come from a 750-bedded hospital. I'm not like the All India Institute in Delhi or in CMC Vellore. I come from a small hospital. When I started in my research journey, I wrote a lot of grant proposals. For almost 15 years, every proposal was rejected, till we got the first proposal, and since then we have moved on. We are a small institute. We work with small institutes. We also work with big institutes. Shilpa has been a great collaborator with us from AIMS Delhi. But you know, you can start small, but you never know what you can do. The Voyager aircraft was not supposed to last for so long. It's still giving us information and signals. So I would encourage everybody here to start their own thing. We are here to help you from global surgery in India for anything that you want to do. You never know where you will get to. I did not know I will get this far in research, and I was not trained for research. So thank you very much for listening on to me. Thanks a lot for having me here. Thank you.
Thank you, Dr. Ghosh. Because of the shortage of time, we will take the questions later on. The next speaker is Dr. And she will be speaking on decoding small gut dysmotility in intestinal atresia. Please.
Good afternoon, everyone. What I am going to present is a classical example of a bench-side research to bedside. So we as clinicians often do clinical research. So we face a problem, we try to find solutions in the basic science, and then try to apply that knowledge in subsequent management of our future patients. So as they are trying to figure out the presentation, for the benefit of these students, we all know that gut motility is a very integral part of the function of the intestine. Digestion, absorption, secretion, everything will work optimally only if the gut motility is normal. So today what I am going to present is decoding of gut dysmotility in intestinal atresias. There is no conflict of interest. Anyone who has managed a child of a small bowel atresia has faced this problem at one or the other time, that patients post-operatively sometimes don't regain their gut motility. And delayed resumption of gut motility in intestinal atresia poses a formidable therapeutic challenge to the treating physician, as we are not able to feed the baby. Numerous hypotheses have been proposed, many explanations have been given in the literature. But pathogenesis of post-operative tear, over the years, this is the type of research which has been done. These are the papers that have been published in literature, where we can see that not only the nature, but even the extent and the spectrum of histological abnormalities has varied widely. Just to give you an example, there is a paper which says that the ganglion cells are hypoplastic in patients of a small bowel atresia, while there are other papers which have enumerated that ganglion cells are less. So there is a wide spectrum of variation in the reported findings, which to our knowledge, we felt that this was the lacuna in literature and there was a gap in knowledge. So that formed the reason for looking into this again. Research is nothing, but research is looking again and again into the problem if you have not found the solution. So we decided to study the histology of resected specimens of babies with jejunal-ileal atresia, and we tried to correlate it with the post-operative resumption of gut motility. So biopsies were taken from the resected specimens. We took biopsies at both ends of the atresia. Then we also took the biopsy at the site where we did the anastomosis, and we took serial sections of biopsy in proximal dilated segment if we were resecting it. And we evaluated our specimens by light microscopy, and we also did immunohistochemistry staining for the three components that I had enumerated. For muscles, we did alpha SMA. For enteric nervous system, we decided to look into the nerve filament protein and calritin for ganglion cells. And for interstitial cells of Cajal, we did CD117 staining. This is a specimen of one of our patients, where we can see the various sections where we have taken the biopsies as depicted by the white arrows. And we did a CD117 count. And how we did the count, each section where the maximum numbers of cells were present, we counted it under 10 high power field, and the number of sections examined were divided by the number of areas that you have looked into. And we tried, since it was a clinical research, we tried to correlate the CD117 count with the time taken to achieve full enteral nutrition. Full enteral nutrition was defined as when the baby was able to take 100 ml per kg of feed orally without any IV supplementation and fluids. So what were the findings? On light microscopy, we were surprised to see that nearly 84% of our patients, that is 27 of the 32 patients, had a normal histology, normal muscles, normal mucosa and normal submucosa. Only in a very small minuscule of patients, which were around 3 in number, where we noted that actually muscle thinning was present instead of the muscle hypertrophy that we normally expect in a child of obstruction. And in hindsight, we realized that these were the babies with complex atresias, where a vascular event had occurred probably as a etiological agent, and the muscles have thinned out. Decreased number of ganglion cells and nerve fibers were also noted in a very small minuscule of patients, that is around 3%. But to our surprise, on immunohistochemistry, all the immunoreactivities that we have studied for muscle, for enteric nervous system, and calritin was found to be normal. At this point, I would like to highlight a paper by Tander et al., which was published way back in 2010. And there the authors had studied the specimens of a child who was operated without bowel atresia, like when we resect a specimen, say for NEC, where we, at the site of anastomosis, we sometimes freshen the edges. Those edges were taken to get the normal control value of CD117. And they noted that the values of CD117 in a normal neonate would average between 2 to 5. Now, see this slide, where we enumerated the mean CD117 count at various levels of atresia, at proximal end, at distal cut end, 5 centimeters proximal, 10 centimeters proximal, and at the site of anastomosis. And we can see that the CD117 count was absolutely normal, within the normal limits at all the ends. This is a more detailed description of the CD117, the spectrum that we noted in our patients. These are the pictures we can see. Now, for the benefit of the students, we need to understand that interstitial cells of Cajal, they mimic very closely the mast cells. Mast cells look like interstitial cells of Cajal, and pathologists can sometimes get confused between the two. The way to differentiate would be to do a toluene blue staining as has been done in the first patient, and the interstitial cells of Cajal would not take tolerin blue while mast cells will do. So this is a specimen from one of our patients. Can I have a highlighter? It's not working. So in the second slide, we can see that this is a slide of one of our patients where the ICC immunoreactivity is positive around 2 to 4 cells per high power field. These are the slides of some other patients where you can see in the extreme corner, you can see a very strong immunopositivity for ICC and to the tune of more than 10 ICC per high power field. We also tried to correlate the ICC count, as was one of the objectives of our research, with the time taken to achieve full enteral nutrition. And we had plotted the values of CD117 on the ROC curve to get the critical value that can predict the attainment of enteral nutrition. And we noted again here, the patients who were having less than 6 per high power field ICC and those who were having more than 6 didn't have any difference in the time period in which they achieved FEN. FEN was achieved in 19 patients, and if you see the patients who are having more than 6 per high power field ICC, 12 out of the 19 patients achieved the enteral nutrition while 9 patients didn't. So there was no statistical difference as regards ICC count with the attainment of full enteral nutrition. This is just about the ROC curve. So what do we learn from this study? The present study dispels the observation of major histological abnormalities in intestinal atresia as has been reported earlier. Majority had no morphological changes in the enteric muscles and enteric nervous system. And we could not find any gradual increasing trend of ICC in proximal sections as has been reported earlier. Then what on earth causes the intestinal dysmotility? So we felt that the absence of morphological abnormalities in the proximal dilated bowel support the hypothesis of D. Lamar et al. That was proposed in 1970s, where he had said that it is because of the dilatation of the proximal bowel. See, for peristalsis, you need to have coaptation of the walls. If the bowel segment is very dilated, the coaptation is not occurring and therefore the peristalsis is not coming. Though the bowel is histologically normal. How does this change our clinical practice? The change is that initially we used to resect long segments of the bowel, thinking that this bowel is abnormal. But after this study, we have changed our protocol in our institute. And we feel that bowel plication, rather than massive bowel resection, should be the preferred management of intestinal atresias. And this is what we do. Now we would go only around 3 to 4 centimeters proximal and we would plicate the rest of the bowel. We published our study in a very reputed journal of pediatric surgery, and which was published as Novel Insights into the Histology of Jejunal Atresia and its therapeutic implications. Now, what are the therapeutic implications? I will just come in a minute. Do I have the time, sir? So, a prognostic classification was proposed way back in 1971 by Nixon et al., where they had taken 3 indicators for giving the prognosis: the site of atresia, the birth weight, and the associated anomalies. But we feel in country like ours, delayed resumption of gut motility should be one of the prognostic factors, and we think it is time to relook the prognostic factors for neonatal small bowel atresias. So we did plan another study, and we studied the multivariate analysis of time taken to achieve full enteral nutrition in small bowel atresias. Based on the final, we included 49 patients over a period of 23 months, and based on the final outcome, whether the full enteral nutrition was achieved or not, we divided our patients into 2 groups. FEN was achieved in nearly 60% of the patients, that is in 30 patients, and it was not achieved in 19. And we compared the groups by binary logistic regression to identify the factors that were different in these 2 groups. So birth weight, the common things that we normally see: birth weight, gestational age, site of atresia, bowel parameters like maximum transverse diameter of the bowel, circumference of the bowel at the site of anastomosis, and the remaining bowel length was recorded in the 2 groups. And as we can see in this slide, The achievers are depicted in green and the non-achievers are depicted in red. And as we can see, it is understandable that patients having multiple atrasias and duodenal atrasias were highest in the non-achiever group, while most of the patients of the ileal atrasia were in the achievers group. We noted there was a district timeline, and this slide can be used for prognosticating the patients when we are talking to the attendants. Ileal atrasia, the full enteral nutrition is achieved at the earliest, that is within 1 to 2 weeks, followed by duodenal atrasia and multiple atrasias, where you can say that if there is no complication in the patient will be on full enteral nutrition by 2 to 3 weeks. Jejunal atrasia is the one which takes maximum time, to the tune of 3 to 4 weeks. And these are the figures from our study. We also noted that in the non-achiever group, where we were not able to achieve enteral nutrition, the babies were low birth weight and preterms, much more than the achiever group. This again is understandable because prematurity and low birth weight is often associated with multiple atrasias and jejunal atrasias. We also noted the type of atrasia also determines the time taken to achieve full enteral nutrition. Those babies who have complex atrasias, by complex atrasias we mean to say type 3B atrasia, apple peel deformity, multiple atrasias or atrasias associated with meconium peritonitis or mucoviscoidosis, the timeline to achieve FEN is again different in these patients. Mean time taken to achieve FEN in complex atrasias would be like 3 weeks, which was significantly more than noted in simple atrasias, which will be around 2 weeks. We also noted a negative correlation with the maximum transverse diameter of the bowel as regards the time taken to achieve maximum full enteral nutrition. So the summary of this study was that the risk factors for late achievement of FEN would be a negative correlation with birth weight, gestational age, maximum transverse diameter of the bowel, remaining bowel length, and complex atrasias. Why it is so important to study full enteral nutrition, the time taken to achieve full enteral nutrition? Because it is a significant predictor of survival in our country. And it was also exemplified in this study that in the 30 patients where we were able to achieve enteral nutrition, all of them survived. While the 19 patients where we were not able to establish the feed for one or the other reason, they either died or they went LAMA. LAMA was included in the mortality. And this is another slide depicting the same, the time taken to establish enteral nutrition, 14 days. See, if a normal newborn, full-term baby, the amount of nutrition he is carrying from the mother would only last for 2 weeks. In a preterm, it will be like 7 to 10 days. If you are not able to feed the child by 14 days, it's like a ticking time bomb. And invariably, we lose the child. So we think that it is time to revisit Nixon's criteria, and the adverse prognostic factors in our setting for small bowel atrasia should be delayed resumption of gut motility, complex atrasias, and need for re-exploration, which should be minimized. And we have to get it right, and we have to get it right the first time. Thank you.
Wait, we will ask question at the end. Now I call Dr. Shilpa Sharma. Her lecture is Innovation in Pediatric Medieval Exercise.
Meanwhile, you can take some questions and I'll just take one.
bridge the time, I would like to ask question to previous speaker, Dr. Dhruv Ghosh. Hi sir, we work together in CMC. So my question is regarding the cross-border sharing of data. If you are planning some observational study and there is some data sharing with the cross-border, so what is your take on this? What is the rules? I want to know about it. So you can come on stage, please.
So for cross-border sharing, the ICMR has very good rules. I think one of the previous speakers talked about CTR. I think all our studies, whether observational cohort studies or trials, have to be registered now with the CTRI. That's the rule now. Earlier, the cohort studies did not need to be studied, to be registered. If your data is going outside the land, or even on a server outside the land, you need to get the Health Ministry Screening Committee permission from the ICMR. So once you have the ethical approvals from your institution, they have to be submitted along with the other data to the HMSC. Then the HMSC sits every 2 or 3 months, and then when they give permission, that's the only time when you can start entering data on data collection platforms like RedCap, etc., which will go outside the country. Do not enter data till you have got HMSC approvals. There is some confusion amongst institutions which ask for HMSC approvals first and ethics, then the ethics committee says they will give the ethics committee. That's not the way it works. The way it works is the ethics committee that gives the permission first, which then goes to the ICMR. So as a collaborator, we do all that work. You don't have to do the HMSC part. But initially, we'll ask you proof of submission for the ethics committee, which we can submit to the ICMR. ICMR is happy with that, provided we provide the ethics approvals. You can only start with the ethics approval if it's a multinational trial with your HMSC approvals.
So means institutional permission first, I think.
Yes, yes, yes.
Thank you so much.
Sorry for the delay. So we'll be talking about innovations in pediatric minimal access surgery. I have purposely added another phrase to it, evidence-based medicine, because that is the way you should think about where you need innovations and how you're going to do it. Necessity is the mother of invention. We all know that. Everyone fears surgery. Can we do better? No one likes big scars. All want less pain, less complications, less blood loss, faster recovery, less morbidity. Minimal access surgery came into existence in 1980s. However, it took some time before it began in children. The last decade has seen a big surge in it. So is mass safe in children? Is it feasible in our circumstances? Can it replicate open surgery? And if so, for which conditions? Is training in open surgery vital before shifting to MAS? This is a very important question as regards general surgeons, because now laparoscopic cholecystectomy is the way, and when they land up with a biliary stricture, these patients are then referred to the gastrointestinal surgeons. I'm working at ILBS at the moment for training, so we see so many biliary strictures that may present even 6 months after lap chole. So yes, you should go ahead with open surgery and then for training in MAS. Coming to evidence-based MAS in children and innovations, these will be my 2 objectives for today. So what is evidence-based medicine for the benefit of the nurses and the students here? You see the best scientific evidence, the clinical experience, and like Dr. Dhruv Ghosh had mentioned, the patient values, what is needed. So what is clinical expertise? That is what the clinician knows. That's why we need seniors and juniors to come along so that the juniors may think about innovations and how they're going to go about in future, plan their future with experience from the seniors. What is the evidence-based medicine? We have a lot of literature available now. Google is growing day by day and we need to keep looking at it. What you may have read yesterday may not be true today because new studies are coming up which may even counteract whatever you have read and learned for your examination. The patient values are most important. This is what the patient wants. And there have been many referrals now where patients come to us. We want laparoscopic pyeloplasty, but we've been told robotic is good, we'll have to travel all this way, and what will become of us? So there are steps for evidence-based medicine. You ask a clinical question, acquire the best evidence, appraise that evidence, apply it, and then assess how it's doing. It may not be the same in India as it is in UK, because we have different things to look up after. We have infections in the post-operative period. So there are levels of evidences. We have systematic reviews. There are 5 levels. We all should know this. So systematic reviews are the level 1, cohort studies level 2, case control 3, case series 4, and mechanism-based seasoning level 5. We can divide it further into 1A and 1B, where RCT take the top, the systematic reviews of the RCTs, then the RCTs 1B, then 2 is cohort, and then individual cohort 2B, and further on. So when you come to expert opinion, that is level 5, this is the beginning of research. So expert opinion is very, very vital, and here is where we need innovations. So when we have a surgical innovation, it may not see the day till another 5 or 10 years, because it has to go through the various stages. You had heard a very nice oration from Professor Miglani, but till others adopt what he is doing and then produce literature that this is the way to go, this is what patient wants, this is what is delivering good outcomes in future, with less time, then other comparisons also need to be made. So when studies are comparing different interventions or innovations, you have to see what are they looking at. Are they looking at the timeline? Are they looking at the morbidity? Are they just looking at the fistula rate? So all these things may be different. You may have no fistula, but you may be spending so much time doing that surgery. Is that feasible in a government setup where so many patients are lined up? So all these things matter. The Center for EBM grades of recommendations are 4, A, B, C, D, depending upon the level of evidence. So for pediatric minimal access surgery today, we have level 1A evidence for laparoscopic appendicectomy, inguinal hernia repair, orchidopexy, pyloromyotomy, and varicocelectomy. Level 1B for fundoplication and pyeloplasty. What are the advantages? Less wound infection, less pain for appendicectomy, less retching for fundoplication. Fundoplication is a procedure done in the West quite often because they have many patients with cerebral palsy. In India, our cerebral palsy patients are not referred so often for fundoplication, so we are doing it less. Lower incidence for metachronous inguinal hernia, shorter hospital stay in cases of appendicectomy, orchidopexy, pyeloplasty, shorter time to feeds for pyloromyotomy. In appendix, there is level 1A evidence that lap is better for the complicated appendicitis. People have worked in more, where irrigation was done first previously, but now they say do only suction. So doing only suction is better than going in for irrigation in complicated appendicectomy because it's going to spread the infection. So focus more on suction, and then later on if you need be, you can do whatever you want. For comparing lap and open fundoplication, there is evidence that lap is better. Comparing open hernia, inguinal hernia repair, it's better in children. Lap is much better because there is less operative time in bilateral hernias, less complications and less incidence of contralateral hernia. Open orchidopexy, lap is good, but when it comes to palpable testes, open surgery is better. So if you have a case with palpable testes, do not fool yourself or the patient going in for laparoscopy just to see that yes, it's entering the ring. There is evidence for lap being better for pyloromyotomy, that is infantile hypertrophic pyloric stenosis. Now people have started doing robotics, so comparisons have come for laparoscopy versus robotics. When you talk about pyeloplasty, the operative time is longer for laparoscopy, so robotic is good. But when you talk about infants, the operating time becomes longer for robotics, so here laparoscopy will be better. For varicocelectomy, yes, laparoscopy is better. Varicocele is, I hope you all know what's varicocele. It's a dilatation of the testicular vessels. The take-home message here is it is a common to find it during puberty, so do not take pubertal patients for varicocelectomy, which some people do inadvertently. It is not required, it settles with time. Comparing choledochal cysts, so there now the level has changed from level 1 to 2A evidence, and same thing with intersusceptions. What about chest lesions? So here we go slow because the level of evidence is only 3A and B for diaphragmatic hernia or TREF or lung resection or pneumothorax. It will slowly grow up, but at the moment it's only level 3A and 3B. So how do we improve that? We need to innovate, we need to improve our surgical skills. So there are 3 levels of innovations. One is the incremental innovation, which people do in a small setting, yet there are meaningful improvements with your products in your setup. There are breakthrough innovations which help a larger market and is professional. And then there are transformational innovations like the vaccine we had for COVID. It involved the whole world. So innovations in minimal access surgery have been going on. People have tried to do through a natural orifice, operating the gallbladder, going through the rectum, trying to do single incision laparoscopic surgery. But when you talk about evidence-based, the indication has still not been uniform, and this has only lied with only few surgeons. Robotic surgery is now coming up in a big way. The market is open. So previously we had one robot with 4 arms which used to take a lot of space. It is good. It improves the surgical precision. There is high definition 3D imaging, but needs a lot of training, and they have good training modules also. So they train you for 6 months. We have the Medtronics simulator at AIIMS where anyone can come to practice. There was a feedback problem. There was force feedback was not there. You don't have tactile sensations with robotics. So now they are working on that as well. Image guided microtherapy. This is very good. You must have heard about the gamma ray radiation for brain tumors, which neurosurgeons are doing. So here they can combine interventional radiology with surface viewing. You have the medical capsule robots. Here the robot goes inside. You just swallow that capsule and it will even release some medicines there if needed, and also give you a good camera view and then pass out through the rectum. What about the instruments? The instruments are taking innovations day by day, and optical trocar is very good. Previously people used to put in the trocar blindly or after the needle. Now you can see your view through. We have been using it routinely for our donor nephrectomies, and it's really good. You have a right angle clip applicator. It's available only for titanic clips now. It's very good for renal vessels, but we need one for the plastic clips. That's not available. This articulating camera is also there now. So these are the advantages you gain over laparoscopy. When we have the renal vein and the renal artery close by, you have 2 or 3 renal arteries coming down. So you have this camera which goes in and sees from that side also. So what you are seeing from front, you are seeing, but it can even go to behind the structures that you are viewing and give you a complete angle, like what is the structures down there. So this is really useful. Coming to hybrid surgery, this is the way through. So you think robotic is good or laparoscopy, you can do both together. Some steps may be done robotically, and then you can do some laparoscopically, and if need be, you can even go in open to handle the rest. This is good for hepatectomy. What's new? You have indocyanine, sentinel lymph node biopsy, perfusion can be seen for malignancies, and robotic assisted hepatic surgery is coming up in a big way. It's a very dedicated surgery. We take 10 hours for doing a liver transplant each side, 8 to 10 hours. So imagine if you do it robotically, it will take many more hours, but Medanta is doing it and they are successful. We have single port robots coming up which can unfold inside. This year in June, I had the opportunity to go to Karolinska University, Sweden, which gives the Nobel Prizes. So there you don't have any humans who are going to check that the drugs have finished. This is very important for the nurses here. So you have robots which come in, take the lift, go up and fill your counters with the drugs. And if a human comes nearby, they will say, please stay away, give me space, and they're going on their own. So it's really interesting. The world is changing. You have snake robots as well. So you shape off a snake, you can go inside and do whatever you want.
When it comes to robotics, it seems engineers take a lot of inspiration from snakes. Snake robots that fix pipelines on the ocean floor, snake-inspired machines that burrow through sand and soil, and snake-like robotics that could even be used in emergencies. Now, a team led by Jessica Berner-Kars, the director of the Continuum Robotics Lab at the University of Toronto, Mississauga, is building very slender, flexible.
So these are the innovations that we come to know about, but there are many innovations going on in China which only the Chinese know about, and when you see them in conferences, you're really surprised. They make light models, light instruments which go inside and work like a robot, but actually they are laparoscopy. So there are many things which are coming up, and we should attend the exhibitions of the conferences that we go to see what's new happening. At AIIMS Delhi, we do simulation and we also use the cadaver. So I've been assisting some general surgeons who are practicing these hernia repair. If somebody tells me a mesh hernia with robots, I will think what is happening. It's not needed. What is the need for doing that? But if you see them doing it or you assist them, they go inside, make an incision, put the mesh there, go on the opposite side with the robot, make an incision and pull out the mesh there. So there is no incision outside. Everything is handled inside nicely with the robot. It's much better than laparoscopy because they're able to see all around and stitch it also nicely there. And they were doing a mastectomy with robot. You think it's all visible outside. What's the need to go in with a robot? But you can go under the lesion, take it away from each muscle fiber and give a small incision. It takes time. So a lot of practice is needed. Need not go to the patient directly. All this can be practiced on cadavers. We have also developed a simulation model of TEF. Last year, RIPSS, we had inaugurated it, so it's there if somebody wants to see. It's 10 times less costly than the Australian counterpart. And it has better tissue fidelity, so resembles normal esophagus and trachea. So you have these 3D cameras, which are really good. So now we have equipment which can give you 3D and 2D both. You don't need to go for one of them. So if you need to do one step with 3D, you can do that, and then remove your camera and do a 2D laparoscopy. And you have to learn your open surgery again. So like when we do nephrectomy, the patient is in a lateral position. So we've learned how to do a fenestrial incision in lateral position, which we will never imagine otherwise. We'll think we have to make the patient supine, take out all the layers. But people are learning because it's the need of the day. So do a fenestrial incision in a lateral position and take out the kidney from there. So this is the latest Hugo RAS system where all the forearms of the robot are now separate, and more innovations are going on. Thank you.
Now the session is open to question. Few questions can be taken. If there is no question, we conclude this session.
With the permission of chairpersons, may we start the felicitation ceremony then, sir? No questions are there, sir? Then? Okay. Okay. See, that is for this session, we would like the chairpersons to kindly felicitate our speakers, Professor Dr. Dhruv Ghosh. So request you to kindly come on the stage, please. Request our chairpersons to kindly come forward and felicitate our speakers, please. Professor Dr. Archana Puri, PMCC from Safdarjung Hospital, New Delhi. Request you to come on the stage, please, ma'am. Professor Dr. Shilpa Sharma from AIMS Delhi. Request ma'am to kindly come on the stage, please. Now, I would like to request Dr. Vijay Kundal sir to kindly come on the stage and felicitate our chairpersons for the session. We thank our chairpersons for the beautiful session and your patience, sir. Request you to kindly felicitate Professor Dr. Sumitra Kumar Biswas, sir. Kindly felicitate Professor Dr. Narendra Singh, sir, please. We thank our chairpersons for the session. Thank you, Dr. Vijay Kundal, sir. Thank you so much, sir. I would now like to invite for our keynote speaker for the day, Professor Dr. Shakti Kumar Gupta, sir, Executive Director and CEO, and also the Organizing Chairman and Chief Patron for the Research and Innovation in Pediatric Surgery, that is RIPSS at AIMS. Thank you, sir. request Dr. D.K. Gupta sir and Dr. Goswami sir to kindly chair the session, please, sir. Request you to kindly come on the stage, sir. Request the AV team to kindly check the mics, please. Thank you, sir. Thank you, sir. Thank you, sir. Sir.
Hello. Very good afternoon. It's a pleasure to chair this session with my senior colleague, Dr. H.L. Goswami, after so many years in his own host city. And equally pleasure to introduce the Gupta. It is his own institution, and it was of AIMS New Delhi and gain of Jammu J&K state. What a wonderful person, jovial, interested, experienced, innovative, and always full of energy. So I think Jammu is really lucky to have such a wonderful person as it's not only director, but also a friend, and also with a bright future of this institution. Dr. Shakti Gupta, to you.
Good afternoon, my esteemed senior colleagues, faculty, students, our nursing colleagues. First of all, I extend greetings from AIMS Jammu, and welcome to AIMS also. So, I'm not a pediatric surgeon, but my background is administration. We'd like to share actually what we are doing, actually, what are the challenges we are facing, and what is our future vision actually for AIMS Jammu. And the topic was about the surgeons as a leader. There's no doubt about the surgeons that they're not excellent leaders in their field actually. So I have been fortunate to have worked with surgeons who were very effective leaders during my tenure at AIMS New Delhi for about 27 years. To name few, Professor Venugopal, Professor P.K. Dave, our senior actually, Professor D.K. Gupta, and I love working with pediatric surgery actually, and especially I admire him actually because the system which he developed in the intensive care unit actually, where actually really actually it was a worth visiting actually and experiencing. Then of course my teacher, Professor Goswami, I did my 1 year surgery whole job with Professor Goswami, Professor Dr. R.N. Sharma, and learned a lot at that time. So whether in the operating room, whether you are in the ward, OPDs, academic meetings, or in the boardrooms, they all have exhibited exemplary attributes of leaders in various areas, including institutions, innovativeness, and team building. So I was fortunate to be in AIMS for 27 years, working at different levels, right from the faculty, then the Hello Department, the medical superintendent for 15 years, in almost all areas of AIMS Delhi. So pioneers, they all are pioneers in their respective areas of work. They displayed unwavering confidence, inspiring and motivating their colleagues and juniors. So all of you are potential future leaders who are sitting over here, and most of you will definitely prove to be. I would like to share our extraordinary journey at AIMS Jammu with all of you, along with some points to ponder also. So I hope everybody knows the vision of our first president of AIMS, Rajkumari Amrit. So it was her statement, this statement in the parliament, that she said, it has been one of my cherished dreams that for postgraduate study and for the maintenance of high standards of medical education in our country, we should have an institution of this nature in India, which would enable our young men and women to have their postgraduate education in their own country. I think that was a very visionary, and that was actually when they were establishing AIMS Delhi. Then this is a vision of our Honorable Prime Minister of India, Shri Narendra Modi ji. AIMS like institutions, they aim to address regional healthcare imbalances, encourage evidence-based research, and elevate medical education standards in our country. Now you can see that from the first 6 AIMS, now the number of total AIMS has increased more than 22 as of today. So this is the trinity of mission for all AIMS. On the top, we have the education, followed by research, followed by patient care. So whenever in AIMS Jammu, when I have interaction with the faculty, with the nurses, and with all those with whom I am working, so I always ask my faculty that you have to spend 30 minutes of your time on education, 30 minutes of your time on research, 30% of your time on patient care, and 10% of your time you must spend in the community work. Then this is a governance structure which everybody knows. Now this actually for working in AIMS, what we did first in AIMS when I joined over here, that we prepared a governance manual, which is actually a reference manual for working in AIMS, whether in the selection, composition of committees, or all actually based on the guidelines by the DOPT, by the Ministry of Health, and other agencies. Now you know that what are the objectives of AIMS? These objectives are for all AIMS. First and foremost is to develop patterns of teaching in undergraduate and postgraduate medical education in all its branches so as to demonstrate a high standard of medical education to all medical colleges and other allied institutions. To provide facilities of high order for the training of personnel in all important branches of health activities, and also for medical research in its various aspects. And to grant medical degrees, diplomas, and other academic distinctions, which will be recognized medical degrees for purpose of Indian Medical Council Act 1956, the National Medical Commission. I hope you all know that whatever degrees are being awarded by AIMS, that need not to be actually recognized by Medical Council of India, and they are accepted, recognized degrees across the globe. So this is AIMS logo actually. So we actually deliberated for about 6 months what logo should be there for AIMS Jammu. And after 6 months of this thought process, so this logo of institute, it reflects the social, cultural and spiritual ethos of Jammu, AIMS Jammu. Like we have Mata Vaishno Devi, the Rangnath Temple, and Tavi Bridge, Tavi River. Then the most important of our meaning, that is our motto is, good health is the greatest blessing and health is the mean of everything. Then this is our journey. Actually the cabinet approval for this institute was done on 10th of January 2019. Foundation stone was laid by Honorable Prime Minister on 2nd of February. Then Gazette notification was done on 4th of December 2019. Bhumi Pujan by Honorable Dr. Jitendra Singh was done on February 2020. Then I joined in AIMS in May 2021. And you know that this institute though was inaugurated by Honorable Prime Minister on 20th of February, because at that time there were about 18-20 institutions which were to be inaugurated by us, but that was the inauguration of our infrastructure actually. But we started our OPD from 1st of August this year actually. And you know that in 4 years time, 1 year actually went into the COVID management and other thing. That was a big challenge for us actually, because we get more than 80% of laborers from outside Jammu. They come from the West Bengal, Orissa, UP, Bihar and other parts. So that was a big challenge how to retain the manpower actually for this actually, because Locally, this type of available manpower is not there actually. So then actually it was a big challenge. Usually this magnitude of the institute takes about 5.5 years. And with support from the state government, their state administration, from Ministry of Health, and even PMO office, because there was a team, this progress of AIM Jammu was monitored by the Cabinet Secretariat in the PMO office actually. So we were able to achieve this actually in 3.5 years actually. So that actually when I joined over here actually in May 2021, there were only 400 people working. And with every meeting actually we increased the manpower by 500 each. Then ultimately we appointed about 3,500 manpower working 24/7. So our target was, I gave a clear message that I don't want building in phases. I want all the 43 towers which are there in AIM Jammu simultaneously to be completed so that we can start all the facilities actually. And we are able to do that actually. Then in addition, this is actually inauguration by the Honorable Prime Minister. Then actually the OPD when started on 1st of August 2024, we started about 31 departments, 20 general, about 11 super specialty departments. Then actually these are departments which in different departments where we started the OPD, about 21 general and 10 super specialty departments actually. And in last 4 months, when we started actually, we are getting about 1,000 to 1,200 patients a day from not only Jammu province, but from the Punjab, from the Himachal and from Leh and Ladakh also actually. Then any patient who comes over here actually, so we have appointed patient care managers, patient care coordinators. Actually they get a feedback, they conduct an exit interview after the patient has passed through the different processes and the system. Then they ask them their inputs actually. And what we found that 99.6% of the patients, they are quite satisfied with the services of AIM Jammu. And whatever suggestion they give, we keep on implementing those also. It is an ongoing process. Then we have established 24/7 diagnostic laboratory services, which is available to the emergency, to the ward and others, in addition to the main department which are there in the academic block actually. So this is in addition to the comprehensive lab facilities of pathology, biochemistry and microbiology which are being established in the academic block. We have a very good radio imaging system as on today. We have got actually MRI, digital X-rays, CT 126 slide, 128 slides, DEXA and MRI also 3 Tesla. Then in addition to that, we started OPD as a 100 beds to begin with, but now we have increased to 250. And we have actually challenged to commission 750 beds in first phase, that actually in coming 6 months. Actually, that's the challenge which we have accepted. And we have got about 20 operation theatres, most modern operation theatres, that also we want to make it commissioned within 6 months time, but at present, 2 have been made functional and another 4 will be made functional within a week time. So we want to go a multiple of 4 theatres. Then in addition to that actually, so there is a total number of beds in first phase are going to be 750, which will increase to 1,500 and then third phase it will increase to 2,200 beds. So in 750 beds there is a provision of 193 ICU beds. This is very typically, we have provided ICU beds in each and every department. Every specialty is going to have an independent ICU with them near to their wards. In addition to that, there is going to be a 120-bedded main in this intensive care unit, but at present we have started 12-bedded emergency ICU services in the emergency department. Then OT services, like I said, that 22 operation theatres will be there. So we have already started in 4 months dialysis facilities at AIMS. Blood bank at AIM Jammu, I feel proud of the blood bank being established, which will be made functional in this month end only. Though we have already started storage facilities from 5th of September, then actually it is going to be the first time to have the most modern equipment in the first phase, also with the facilities like net testing platform, immunase-based viral marker screening platforms, fully automated immunochemistry analyzers, blood component irradiators, 3 apheresis equipment. Will be actually made functional within a month time or so. Then in addition to that, we have already established a poison information and management center in the Department of Pharmacology, which is working during the daytime. But the moment we get more scientists and resident doctors, it will be made functional 24/7. The idea is that any institution, actually, anywhere in the country, actually, if our district hospital, if there is a case of poisoning, so in initial resuscitation and stabilization, if they need any further guidance and support, and this center will be able to provide information, guidance, or what type of antidotes are required actually. So this has already been established in AIMS Jammu. Then when we talk of the support services for patients, we have already introduced the concept of patient care managers, patient care coordinators, and patient assistance services. What is patient assistance services is that we have put the volunteers, basically the hospital attendants with the pink coat on, actually they are available in the OPD, in the emergency. So actually whenever any patient comes who needs any support, any wheelchair or the trolley, so it is our responsibility to take the patient where they want to take actually and to take the patient to the respective area. We don't want and allow the attendant to take the patient or pull this trolley or take the wheelchair actually. Otherwise, whenever any patient comes to the hospital and there is a need of trolley or the wheelchair, so they will try to find one. And I have observed so many times that even the ladies are pushing the trolley and wheelchairs. So that we have stopped over here, and we have introduced a concept of patient assistance services actually. Then patient care coordinators are available at the reception centers to guide the patients in registration, in any other help. Then patient care managers are very qualified. They are graduate in life sciences plus postgraduate or MBA in healthcare management. And their role is actually they are the link between the doctor's administration and the patient. And they actually, if there is any patient who needs any financial support from any national schemes, so it is their responsibility to take care about that. And it is our responsibility to educate the patient from where they can get the financial assistance also. In addition to that, we have already started these shuttle services. Then we have actually provided already 216 bedded night shelter is ready for the attendants, because when I was in AIMS Delhi, because the number of patients are very much, it is 16,000 patients a day with attendants. So there is a space for the guest houses or the dharamshalas or sarais, but still that people are not able to. So what we have created, before we started this hospital, these night shelter facilities are already there, which is totally air conditioned. Then in addition to that, we have already provided Kendrev Bandar facility for this journal general items. Jana Shuddhi Kendra, Amrit Pharmacy is working over there. Banking facilities are already there actually in our campus. Then in addition to that, there are specific this hospital. When I talk about the hospital services, besides the modular operation theaters, nurse call system, we have already installed the pneumatic tube system for transport of the samples from one place to the main laboratories for testing. We have introduced automated waste and laundry system actually, which is not there in any AIMS in the country, for for movement of waste and the laundry from one area to the other area. And we have most modern audio-visual system in the teaching the classrooms. The unique outsourcing of services. This is a new model which we have introduced in AIMS Jammu. Usually what happens all other AIMS actually, they procure the equipment and ask the vendor to operate and maintain it actually. But what we have done, like mess and catering services, so we have already asked the vendor to install the equipment, operate, maintain, and everything they have to do, and we are paying rupees 140 per day for all the meals, which include breakfast, lunch, evening tea, snacks, and dinner also. Then in addition to that, like laundry and the linen services, we are not going to spend any money on procurement of the linen. The equipment has been installed by the vendor. the operation, maintenance, manpower, and he will supply the linen also to us. Otherwise, we spend crores and crores of rupees on procurement of linen in all other institutions. So that actually we have taken care. Now, another is that CSD, it is also has been outsourced. The expenditure on civil work completion, equipment, manpower, operation will be done by the vendor, but our committee will supervise and monitoring this actually. Then actually already 5 batches of MBBS are there actually. We took 50 in 2020. Now at present the 5th batch which have joined, we have taken 100 MBBS students as in today. Then we have also started the BSc Nursing. College of Nursing has been started. We have taken over 60 BSc Nursing students. Then in addition to that, we have already started PG program, 45 seats allocated to AIMS Jammu, depending upon the availability of faculty and their eligibility. And we are going to start DM, MCH courses also. And the total department general are 26 and super specialty departments are 24, which has already been approved by our governing body. This is a unique program which we have started actually in Jammu, along with IIT and IIM. That is a MBA Hospital Administration and Healthcare Management program, which was launched on 23rd October 2021, jointly by AIMS, Indian Institute of Management and IIT Jammu, first of its kind program, enlisted in CAT, 75 seats, then teaching by eminent faculty from all the 3 institutes. Highly successful program, seats increased from 45 seats to 75 now in 2023. Now this year at 24, the number has gone 40, keeping in view the demand. So there is a 100% placement of this 2022 batch, with having a package of about 15 lakhs to 32 lakhs per annum. They are open to the medical and non-medical also. And they are getting even their package actually more than the IIM MBA graduates. So this was launched by Shri Amit Shah, Shri Dharmendra Pradhan, our education minister, by Dr. Jitendra Singh, Governor of Jammu and Kashmir. Now another unique program we have started with IIT Jammu, that is a joint PhD program where the faculty from AIMS and IIT Jammu will be the guides and supervisors. Student can be from IIT, from AIMS also. Another program we are going to launch is the MBBS plus PhD program with IIT Jammu, because so many MBBS students do not want to go for the PG like MD and MS or clinical subjects. So they can go directly for the PhD program. We are going to launch biomedical technology course with IIT Jammu and School of Public Health with IIM Jammu. Then in addition to that, we are promoting research. Already we have received 95 research proposals as of today. And we have got good funding from ICMR. In one of the projects we got 25 crore rupees. In another 3 projects we have got about 1.5 to 2.5 crore rupees on that. And we are giving trust and motivating our students, whether they are nursing students or MBBS students, to get involved into the research also. And we have kept a provision of funding from the AIMS itself. Then in addition to that, so these are the, so right the day one, what are the meeting we have conducted, what were the decision taken actually we have compiled into a book, and which actually contains right till today that how many meetings, what was the decision, and whether what was the decision were implemented, or this has become a reference document and anybody can refer to that. In addition to that, our faculty, I am very proud of my faculty, they are coming out with a book, textbook of patient and healthcare worker safety, which will be released on 3rd of February, which is going to be our foundation day. Then digitization of AIMS Jammu. So this is, we are going in a big way. We have already earmarked a budget of 20 crore rupees for this. So there is going to be a seamless integration of healthcare ecosystem in AIMS Jammu. Then digitization, we have 4 actually milestones. We are already in the milestone 2. And whole digitization process will be completed in 1 year time, and when our AIMS Jammu will be 100% online. Then this is a patient referral system which we have developed at AIMS. I can say with proud that AIMS Jammu has got a well-developed referral system. You can get an appointment on app-based. You can get an appointment through the phone. And then actually, it does not mean that we don't entertain other patients who have not got the appointment. So any patient who is walking, they can, our security guard guide them to go to the Ayush block. Those people who have got an appointment, they go to the main OPD. Those patients who have been referred, they go to the main OPD. And emergency patients have been referred to the emergency department. So this way we have decongested the patient crowd in our hospital. And then actually we have most modern lecture theatres over here. Our Honorable Health Minister when visited, then we demonstrated this actually, and he wrote and he witnessed that actually how this system is operating. Then he has written my good wishes to AIIMS Jammu. Then this is a digital library. I will appreciate that all of you must visit our digital library. Actually, this is one of the best library I can say in the country. None of the AIIMS in the country has got that digital library which we have got. And this has been inaugurated by the Secretary. So this is the entrance, total RFID based entrance, total controlled. Then these are the actually reception over there actually. These are the different areas. We have specially created a children corner. We want that when faculty comes, they should encourage their children to come to the library to develop them a habit of going to the library actually. So these are the new arrival section. This dissection rooms, total soundproof dissection rooms. If you want to discuss some thesis subject, PhD subject with your students, you can go to the library and sit over here. And then these are the reading areas. These are the library resources. We have already e-books like subscribed textbook about 5,000 actually, and then journal for more than 1,400 journals. And we are very active on the social media actually. So we have already made about 202 YouTube talks. We encourage our faculty, our visitor, any guest who comes over here actually to give a talk about 8 to 10 minutes for the public awareness. In addition to we ask our faculty and our nurses also to write an article in the newspaper for creating the public awareness. Then actually this is the value addition we have created in Jammu. We have already actually created an amphitheater over there, cycle track, soft music in whole of residential area, swimming pool facilities in the guest house, gym facilities are coming up. We have a fully air-conditioned indoor sports complex which will be functional within a month or so. We have a very good stadium, cricket stadium, equal size is equal to criticism. Then these facilities are shortly coming up for the babies. So then there are some more value addition which we have created, that we are sitting here at which is the most modern convention center. And we total have a 2 to 27 acre land, and we are developing in Jammu as a global village. We want to provide each and every facility within the campus itself so that nobody needs to go outside. Then these are sports complex. These are sports facilities which are going to be available within a month or two. Gym, squash, basketball, football, outdoor sport facility, basketball court, badminton courts, then kids play areas, tennis court, then cricket pitch is already coming up actually. Then we have provided soft music in residential areas. Then actually we are getting a lot of support through the CSR initiatives actually. So I am approaching at different public sector organizations for getting we got air conditioned bus from the State Bank of India, then electric golf carts from the J&K Bank. Artwork is being provided that you see the beautiful sceneries which has been provided to Mr. Ajay Pudar from Bombay. Night shelter actually already we are there, but we have approached Power Grid of Corporation for donation of 45 crore. They have already agreed for 15 crore, but I am trying to get 45 crore so that we can add another 650 rooms for the patients attendant. Similarly, robotics smart lab, the National Stock Exchange Foundation, we are in touch. Already proposal has gone for 16.32 crores, and I'm sure that before end March, we'll getting this smart lab, which will have a capacity of 60,000 tests a day, and the turnaround time will be about 4 hours. Then in addition to that, iBank proposal is with HUDCO, 1.27 crore rupees is going to be there. I am sure we are going to establish soon. Then cancer mobile van facility with ICI Bank, electric golf course, another 10 has been approved by Woodco. Now, actually, since our focus is to develop this as a green campus, so we want to introduce more electric vehicles. Actually, movement between the north campus, this is the north campus, and across the road is a highway, is a south campus. So our electric vehicle will go so that no staff need to come bring the vehicle over here. Then in addition, some OT equipments have been donated by the SDFC Bank, and we are in touch with them for another 5 crore rupees grant from them. So we are actually focusing on collaborations. We have signed MOU at the national level. Then actually the MOU with the Rashtriya Ayurveda for research in Ayurveda. Then we have also actually the MOUs with Himalayan Research Institute for Yoga and Naturopathy. Then we have an international MOU with University of Alabama for innovation, entrepreneurship, and startup program in healthcare industry. And these are the proposed facility which has already been approved by our governing body. In this actually the proposed facility are establishment of Center of Excellence for Advanced Studies in Hospital Nutrition, Center of Excellence in Ophthalmology, including skill development, dental sciences, then comprehensive cancer care, robotic and technosurgery center, then at least Center for Excellence Telemedicine and Telecare, and Center of Excellence in Trauma Sciences and Institute of Traumatology. We don't have any Institute of Traumatology in the country. We are already in discussion with Israel. The MOU has gone to the Ministry for clearance, but since Israel is in turmoil, so this is getting cleared by year or so. We are actually going to tie up with the Shiva Medical Center, which is one of the best 10 centers in the world. So we are already in touch with them actually, and there will be exchange program, exchange of faculty, the students, and then the joint research and skill development facility. Now already we have established a College of Nursing with 60 intake. Then our future is also actually predictive medical technology. That proposal has been approved, and we will start working on that also. Then actually we are going to establish research center and international collaboration facility over here. Then Department of Quality and Patient Safety has already been approved. Now we are going to recruit the manpower. Then we are going to establish simulation skill development facility. The proposal of 100 crore rupees has already gone to the Tata Trust, and we are in touch with them. We submitted a proposal of Institute of Forensic Sciences to the Ministry of Home Affairs. They have approved, and they have passed this to the CBI, and I am happy to share that this institute is coming up in the district Samba itself actually, where actually AIM Jammu will work with the Ministry of Home Affairs along with the law enforcement agencies. Then we want to create a industry academia interface for the research, because research, you know that a lot of money is required for the research, and we want to work with the industry, and the facility will be provided within the campus itself. Then we are also going to establish a guest house for international faculty and researchers. We have taken a principal decision that we can invite faculty from country, from outside country. They can come over here, work with us in the area of research, in teaching, in skill development, and we'll take care about their air travel as per their entitlement, maybe business class for the professors, and the guest house facilities over here. In addition to that, a total pocket money of 6,000 per day. So that decision we have already taken actually. Now we have written a letter to them actually, but people have started coming to us actually. They spend time from New York, from other part of the US, from Australia. They keep on coming to us, and our idea is to get them involved into 3 main areas, that is research, teaching, and the skill development. So these are the centers which has already been approved, which I was talking about. Now another area where we are going to work is the Center of Excellence in Precision Medicine. AIM Jammu proposes to establish a Center of Excellence in Precision Medicine, bringing cutting-edge next-generation sequencing technology. It will function as a reference center in the northern India. It will transform the field of pathology, oncology, gynecology, and transfusion medicine, and other specialties they want to use. I have got a funding of about $1 million for this facility, which is being established, and on 3rd of February this will be inaugurated by Honorable Health Minister actually. I think this is going to have a edge in the diagnostic facilities. No, there are certain points to ponder actually. So to end my talk, I want to say that you should save only those memories which give spark and twinkle in your eyes, not wrinkles on your face. That we must adopt in our life. Let us join together to make AIIMS Jammu a most modern and state-of-the-art institute with focus on quality patient care. Our motto is patient first. What are the infrastructure we are creating? If doctors are there, if nurses are there, if we are there, it is for the patient. And keeping in mind the needs of the patient, we must develop our institute keeping all their necessities in mind. So, to end, time has no holiday. Dreams have no expiry date. Life has no pause button. So let's move forward. So enjoy every moment of your life. Your personality, your presentation, your conduct, your communication should look different, because AIIMS is an institute of national importance. And when we are working in AIIMS, our communication, conduct, behavior has to be different actually. And for the administration, our responsibility is to give you that environment where you can actually do the research, freedom, and grow. That is our actually mandate. So at AIIMS Jammu, we don't work by clock. So we presume that everybody is present 24/7. So in our administration also, unless we don't finish the work by evening, we don't go home. Our normal working is 9 in the morning till 9 in the evening. So our faculty also, unless they don't finish the work, so they have to finish on the same day. So every department to develop their vision, their mission, quality policy, SOPs, checklists, and protocols. Only then we can move forward. So try to keep balance between your family life and the professional life. That is very important. So if you are not keeping that balance, so you will not be comfortable at the hospital also, in the institute also. If you are not keeping a balance with your wife, then you can imagine what you are going to face. The components which will dictate healthcare professions in next generation healthcare, that is going to be the quality, patient safety, and safety of community, which is supported by technology with focus on research and development. These are the things which are going to dictate our future healthcare. We want to develop AIIMS Jammu as a global village with international students, counseling and study centers, internationalization of various facilities and training programs, inviting scientists and experts from national and international universities. Then focus will be on developing centers for academic excellence, research labs, industry engagement, global engagement, and digital education and student support. The modalities for delivering the future education will be online education programs, learning management systems, and equitable use of technology. So we must adapt. We should not actually only depend on traditional system of teaching. We must adopt integrated learning modules, monthly guest lectures on diverse areas, and we must establish leadership forums every month where all faculty, students, nurses, everybody should join, and we can have some leadership lectures. The biggest challenge before us is how to bring patient in decision-making process in disease management. I think that's the biggest challenge. Looking for more involvement of patients, are their attendants, are representatives for initiation of the medical management actually. That is important. if we take patient into confidence, their relations, attendant into confidence, what type of surgery we are going to do, what type of intervention or treatment modality we are going to do, if you take them into confidence, then we are not going to have any communication gap and violence and other areas in our institutions. The compulsory briefing of the patients before surgery or any intervention, along with the relatives, attendants after rounds about the patient's condition is of paramount importance. I think nobody can ignore that at least. Non-mandatory skill development and knowledge updation of all categories of healthcare workers, whether they are faculty, SR, nurses, paramedics, and sports staff. I think we must conduct regular soft skill and communication workshops for all category of workers so that actually they can conduct in a proper professional way. And with this, thank you so much for your time. And I remember actually the ICU of Professor D.K. Gupta sir. My one operation actually had imperforate anus. Immediately they were taken to their, they immediately admitted and asked us to give phone number and go back and come in the morning and evening, we'll brief you what is the progress. I think that is modern, that is the example which I have kept in my mind. Still I don't forget that actually. Thank you so much. Thank you.
Thanks for Shakti. Chairing a session where one of your students happens to be keynote speaker is a matter of pride and satisfaction as a teacher. Dr. Shakti has given us the milestones and the future roadmap of the AIMS Jammu. We are lucky that we have a CEO and director who, in addition to being an accomplished administrator, is a local person, is aware of the local problems. So I think that works very well for the institute, and we wish them all the best. Thank you.
Requesting our chairpersons to kindly felicitate Sir, please.
Such a lovely talk. What a keynote address, I think. It is so mesmerizing. We have no doubt.
Request all of you to kindly stand, please.
With his really educated person. A marvelous job for this institute. That's all. Really very, very good.
Taking a moment, I would like to request Shilpa ma'am to kindly felicitate our chairpersons also, ma'am. Please, ma'am.
It's my pleasure to extend a warm and a sincere welcome to all of you to the inaugural session of the 9th Annual Conference of Research and Innovation in Pediatric Surgery. For the inaugural ceremony, I would like to invite our esteemed dignitaries to grace the stage with their presence. First, I would like to call upon Dr. Professor Sumitra Kumar Vishwas, Sir, President IAPS. Give Sir a big round of applause. I'd like to invite Dr. Professor Shilpa Sharma, Professor Pediatric Surgery, AIMS, New Delhi. Please, ma'am, we would like you to grace the stage with your presence. I would like to call upon next Dr. Professor Nisar Ahmed Bhatt, Professor and Head of Department of Pediatric Surgery, SKIMS. I would like to call upon our Honorable Director, Sir, Dr. Professor Shakti Gupta, sir, to please grace this occasion with his presence. Next, I would like to invite Dr. Lieutenant General Sunil Kansar, our worthy Medical Superintendent, to please grace the stage. I would like to call upon Dr. Meeta, our most talented Dean Academics, to please honor this occasion. I welcome Dr. Saurabh K. Gupta, Dr. Shabab, and Dr. Vijay Kundal to please join the dignitaries on the stage. Jammu Kashmir is known for its warm hospitality all over India. And in our culture, the dignitaries, the guests are akin to God, which is Atithi Devo Bhava. So I request Dr. Vijay Kundal sir, our organizing secretary, and Dr. Lucky Gupta ma'am to please welcome all the dignitaries on the stage with the bouquets.
In the meantime, may I request the team for the lamp lighting ceremony to kindly be ready. Thank you so much, Dr. Vijay. Thank you so much, Dr. Lucky. Now I request all the dignitaries. Okay. They both can have an exchange. Ankit, may I request you to kindly take this felicitation photograph, please? A welcome by the host, by the guests themselves. Thank you so much, Ankit. Now I request all the dignitaries to kindly come forward for the lamp lighting ceremony. May I have the team for the lamp lighting on the stage, please?
वस्त्रावृता या वीणा
Thank you so much. Now I would like to invite Dr. Vijay Kundal sir, Organizing Secretary and Etuary Pediatric Surgery, AIMS Jammu. Sir.
Good afternoon, respected dignitaries on the dais and off the dais, and faculty colleagues, students, and all dear friends. It is with immense joy and pride that we gather here today at AIMS Jammu for this Research and Innovation in Pediatric Surgery conference. I welcome you all to our city of temples. On behalf of AIMS Jammu, I extend a warm and heartfelt welcome to Professor Dr. Sumitra Kumar Vishwas, sir, President IAPS, Professor Shilpa Sharma ma'am, Chairperson RIPSS, Professor Nisar Ahmed Bhatt, President JK Chapter of Indian Association of Pediatric Surgeons. A special welcome to Professor Dr. DK Gupta sir, a renowned figure in pediatric surgery worldwide who has travelled all the way from Australia. A warm welcome to Dr. Miglani sir, President-elect, and all the esteemed faculty and speakers and delegates who have travelled from all over India to attend this conference. I also want to welcome our senior pediatric surgeons of the Jammu and Kashmir, Professor H.L. Goswami sir, Dr. Yogeshwar Mangi sir, and Professor Naseeb Chand Digra sir. The seeds which they have sown, it is time for us to water those plants now. Our support system and our worthy Executive Director and CEO of AIMS Jammu, Professor Dr. Shakti Kumar Gupta sir, we welcome you sir. I extend my warm welcome to Professor Sunil Khan sir, MS and Dean Research in Jammu. I also welcome Professor Meeta Gupta, Dean Academics, Dr. Saurabh Gupta, Dean Examination, Dr. Shabab Lalit Angurana, Associate Dean Research, and Colonel Sanjay Garg, DD in Jammu. I warmly welcome our esteemed faculty members and dear students whose participation enriches this conference. Your presence here underscores our shared commitment to advancing healthcare for children. I believe you will enjoy a good time during this conference and it will be a great learning experience for all of us. Thank you.
It's a moment of pride and privilege to have amongst us the most dignified personality, Dr. Sumitra Kumar Vishwas, as chief guest for today's event. It's an honor to invite you, sir, to the dais to address our audience.
Good afternoon, everybody. The dignitaries on dais and off the dais. I was not very keen to come here, but because of coaxing of Vijay Kundal, I had to come. So, but I must thank them that I have not. I would have missed a very good occasion. From the keynote lecture, I can visualize that AIMS Jogvi is going to be older years Nalanda or Taxila. That's the roadmap. I can visualize that future. And though I was a founder member, probably my membership number in the RIPSS was number 10 or something. Probably I was the first EC member also, but I was in sleep like Kumbhakarna. That has been announced now. So with these small talks, I thank for the success of this conference. I pray for the success of the conference, and I am very much impressed by their hospitality. And this institute is very much well planned and well organized. Thank you all.
Thank you so much, sir. Your words have motivated all of us now and then. I would like to invite Professor Dr. Shilpa Sharma, Chairperson RIPSS and Professor Pediatric Surgery, AIMS New Delhi, on the dais, please.
Thank you, Sanjoli. The RIPSS, earlier it was known as the research section of IAPS. It was formed in 2006 in the annual conference by Dr. G.R. Prasad. We had founder members like Dr. S.K. Biswas, Professor D.K. Gupta, who are here today. The annual conferences organized by this section have been very unique because we inculcate the essence of research amongst new researchers. Most faculty involve great scientists and eminent surgeons who've done substantial research. The audience includes basic and clinical scientists and that discuss the scientific basis of disease. The previous conferences have been held in major prominent institutions in 5 major cities, including the first 2 at Hyderabad, followed by Dr. RML Hospital, where I was there at that time, the 3rd one, the 4th at IMS Varanasi, 5th at PGIMER Chandigarh, 6th at AIIMS Raipur, and then we had an online one during the COVID, and the last at AIIMS New Delhi. In 2021, during the COVID, we had a grand conference which was online with 306 delegates, including 60 international delegates from 19 countries, with maximum spread of knowledge, with recordings of all the speakers. Personally, I have been closely associated with RIPSS since 14 years, involved in organization of the last RIPSS since 2011, initially as a member, then executive member for 2 terms, secretary for 2 terms, and now chairman. The logo of RIPSS was designed in 2021, and the name was changed to Research and Innovation Pediatric Surgical Society as per suggestion of Professor A.K. Basu, to include the word innovation, as he saw that many of the papers were based on innovation, and in GBM he added this. It is heartening to have this prestigious national conference at AIIMS Jammu under the able leadership of Professor Shakti Gupta, Director and CEO AIIMS Jammu, with Organizing Secretary as Dr. Vijay Kundal and Dr. Lucky Gupta as Joint Organizing Secretary. RIPSS is grateful to you, sir, to AIIMS Jammu, the whole team here, the academic department of AIIMS, for having us here to this prestigious and beautiful state of our country, Jammu and Kashmir, which people from the south fear to come to, but here we are today. We are indeed honored with the in-person presence of our President IAPS, Dr. Sumitra K. Biswas, President-elect Dr. HPS Miglani, Founder Chairman of RIPSS Professor D.K. Gupta. We are blessed with faculty and delegates from across the country, east to west and down south, in person, and many more are seeing us online. RIPSS is privileged to bestow 5 RIPSS Lifetime Achievement Awards this year, which will be honored here in this inauguration, to Professor D.K. Gupta, Dr. Hira Lal Goswami, Dr. Yegeshwar Mengi, Dr. Nasir Digra, and Dr. Shakti Gupta. It may be a surprise for him. In 2023, RIPSS started 2 RIPSS orations for outstanding researchers and surgeons. You heard the AIIMS, the Amita Sen RIPSS oration by Dr. HPS Miglani just shortly. The Purushottam Upadhyay RIPSS oration this year will be delivered by Dr. Anurag Krishna. It was started by an endowment donation by Professor D.K. Gupta in memory of his revered teacher, again an example. But the Executive Council at RIPSS decided to change the name to Upadhyay Gupta Oration so that the 2 names remain together for times to come. This year, RIPSS has started a 3rd oration by a donation from BHU alumni. We have Dr. S.K. Biswas, who is also a BHU alumni, here with us. The BHU alumni RIPSS oration was to be delivered by Professor A.N. Gangopadhyay. We will honor him, and he will deliver it in next 2 months, anytime online. Because of a family issue, his brother was not well, he could not make it here. There was a pre-RIPSS live workshop on extrophy bladder yesterday at GMC Jammu, and we are grateful to Dr. Salim Naski for that. We have 2 hands-on workshop training modules prepared by the AIIMS IIT collaboration. The model on abdominal wound was specially created for the MBBS students and early medical general surgery students. Dr. Varun and Jogendra from IIT Delhi will be here convening this with the support of the Ethicon team. I encourage all of you here, nurses, students, faculty, to please join that as mentees and mentors so that you learn and you teach through that model, so that patients are not models to learn from. You have to learn on simulators. RIPSS currently has 116 members. We do not encourage too much membership because we want only those who are interested in research to join in. 46 members were added this year. Many of these are here today attending the conference. Professor Manish Pathak from AIIMS Jodhpur, Dr. Dhruv Ghosh from CMC Ludhiana. The Secretary of RIPSS, Dr. Sagar Javale, is an ardent innovator and he has more than 30 inventions. He could not make it here, unfortunately. He has developed a patent cell of RIPSS and helps the members to even expertise their knowledge and innovations to have patents in their name. The executive members, Dr. Sanjay Raina from JNK, Vijay Upadhyay, who is here and will be taking over as chairperson-elect, Pragna Bendre from Maharashtra, Ravindra Mahapatra, Dr. Sujay Pal from Kolkata, Nitin Borkar and Subhashi Saha have worked hard over the last 2 years and will be handing over the responsibility to the new team this conference, and it will be led by Professor Prabhu Goel, who is here today. RIPSS is the avenue where the mind explores research with an open mind, where meaningful discussions are held with scientists and innovators. I hope you all enjoy the conference proceedings and make use of your presence at AIIMS Jammu. RIPSCon 2024 academic program has included good research-based topics that are useful for all specialities and also includes meta-analysis, systematic review. We have Dr. Ajay and Sachit from AIIMS New Delhi who will be covering that tomorrow. So I encourage all of you to attend that. It is not only for pediatric surgeons, it's for everybody, the whole of AIIMS Jammu. Thank you.
I would now like to request Dr. Nisar Ahmed Bhar, Professor and Head of Department of Pediatric Surgery SKIMS, to come to the dais to address the gathering with some words of wisdom.
Good afternoon, everybody. Dignitaries on the dais, colleagues, students. On the behalf of JK chapter of IEPS, indeed it is my pleasure to welcome you all for your participation and encouraging us on this first academic event. In fact, the pediatric surgery, in JNK, the Sheikh Kashmir is the only place where we are offering the pediatric surgery facilities. But because of the terminal for last 3 decades, we could not do much on the academic event. So last year only we could launch this chapter. But then Dr. Vijay took a lead in arranging the first academic event. Hopefully we will be seeing such events very frequently in future. And we also are planning next year PASI at Srinagar. So please just mark your dates and join us next year. Will be somewhere in May. We are arranging this. So everybody is welcome. Thank you very much.
Thank you so much, sir. I would like to request our Executive Director and CEO, sir, Professor Dr. Shakti Kumar Gupta, sir, for his words of enlightenment, please. We already had a wonderful session, sir. Few more words, sir, please.
So, good afternoon once again. My respected teachers are there, Professor Dr. Maggie. I saw just now actually Dr. Linda is also here, colleague. I'm happy that the Pediatric Surgery Society decided that to hold this meeting over here. And we are trying our best to come to your expectations. Though AIIMS Jammu is taking baby steps, so I'm sure that another coming 1 year, this is going to be the most happening place in Jammu. And already actually, Dr. Sushma Bhatnagar from AIIMS Delhi, they are going to have a World Congress in the end of January in Jammu itself actually. So they have shifted that conference over here. Then in addition to that, we are going to have another international conference on genomics and next generation sequencing in the month of February. We are expecting about 40 experts from across the globe. They will be here at that time when we inaugurate the next generation sequencing lab. So we have lined up so many activities over here actually. Just actually I observed there is some, this sound system there was some problem, but we will take care of the decision. And maybe I discussed with General Sunilkant also, actually, this should be actually rectified within a week time. Maybe we will go for more high-tech audio system. Though this is the most digital auditorium where all sound system, all this lighting system, air conditioning system can be controlled with one this iPad. So maybe actually this beginning first conference is there. Actually, we have observed there are certain things which needs to be given attention on priority. And I'm sure that everybody will have a wonderful time in Jammu. And maybe when next time you come, actually there are going to be more actually improvements and changes in the setup actually, where you can feel like coming, like a homecoming sort of thing actually. Like our guest house is a very good guest house actually. We have started actually furnishing it also. And it is a 26 room guest house. And we are ensuring that to provide the best quality food and environment over there. And with these words, I thank to the organization to giving us the opportunity to hold this conference over here. And more to come actually. Thank you so much.
Requesting our Executive Director and CEO, sir, to kindly felicitate Professor Dr. Subhashra Kumar Biswas, President IAPS, that is Indian Association of Pediatric Surgery, please. Sir. Thank you so much, sir. Now I would like to request sir to kindly felicitate Professor Dr. Shilpa Sharma, Chairperson RIPSS Research and Innovation in Pediatric Surgery Society, and Professor Pediatric Surgery, AIIMS, New Delhi.
I would request Dr. Sumitra Biswas and Dr. Shilpa to please felicitate our worthy director, sir, Dr. Shakti Kumar Gupta, sir, and please give them a big round of applause. I would request Dr. Biswas and Dr. Shilpa to also felicitate Dr. Nisar Ahmed Bhatt, sir. Please, audience, please give them a round of applause.
Thank you so much, sir. Now I would like to request Professor Dr. Nisar Bhatt, sir, HOD Schemes, to kindly felicitate our MSR, Lieutenant General, Dr. Sunil Khan, sir, SMVSM. Requesting Dr. Vijay Kundal sir to kindly felicitate Dr. Meeta Gupta ma'am, Dean Academics. Since ma'am gave me a beautiful smile, so I just missed it. So Dean Academics and HOD Ops and Gynae AIIMS Chairman.
I would request Dr. Vijay sir and Dr. Lucky Gupta ma'am to felicitate Dr. Saurabh. Dr. Vijay sir and Dr. Lucky ma'am, please felicitate Dr. Shabab sir.
Thank you so much. Last but not the least, I would like to request Shilpa ma'am to kindly felicitate Dr. Vijay Kundal sir, please. So the aspiring students, those who want to be the next pediatric surgeons, request you to give a round of applause for all the senior leaders who are on the stage, please. We shall start with the next ceremony of Lifetime Achievement Award. We are just putting the chairs and then we'll call. So, I request all the dignitaries to please be seated, please. Abhi hai. I would like to trouble again all the dignitaries to kindly felicitate Professor Dr. D.K. Gupta sir, Research and Innovation. Okay. So, ma'am, this is very difficult, all the dignitaries. For me, everybody is a leader, everybody is a senior dignitary. So requesting all the dignitaries to kindly felicitate together Professor Dr. D.K. Gupta, RIPSS founder, on the stage, please. Sir, I would like to request you to kindly come forward, sir.
Good afternoon, everyone. It's an absolute honor to stand before all of you, as I have been the student of all these intellectuals who are going to receive Lifetime Achievement Awards today. First and foremost, I would like to express my heartfelt gratitude to Dr. Shakti Kumar Gupta sir, ED and CEO of the AIIMS Jammu, and Dr. Vijay Kumar Kundal for giving me the opportunity to speak at this prestigious occasion. Okay. Professor Devinder Kumar Gupta is a founder of the chairperson of the RIPSS, and sir has served as professor and head of the Department of Pediatric Surgery, AIIMS, New Delhi, until his superannuation in July 2018. During his tenure, he treated children with various malformations, cancers, trauma, and other illnesses, and trained over 100 fellows leading to MCH degrees. He also had prominent leadership roles, including Vice Chancellor of King George Medical University, Lucknow, and Director and CEO of the Postgraduate Institute of the Child Health, Noida, NCR. As Executive Secretary of the National Academy of Medical Sciences, he contributed significantly to Medical Academia. Professor Gupta was a founder member of SARC, Federation of Pediatric Surgeons, the International Society of Hypospadias and DSC, and the International Society for Regenerative Medicine. He conceptualized and established the Center of Advanced Molecular Biological Research at KGMU and Postgraduate Institute of Child Health in NCR. An acclaimed author, he published over 300 scientific articles, 230 book chapters, 12 monographs, and 12 reference books, with translations in German, Polish, and Chinese. He served as editor-in-chief of the Journal of Indian Association of Pediatric Surgeons and as an editorial board member for over 15 international journals. Known globally, he was invited to over 80 institutions worldwide as a visiting professor, keynote speaker, and demonstrator of live surgical techniques. He recognized with numerous prestigious awards and honors, including honorary fellowships from the FRCS Edinburgh and Glasgow, the PsychOps Ambassador title from Italy, and the GAP-IO International Award for Surgical Excellence 2022. Professor Gupta's contributions are immortalized through awards and lectures established in his name, including the Devendra Gupta WAF at APS Gold Medal and the annual lecture at KMU.
May we hear the applause, please? Thank you so much, sir. It's time to recognize and give respect to the senior pediatric surgeons of J&K and present them the Lifetime Achievement Award. I would like to request Professor Dr. H.L. Goswami, sir, to come on the dais, please, sir. Sir.
Welcome, sir. Professor Dr. H.L. Goswami is a distinguished pediatric surgeon. He completed his MBBS in 1969 from Government Medical College, Srinagar, followed by MS in 1973 and MCH in 1975 from AIIMS, New Delhi. Dr. Goswami began his career as a lecturer at GMC Jammu in 1975 and retired as Principal Dean in 2005. Post-retirement, he served as a member of the Jammu and Kashmir Public Service Commission from 2006 to 2011. He has had significant leadership roles, including President of the Northern Chapter of ASI and member of the Institute Body and Academic Committees at PGIM Chandigarh, SKIMS and Jammu University. Dr. Goswami's contributions to surgery and medical education have left a lasting legacy. Welcome, sir.
I am honoured to invite now on stage Dr. Professor Yogeshwar Mendi. Dr. Lucky will elaborate the contributions of Sir to the field. Welcome, sir.
Welcome, sir. Professor Dr. Yogeshwar Mendi is a distinguished medical professional with extensive experience in pediatric surgery. He completed his MBBS in 1966 from Srinagar University, followed by MS in General Surgery in 1972, and later specialized with MCH in Pediatric Surgery from PGI MER Chandigarh in 1980. Dr. Mendi began his career as a faculty member at the Government Medical College Jammu, serving from 1976 to 1983 and later from 1994 to 2002. He also gained international experience as a consultant pediatric surgeon at KFCH Gezira, Kingdom of Saudi Arabia from 1983 to 1991. Upon retiring to India, he served as a professor of pediatric surgery at SCOMS Jammu From 2003 to 2015, his commitment to maintaining the highest landmarks of hygiene and surgical precision has been a hallmark of his practice. Welcome, sir.
Thank you, sir. It's my pleasure to invite our senior pediatric surgeon, Dr. Naseeb Chand Digra, sir, to the stage for the felicitation.
Good afternoon, sir. Professor Dr. Naseeb Chand Digra is a distinguished pediatric surgeon with over 36 years of experience in the medical field. He completed his MCH in pediatric surgery from the PGIMER Chandigarh in 1990 and holds an MS in general surgery from the same institute. Dr. Digra has served in various prestigious roles including principal and dean and professor and HOD surgery at the Government Medical College Jammu. He is superannuated as a secretary technical for the Health and Medical Education Department, Jammu and Kashmir Union Territory in March 2021. With extensive administrative experience of over 16 years, Dr. Digra has made significant contributions to both medical education and research, having guided over 50 postgraduate students and published more than 40 scientific papers in the national and the international journals. Dr. Digra has been an active member of several professional organizations, including the IAPS, IMA, and the Association of Surgeons of India. As governing council member during 2019 to 2021, he also served as a vice president of the J&K chapter of ASI and editorial secretary cum associate editor of prestigious scientific journal JK Science. His commitment to the field of pediatric surgery is reflected in his extensive clinical practice and numerous scientific contributions. Welcome, sir.
It's an honor to felicitate the pillar of the strength of our hospital, our worthy Executive Director and CEO, Dr. Shakti Gupta sir, for his immeasurable contribution in the field of medicine and especially for laying the foundation of this hospital. I will invite Dr. Lucky Gupta to speak a few words.
Good afternoon, sir. Professor Dr. Shakti Kumar Gupta is an alumnus of the Government Medical College Jammu, from where he did his MBBS, and AIMS New Delhi, from where he obtained his Masters in Hospital Administration. He headed the Department of Hospital Administration at AIMS and mentored more than 45 postgraduates and PhD students, conducted 112 research studies, published more than 110 research papers, published in several national and international journals of repute. He has also been the principal investigator of WHO projects on public hospital governance, AIMS a case study, national consultation on PPP, and electronic medical records. The Department of Hospital Administration under his leadership had the honor of being the first department of AIMS to receive ISO certification. He has authored 11 books on various aspects of the hospital administration. Sir is fellow of NAMS, International Medical Sciences Academy, Academy of Hospital Administration, and Institute of Hospital Engineering. He has been the recipient of the WHO Fellowship to study accident and emergency services at USA and Management Development Program of National University Singapore. He has also been the program director for various healthcare capacity building programs like Healthcare Executive Management Development Program for senior healthcare professionals in collaboration with WHO, National Initiative for Patient Safety, and Best Procurement Practices for Hospitals. Dr. Gupta has been nominated member of Expert Committee of National Human Rights Commission. He has also been the chairman of the Expert Committee for Formulation of National Ambulance Code. Sir is the founder president of Research Foundation of Hospital and Healthcare Administration, a leading organization promoting research and training in hospital and healthcare management. President of the Academy of the Hospital Administration, editor of Journal Academy of Hospital Administration, and editor-in-chief of International Journal of RFHHA since 2012. He is also been the founder-president of EMS Leaders Forum for providing a common platform for convergence of the global think tank in the field of EMS. He was elected as member of the Advisory Board of Center for Health System Innovation and Entrepreneurship, Oklahoma State University, USA. He is expert consultant of Ministry of External Affairs for establishing 2 hospitals in Bhutan and trauma center in Nepal. The projects of the Bhutan and Nepal have actually translated into tertiary healthcare facilities. Sir has also been the consultant of UNOPS Asia Office. Dr. Gupta has been honored with numerous national and international awards, which include Capital Foundation National Award, Times Healthcare Achievers Award, Pratibhashi Saman 2002, Chikitsa Ratan 2010, and Shram Shri 2010. Bestowed with the International Partner of the Year Award by the University of Germany and was confirmed the State Award by JNP government. Welcome, sir. Thank you.
I would request resident dignitaries to please have a seat. I would like to invite Dr. D.K. Gupta, sir, the founding member of RIPSS, to please address the audience for a few minutes.
Good afternoon, everybody. Honorable Director, Dr. Shakti Gupta, President IAPS, Dr. Sumitra Kumar Biswas, Chairperson of RIPSS, Dr. Shilpa Sharma, Dr. Nisar Bhatt, Dr. H.P.S. Meglani, incoming President, Dr. Prabodh Goyal, incoming Chairperson for RIPSS, the Hospital Administrator, Dr. Sunil Kant, Lieutenant General Sunil Kant, Medical Superintendent of this hospital institute, students, nursing group, and staff members. It's in fact a pleasure. It was a surprise visit for me, just decided 3-4 days back only. And it came out to be a lifetime experience, how a budding institution is being administered, managed, supervised, and seeing the progress. I am very much impressed, Dr. Shakti Gupta, with your contributions and planning. It's really alarming as well as a path breaker to all other administrators involved presently in the institutions. For any institution, 3 things are important: patient care, education, and research. And for all these, you need the staff, the space, and the equipments. No institution is built with bricks, mortars, and buildings. This is the conduct, character, contributions by its staff. And ultimately it comes down that what is the quality of the staff of any institution. If the administration has selected a good and committed staff who really own the institution, the future of the institution is bright. And if in the beginning you have really done mistake, and then the whole institution is ruined. So my dear friends, ladies and gentlemen, the onus of the progress of this institution lies on your shoulders. You have to own the institution and contribute to your best. You have always to think what you can contribute to the institution and not what institution can contribute or can give to you. So I think, as Dr. Shakti has already pointed out, you have no working hours. You have to think, sleep, dream, eat, everything with this institution, right from morning to late night, and that is what your commitment to build this institution is. About the research, I think this was also very well pointed out that in our setup, patient care is the top priority. You have to take care of the patient as your gods. If they are satisfied, your institution is good. If you think that your research and education get the priority and patient care is neglected, this is not true for our country. Our country, patient care number one, medical education number two, and research comes third. Research is equally important. For any institution, it is the research that puts your institution at the national and international level. And so also the publications. So for any institution worth in the medical education to have its name and fame, you have to contribute in the field of research. So next point I would like to emphasize, it's the communication with the patients and the parents. Dr. Shakti will remember, we had very close association at that time. On 8th floor, we had the operation theaters in the main institute building in New Delhi, but there was no room where the attendants could be called. They could be told that yes, your child or your patient is operated. This is the finding. This is what it is. How is it? I mean, for this single word, I had to request Dr. P.K. Dave and Dr. S.K. Kakkar to give us a small place. No room was available, nothing was given. I created a place next to the stairs, if you remember, Dr. Shakti. It was a small cubicle, 8 by 10 feet, and I just got some wooden partition done and put somebody there. Okay, all right, if this child is operated, call the attendants. There was a telephone, and you just spend only 20 seconds. Yes, your child is operated, everything is okay, and they are happy. So instead of anybody else giving this message, if the chief surgeon gives this message, I think you have done your job in the best interest of the patient and the attendants to satisfy them. Simple things, and I'm sure Dr. Shakti has such a vast experience in administration. He's taking care of all these things. I have noted it, whether it is the guest house, whether it is the institute, whether it is the management. We all noted that there was some hiccup in the audio system in this auditorium, beautiful auditorium. He already pointed out before I could tell him that yes, something needs to be done. There is a system, but whether the operator needs to be told or whether the system needs to be checked. And there are many things which really come with the experience. But yes, all these things depend on how is your administrator, who takes care of all these things. Minor points, but they result into a major development. So with these things, I once again thank you very much, and I have come to this institute to learn much more. I might have faced the same situation in 3 institutions, in Delhi, in KGMU, in Noida, and then in academy as well, National Academy. But after coming to this place, I think I'm learning quite a lot, and how you are facing all these challenges for a betterment of this institute. And that is how I wish to compliment you. I wish you the best for future, and I'm sure that with your leadership and with your proper planning, this institution has a great future. With these words, thank you very much.
Thank you, sir, for your kind and encouraging words. I would like to call upon the dais Dr. Professor H.L. Goswami, sir, to speak a few words.
Dignitaries on the dais, distinguished delegates, fellow students, ladies and gentlemen. I'm indeed humbled and honored by this honor being given to me. And I think for that I'm grateful to the people who guided me, who helped me, like my teachers, my family, who tolerated me, and my colleagues for going through this milestone. Well, when I look at the pediatric surgery family today, it reminds me of the day I joined the Department of Pediatric Surgery in our Institute. I was the last general surgery postgraduate of Professor Upadhyay, and the unit had two consultants, Professor Upadhyay and Mrs. Rothke, one senior resident, and three rotating general surgery postgraduates. On any national platform, you could hear only four names: Professor Upadhyay, Professor Pathak, Professor Subir Chatterjee, and Professor Gandhi. And I think it's the day to remember them for the contribution they made for this specialty. I'm once again thankful to the organizers for honoring me today. Thank you.
Thank you so much, sir, for your kind words. I would like to call upon the dais Dr. Professor Yogeshwar Mengi to please speak a few words of wisdom.
Thank you. Good afternoon to all. I am really very grateful to the RIPSS Society Organizing Committee for inviting me. I feel very humbled and very grateful to all of you for having me here. I did my MCH pediatric surgery from Chandigarh in year 1980. After that I came to GMC, Jammu, and we were only two pediatric surgeons at that time. We worked under the Department of General Surgery. The only regret in my life has been that we tried hard to establish identity for pediatric surgery in our region, but we failed and continued to work under the General Surgery Department. But now, today I am feeling quite satisfied. I see there is a very bright future for pediatric surgery in our region. It has come up very nicely. I noticed the number of members in the J&K Pediatric Surgeon Society. It is all more than 40 now. And compared to just two pediatric surgeons in 1980, I see a very bright future now for pediatric surgery in Jammu region, and I wish them all the success and a very bright future. Thank you.
Thank you so much for the lovely words, sir. Now I would like to invite our senior pediatric surgeon, Dr. Naseeb Chand Digra, sir, to share his wisdom with our audience.
Good afternoon, everybody. Dignitaries on and off the dais, ladies and gentlemen. Pediatric surgery has made great strides in the last few decades. When we were students in late 1980s, we were just being trained as general pediatric surgeons. There was no subspecialties of pediatric surgery as we see today, like pediatric neurosurgery, cardiothoracic surgery, and others. And another area which we didn't witness at that time, and we witnessed as a general surgeon only, that is minimal access surgery, which is now an established entity even in pediatric surgery. Pediatric surgery has been revolutionized not only by technology, but also by research, especially genomics. Now all disease, we have to go to the root of congenital disease or even malignancies as genomics. But I put a word of warning that prenatal diagnosis is putting a new entity in our specialty, which is in jeopardy, that is unborn patient. I think in last 3 years, I have not seen any patient with neural tube defects and hydrocephalus. Maybe the same experience is with other colleagues, senior and juniors. And the reason which I attribute to this is antenatal screening, and most of the unborn patients are being lost, and this can happen with other anomalies also. Another thing which I want to highlight is the research which is being done under the aegis of RIPSS and other organizations. India has been the cradle of, I think, science and innovations. Our ancestors, I'm going to quote 3. One is Charka, Mahabhadyacharya Charka. Few days back, American Heart Association has put a advisory that food is a medicine. But this was around 3,000 years back that Mahabhadyacharya Charka has said food is the best medicine. And another person who was the first one to diagnose malnutrition, Jivak Bhattacharya. I think those people who are familiar with Ayurvedic medicine, they must be knowing that pediatrics in Ayurveda is called Kumar Bharatya Sastra. This man was the one who has devised surgery for malnutrition. And secondly, this man, as I was going through the history of ancient surgery, they say he used to have something in his hand which has a torch on its end, and he was diagnosing the disease in the abdomen, which I presume he must be having an ultrasound, or he was having a stethoscope. Another thing which goes to this man, Jivak Bhattacharya, is he said, everything which is available on earth is a medicine. I think we correlate all the factual things which are happening today. I think food is a medicine if taken in a proper way, moderation. So, in the end, I think I am grateful, thankful, and obliged to the administration of AIIMS, Jammu, the office bearers of JKIAPS, and the organizers of RIPSS 2024, who has honored us. And I'm double honored because I'm honored with my teachers, my senior colleagues, whose blessings have always been with us. I'm going to put one thing which I think Professor Goswami Saab and Dr. Mengi Saab have given me, and that is the art of writing papers. They were persistent that we should write papers. And I think whenever we say writing a paper or organizing a project, we say 3 M's: man, material, and money. But I put 2 M's more. One is a scientific mind. If you have all 3 M's together, but you don't have a scientific mind, I think you cannot do innovation or research. And most important thing, lastly, is motivation. And this motivation for scientific mind has to come from your colleagues, your teachers, your mentors, and as I think Dr. Gupta has said, even from your family. So I was seeing an exhaustive program which Professor Sakti has put in. I think such exhaustive program is okay, but if you want to maintain a family life, I think it is very difficult. But I think he has done a collateral, I think, thinking also. He has put all the facilities for recreation and other things in the hospital or in the institution complex itself. Thank you very much.
Thank you so much, sir, for the encouraging words. Now I invite our worthy Director, sir, and CEO, Dr. Shakti Gupta, sir, to speak a few words.
My respected senior teachers, my colleagues, I extend an open invitation to all our senior teachers from J&K, from SKIP Srinagar, from outside Jammu, that AIIMS Jammu is a very young institute. It is a budding institute. Our faculty is quite young. They need your guidance, they need your blessings, they need your enrolling.
So like I have said that we have started inviting our senior faculty from across the country and other countries also to come to AIMS, spend time and guide to our faculty, students, resident doctors and nursing staff also. I am giving example that we had invited Professor R.K. Arya, who was head of Department of Pathology in AIMS Jammu. He came here, he is about 87, when I requested him to come and spend time with our students. And he had a very good interaction for a week with the students, with the resident doctors separately, with the faculty separately. Then he has given a lot of suggestions how we can take Department of Pathology to the next level. Similarly, I had also invited Professor Arun Sharma. He had come here actually, he had interacted with our faculty, and we had one talk also actually which was recorded and it is available on YouTube also. Similarly, actually, we invited Professor Bhagwati from New York. He is a professor of neurosciences. Now, after visiting Jammu, actually, he started something new, this teaching while walking with the students in the campus. That was very interesting actually, and after visiting the campus, he has decided that every year I like to spend 2 to 3 months in Jammu with the students, with the faculty, and help you, guide you in developing this institute. Similarly, we are getting regular 8 to 10 faculty from Monash University, Australia. They come every year in the month of February, March. They spend a week over here with us, and faculty from UK also. And we are working on different areas in research activities also. And similarly, actually, a large number of our doctors of Indian origin who are working abroad for last 30, 40 years, they keep on visiting to us, guiding us actually. Now they are also actually, I have also extended an invitation to them to come over here and work with us and guide us so that this institute is taken to the next level. So myself open invitation to everybody actually. You are welcome to come. I'll send actually the informal invitation also to invite you actually. If you want to spend a week, 10 days with us and guide our faculty, students, nurses and others also. Thank you so much, sir. Thank you.
Thank you so much, sir. Taking few minutes of all before we break for the lunch, we shall now start the RIPSS Fellowship 2024. For this, I would like to invite Dr. Sumitra Kumar Biswas, President IAPS, Professor Dr. Shilpa Sharma, Chairman RIPSS, Professor Pediatric Surgery, AIMS New Delhi. I would like all the fellows to kindly come near the stage, please. May we have the presentation, please? No, sir, you have to, sir. On the left side, okay. Sure. We'll start with Dr. Archika Gupta, ma'am. Can you please come on the stage, please, ma'am? May we have a round of applause? Requesting Dr. Sumitra, sir, and Dr. Shilpa, ma'am, to come in front of the stage, please, ma'am. We can use this left side of the stage for this purpose. Thank you so much. Dr. Vijay Datta Upadhyay. Dr. Vijay Kundal. Dr. Lucky Gupta. Now I request Dr. Sumitra sir to kindly present it to Dr. Shilpa ma'am. Thank you so much, sir. Thank you so much, ma'am. We have 5 more names. Dr. Subramanya, Dr. Roshan Chanchani, Dr. Sunita Singh, Dr. Gurmeet Singh and Dr. Piyush Kumar. Yes. Now I'd like to request all the dignitaries to kindly come up for the group photograph, please. Ma'am is requesting all the delegates to come up for the group photograph, please. I would now like to request Dr. Vijay Kundal to kindly present vote of thanks, please.
So on behalf of the organizing committee, it is my honor and privilege to extend a heartfelt vote of thanks to all those who have contributed to the success of this conference. The event is particularly special for me as it has always been envisioned the growth of pediatric surgery in Jammu. So first and foremost, I would like to deeply give gratitude to our esteemed chief guest, Dr. Sumitra Vishwas sir, Shilpa ma'am, Dr. Nisar Bhatt. Special thanks to D.K. Gupta sir, Niglani sir, Goswami sir, Yogeshwar Mangi sir, Naseeb sir, and heartfelt thanks to our director sir. And we deeply appreciate Sunil Khan sir, Dr. Meeta Gupta, Dr. Saurabh Gupta, Dr. Lalit Angurana sir, and Colonel Sanjay Garg sir. A special note of appreciation to our sponsor Medtronic, Nazim Bhai, Johnson Johnson, SR Technomed Park for their generous support in making this event a reality. To our dedicated organizing team and volunteers, your meticulous planning and tireless efforts ensure the success of this event. A special mention of Dr. Lucky and Dr. Akshat, who has been a great pillar of support and strength for us. Lastly, my extend to gratitude to IT team, venue staff, technical and catering team for ensuring smooth operations. So let us carry forward the knowledge and connections we have gained here. Let us remember the impact of our efforts that can have on the lives of children. Together we can shape a healthier future for them. Lastly, thank you Dr. Raksha, my wife, anesthetist, my better half, for bearing me all these years. Thank you once again for all your support and participation. We look forward to see you in different future events. Thank you. We can move to the lunch now. Extremely sorry for the delay in the lunch, but
एक और लाभ की लाभ की करना है
Sunny, take that for the teacher.
इधर है ही नहीं कोई फ्री ही है जी
कहाँ पे लगवा रहे हैं? यूट्यूब पे? क्या मतलब किसमें आ रहे हैं? क्या नाम से? नहीं उसमें नहीं है, वो तो मैं उसमें ज्वाइन उसमें लिंक है। चलो आते हैं ना, बताना, हम बहुत सामने बैठे हैं, ठीक है।
Good afternoon, everyone. I hope all of you have enjoyed your lunch. So after that delicious feast, let's start with the academic feast. This will be the third session of the day. The chairpersons for the session are Professor Archana Puri, Professor and Head Department of Pediatric Surgery, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Dr. Hamid Wani, Assistant Professor, Department of General Surgery, Government Medical College, Jammu. Dr. Anant Pandey, Additional Professor, Department of Pediatric Surgery, King George Medical University, Lucknow. May I request all the chairpersons to please come on the stage. The speakers for the session will be Professor Sanjay Kumar Bhasin and Professor Nisar Ahmed Bhatt. We now hand over the mic to chairpersons for further proceedings.
Good afternoon, chairpersons, esteemed faculty, delegates from AIIMS Jammu and across the country. At the outset, I congratulate Vijay team, who has organized a wonderful event. First event on the platform of pediatric surgery in AIIMS Vijaypur, which is in the stage of its inceptions and slowly growing as a good center under dynamic leadership of Professor Shakti Gupta. About 3 days back, Vijay rang me up and he said that, sir, you have to come and you have to participate in the conference. I said, okay, I'll try. Then he said, you have to present and you choose your topic. I said, you choose the topic, I'll present it. He chose a topic which is must for surgeons from every specialty. Surgeon as a epicenter of the stage and all the specialties, subspecialties. And the topic was dear to me, and I wanted to dwell upon this topic many times in the past, but because of my surgical, academic research and administrative commitments, I could not dwell upon. So thank you, Vijay, for giving me this topic, and I am proud that you are my student. Minimizing surgical errors, surgical checklist and protocols. As a surgeon, we must know this. This is a very, very grey area, and in more than 25 years of my active surgical practice, at least I could not practically implement this very vital area of surgical management, you can say. So I shall be dealing with minimizing surgical errors, surgical checklist and protocols. A little historical perspective. This slide I'm just showing that how my great nation has contributed to the medical sciences, including the surgical sciences. Right from the ancient to the modernity, India has a great role in medical sciences. Furthermore, if you go into the history of medical sciences, you see that physicians were in the lead role. But over a period of time, over the centuries, surgeons overtook the lead. And they become the main leaders in medical sciences. Who's a surgeon basically? Ancient books writes that anybody who has ever staunched a wound is a surgeon. And there is a definition of a good surgeon given by none other than Maharishi Sushruta. And by his definition, presence of mind and courage is number one quality, a hand free from perspirations, tremors, and less grip of sharp and good instruments. Operates to the success and advantages of patient who has entrusted his life to him for surgery. And the surgeon should respect the absolute surrender of the patient. Patient has given his whole body to the surgeon, and death and life is in the hands of surgeon. So surgeon must treat his patient as his blood relative, and more so as a human side, as his son. Ancient surgery, if we further probe into, it is based on mythology, clubbed with religious rituals and superstitions. And witchcraft and crude surgery used to be the hallmark of surgery in the ancient times. There were challenges with the ancient surgeons. Infection, blood loss, pain control, influence of clergies, the religious superstitions, the persecution of medical persons, minimal knowledge of anatomy and physiology, minimal, there was hardly any difference between who's a trained and who's an untrained surgeon or medico. And there was difficulty for internal surgeries whenever you have to explore any cavity. The mortality associated with surgery, this is the area, this is the epicenter of my talk. Why? What is the rationale of choosing this topic? In ancient times, there were 3 parameters of mortality: the pain, the bleeding, and the infection. Over a period of time, the reasons of these 3 things, they were added to cause of mortality, and that is hypothermia, metabolic acidosis, coagulability, hypotension, and hypocalcemia. If we go further into the historical context of surgical safety, over a period of time, there was a firm opinion that you don't have to do surgery for the purpose of surgery only. There should be safety of the patient, which is of paramount importance. Morbidity and mortality should be minimum possible. So, when we go into the history, early surgical practices, there was lack of knowledge about germs and sanitation. And there were so many other loopholes. Then 1846, 1860, these were the 2 years which almost revolutionized the surgical specialty, and that was introduction of anesthesia and introduction of antibiotics. Furthermore, in the initial stage of 20th century, there began understanding importance of surgical management as a whole. And when we talk of surgical management as a whole, preoperative, intraoperative, and postoperative management must be clearly defined. So there started a debate how to make pre, intra, and postoperative surgical management much better to decrease morbidity and mortality. Continuing with this phase, 1980s and around, so many organizations started questioning what surgery is not surgery only. What about morbidity and mortality? So they started playing their role as impetus to further look into the safety aspects of surgery. Then in 2000, there came a strong strategy how to minimize the surgical morbidities and mortalities. And then started coming the checklists, which I am going to deal, in fact. Then 2010, concept of safe surgery, save lives came into existence, and it was given an impetus by WHO. 2015, there emerged a sense of teamwork amongst the surgeons because of so many reasons. So, for better surgical outcomes, a concept of teamwork, surgical teamwork, as well as communication, coordination between the surgical team, anesthesia team, and all other surrounding people. And 2020 and onwards, in last 4 years, we have seen so much integration of the technology, be it robotics, be it telemedicine, and now artificial intelligence, which is under lot of debate amongst the medical and surgical communities. Now comes up things proper. Why minimizing surgical errors? What is a rational? So this is a rational. This is established that now, since last 1.5 century, it is established that organized surgical care has been an essential component of medical healthcare worldwide that can alleviate disability and reduce the risk of death from the common conditions, number one. Number two, estimated 234 million operations world over are performed every year. So, surgery and surgical management, it has become part of global health care. Then, while surgical procedures intend to save lives, unsafe surgical care can cause substantial harm with significant implications. Implications are social, they are administrative, they are legal, they are ethical. So there is a reported crude mortality rate after major surgery from anything from 0.5 to 5%, and that may go up to almost 10% in least developed countries. Complication after inpatient operations can occur even up to the tune of 25%. Almost 50% of surgical harms, they are considered to be preventable. Mortality from general anesthesia alone is reported to be as high as 1 in 150 in some part of world, especially in underdeveloped countries. Infection and post-operative complications, there are other concerns. And one more thing, wrong site surgery has exponential high rate, even in countries like US, United States, which is the most developed country, and keeping foreign bodies inside the operative site, it is also appreciably high. I am not talking, it is not my mouth which is talking, it is systematic review which is talking of these things. And here comes a rationale of discussing minimizing surgical errors. So these are the risks. Consumer Protection Act, it's a separate subject in itself, but it is in the epicenter of everything. Developments, more and more awareness amongst the community. Risks are surgical deaths due to advertent or inadvertent errors, leading to legal adverse issues, further leading to compensations and reputations. And if you teach your students wrongly, it is going to influence teaching training system, and there will be gaps which are very difficult to bridge. Sound is not here. So remedy is this surgical safety checklist. What happened? Around 2004, there came one surgical specialty checklist based on universal protocols, and there were 3 components of that. That is wrong site, wrong operation, wrong surgery on wrong patient. These were 3 components, but they were not accepted universally. They remained restricted up to only a small part of globe. Then another checklist came into existence, that was SURPASS, Surgical Patient Safety System. It is a very elaborate checklist. It starts from admission and it goes right up to your discharge and follow-up. And there are so many lacunas in, though it is an extensive checklist, but there are inbuilt lacunas with this surgical checklist, like pulse oximeter role, like intubation difficulties, like blood transfusion roles, complications, teamwork. They were all lacking in this SURPASS checklist, which came into existence in 2006. During the same period, 2004, WHO started working on this meticulously and deeply, and after 5 years, they came up with their checklist in 2009, WHO Surgical Safety Checklist, and this is, though not widely accepted, but it is the best surgical checklist available. Yes. So in WHO came up with a comprehensive, simple surgical safety checklist, and these were the initial objectives. Very important. I wanted that few PGs or some other doctor should be available in the hall, but no issues. The team will operate on the correct patient at correct site was the number one objective. It will use methods known to prevent harm from administration of anesthesia while protecting the patient from pain. The team will recognize and effectively prepare for life-threatening loss of airway or respiratory functions. It will recognize and effectively prepare for risk of high blood loss. The team will avoid inducing an allergic or adverse drug reactions for which the patient is known to be at significant risk. The team will consistently use methods known to minimize the risk for surgical site infections. It will prevent inadvertent retention of instruments and sponges in the surgical wounds. The team will secure and accurately identify all surgical specimens. It will effectively communicate and exchange critical information for the safe conduct of operations. And then the hospital and public health system will establish routine surveillance of surgical capacity, volume and results. These were the objectives, and on the basis of these objectives, surgical checklist was devised, and role of surgical checklist was fourfold: safe delivery of anesthesia, prophylaxis against infection, effective teamwork, and other essential practices in surgery. Three elements of surgical checklist are sign in, time out, sign out. These are very important, and these are the essence of WHO surgical checklist. I'll skip the text, I'll directly go to the video, and you yourself see how important and how this surgical checklist is to be. It's only 3 minutes video, but it is very important. You must all see this. So this is the WHO checklist performer.
Hello, I'm Anna. I'm the nurse in theatre today. How are you?
I'm fine.
Okay. Could you just tell me your name and date of birth, please?
Jermaina Davidson.
Okay.
12637.
Okay. And your hospital number is correct. What operation are you having done today? Gallstones. Okay, so that's the consent form. I just need to check that you've signed it.
Yeah.
And that's your signature. And you're happy with everything?
Yes.
Okay, that's fine. And the surgical side is not marked because it's not applicable with this one. Are you happy with machines inside and here?
Yes, machines are checked inside.
The drugs?
All the drugs ready?
Okay, are you allergic to anything?
No.
Okay, and difficult airway aspiration risk?
Not anticipated, no.
Okay, any blood loss expected?
Little.
Okay. So we're just going to go ahead now.
Thank you.
This was signing. Next is the time.
Ready for timeout? Okay.
Can everyone introduce themselves by name and role?
Mark Kenny, consultant anaesthetist.
Samuel Shaw, circulation.
Paul Ziprin, consultant surgeon. George Peach, surgical secretary.
Angela Zupan, circulation nurse.
Natalie Pedas, scrub nurse.
Andre Carroll, surgical registrar.
Anna, anesthetic nurse.
Okay, what's the patient's name, procedure, and size?
Janina Davidson, thoracic cholecystectomy. Her main tags have already been checked.
Okay, any expected blood loss?
Minimal.
Specific requirements?
Laparoscopic cholecystectomy, which has been checked already.
Okay, and critical steps?
Possibility for conversion to open surgery.
Any specific concerns? Mistakes?
No.
ASA?
2.
Laboratory equipment?
All present.
Okay, is it sterility checked?
Yeah.
Any equipment issues?
And what percentage of laparoscopic equipment would you be requiring anything extra?
Well, we have the open set on standby.
Antibiotics?
1.2 grams of maintenance in the patient.
Warming?
Okay.
Hair removal?
Not required.
Glycemic control?
Not indicated.
DVT prophylaxis?
Test stockings is standard.
Imaging display?
Not required.
Now is the sign out.
We're ready for sign out.
Okay. What's the name of the procedure?
Laparoscopic cholecystectomy.
Count's correct? Count's correct. In the specimen, it's labeled Janina Davidson gallbladder.
Yes, that's correct.
And any equipment problems?
No.
And key concerns for recovery?
No special concerns.
Thanks.
So this is a checklist. I'll make the checklist available to all the surgical specialties in AIMS. At least you are in the inception of your career and institute's career. You must try and benefits, improved patient safety, reduction in surgical errors, enhanced team communication, evidence from case studies says this all, and standardization of surgical procedures. Outcome associated with marked improvement in surgical outcomes. Post-operative complication rate fall by 36%. Death rate fall by a similar amount. Improves overall safety of surgical patients in diverse clinical and economic conditions. But there are certain challenges. Only 3-4 slides are there. It was very important. I am rushing. In spite of that, I am rushing. Challenges in implementation. I think what I have observed in so many institutions, hardly 2 to 3% institutions in whole of the country, they have adopted it and they are practicing it. This is the core of your surgical practice. So you must know everything. You must know this thing and you must implement. Challenges in implementation. Despite the benefits, challenges exist in implementing. Number 1, resistance to the change. Resistance to the change. Inadequate training. Study biases, which I have told. Region to region, ethnic group to ethnic group, administrative setup to administrative setup. Addressing these barriers is essential for fostering an environment that prioritizes patient. Effective implementation, you can read future directions. The future of surgical management lies in innovations and technologies. Integrating digital tools and data analytics can enhance the effectiveness of the checklists and protocols, leading to even greater improvement in surgical outcomes and patient care. Conclusion. Before conclusion, I again give one statement. If I have to teach surgical checklist to my students, I will take 3 classes, 1 hour each class. It is so important, but unfortunately, even after almost 2.5 decades of my surgical career, I could not implement it. History of surgery dates back to antiquity. There has been laws and codes regulating medical and surgical practices in different civilizations, and they define the growth and progress of profession. Surgical checklists such as WHO, safety checklists and surpass checklists offer a promising intervention for decreasing patient morbidity and mortality due to surgical operations. WHO checklist is simple, inexpensive, readily available tool which reduces complications and mortality related to surgery, should be introduced in hospitals. To implement checklist, administrative will and surgical leaders' desire and acumen is must. We are the surgical leaders. Our desire and acumen, will is must to implement this checklist. And more so when society is well versed with everything and CPA also. I give some statements after every talk. The biggest challenge to moving towards a safer health system is challenging the culture from one of the blaming individuals for errors to one in which errors are treated not as personal failures but as opportunities to improve the system and prevent harm. To err is human, to cover up is forgivable, and to fail to learn is inexcusable. I would much rather see responsibilities exercised by individuals than have them imposed by the government. I would love to be first one to say this, but it is automatically turns into we all have those responsibilities that we ignore because we don't feel like they are ours. And take home, learn from the mistakes of others. Since antiquity till modernity, till so many centuries, we'll go on learning. But learn from the mistakes of others. You can't live long enough to make them yourself, all yourself. And the illiterates of 21st century will not be those who cannot read and write, but those who cannot learn unlearn and relearn. Thank you very much, Vijay. Thank you for inviting me. Thank you, chairpersons, for tolerating me. It's a board talk without any videos, without surgical this and that, but it is must. Thank you very much.
Dr. Sanjay, it was a very interesting talk, but I would just like to ask one quick question. In your experience, you have not been able to implement, so would you leave some guidelines for us in hindsight, which we can apply? Because all of us are attaching this checklist in our files, but unfortunately, as you were saying, ground zero implementation is not there. So what would be your guide to us? 3 tips.
My another one-line introduction is that I remained president of J&K State Chapter of Association of Surgeons of India for quite a long time. Now I am National General Council Executive Member, and we have already developed upon this thing, Association of Surgeons of India. We are on the job, and probably another 2 or 3 years, we may come up with a comprehensive, practically applicable surgical checklist for Surgeons of India. Thank you very much.
Checklist is quite comprehensive.
Checklist is comprehensive WHO checklist, but government as a policy, government of India, or even all the state governments, and we the leaders, we never bothered to read it, its repercussions, and further ask our administrative system that we want to implement this checklist, because there are so many legal issues involved in all these things. So it requires administrative and professional will.
If I commit a mistake outside, I'll be sued. I'll have to pay for it. Here I know it will go, I'll go unescaped, okay? So accountability the first thing, then is the, probably we don't know the legal issues, medical legal issues of this. Once those things will come in accountability, probably all of us will do it. Till then probably will not be possible. Thank you. Yeah, we do it. That's what I'm, because we have no account, suppose
excuse me sir, I think we can discuss it after the session.
Data of mistakes is also available.
Thank you sir.
Thank you, sir. Thank you. Now I request.
I have to leave organizers for some very serious personal issues. I will beg pardon from the organizers and the people sitting here. Thank you very much.
Thank you, sir. Thank you, sir. Now I request Professor Nisar Ahmedra from Skimmers, Kashmir, and he will be talking on innovations in transanal endorectal pull-through. Their experience from Skimmers.
Respected chairpersons, my presentation is technical innovations in transanal endorectal pull-through in Hirschsprung disease. Hirschsprung disease is one of the most common causes of neonatal intestinal obstruction, which is seen in 1 in 5,000 newborns. Various aspects of Hirschsprung disease, starting from the symptoms, evaluation, diagnosis, all of us are well versed with this condition. The treatment options for this disease are well known to all of us, with the conventional multi-stage surgeries, depends upon the time of presentation. And all of us from time to time we have seen the complications of these conventional stage operations. starting from the issues related to the colostomy, it may be a prolapse, maybe the second excretion, and finally leading to the very early abdominal scars. Then there was all these complications. There was a breakthrough in 1980 by So et al., who carried out one primary pull-through without pulmonary colostomy. 10 years later, there was another breakthrough when there was this primary transanal pull-through was done without opening the abdomen. It is a single-stage operation where there is a submucosal dissection from the anal canal. If Professor Gupta remembers, I think in my first year of my MCH in 1990, John Hudson from Australia, he did the first transanal pull-through at AIMS. That child happened to be from Ladakh. He was put on rectal wash for 2 months. But I remember that time he used the endoscope to do the anal transanal dissection. Probably laparoscope was not available that time. So this transanal pull-through, it usually, the basic principle is the same, Savis or Swenson's. Usually people do Savis, but sometimes it becomes difficult and they have to carry on with the Swenson or Dremel. So in this, transanal is usually done when the transition zone is lower down, where we may not use the help of this laparoscope. And in the same disease, we may have to have help from the laparoscope in mobilizing the left colon spleen flexure when the transition zone is higher up. And also it helps us in taking the frozen biopsy. So what are the advantages of this transanal? One is there is no colostomy, it is a single stage procedure, preservation of nerves and vessels, there is no abdominal scar, the procedure is simple, the results are better than the conventional procedure. So in our departmental protocol, all the patients who are diagnosed with Hirschsprung's disease, once these patients are admitted, after the instant resuscitation, we just do the barium enema. If the barium enema is, the transition zone is confirmed on this contrast study, we put this patient on the rectal wash till the age of 3 months, where we decide whether we have to do just laparoscope assisted or simple, transanal. So if it's a short segment, we just do the transanal. But if the the transition zone is not clear, we may have to do sometimes the rectal biopsy. And if there's a doubt, we may have to do the stage colonic biopsy. So inclusion criteria, all the neonates who are diagnosed with the Hirschsprung's disease, except if the patient presents with the perforation of gut, a patient who is not responding to conservative management, patient has a poor weight gain or washes, or there is a massively dilated colon, and of course in total colonic agnosis. So we have total number of patients with the Hirschsprung disease, 91. Out of that, 69 were included in the study. The reason for the other patients who are not, they had, as I already told, they had, peritonitis, they were not responding to the washer, they had a very poor weight gain. So gender disposition was that it was more common in the females, 4:1. The age of the surgery, around 40% of our patients, they are at around age of 3 months, but we had to go around 12 patients in the first month of life. The reason was that these patients had a long segment and they were not responding to the washes. So, a brief about the procedure. These patients are put in the spinal position. This 3-port, we put 3 ports, 5 mm in the umbilicus, 3 mm port in the epigastrum, and another 3 port in the right iliac fossa. This is a small video how we do the laparoscopic assisted immobilization of the colon. These are small babies. Actually, this group of patients where they require this laparoscopic part, they are just within the first 1 month we have to do these cases. And just weight of 5 kg, the small, very small space inside the abdomen, so we have to be very careful. It's very sensitive to just. This is just umbilical board. This is another 3 mm port. This is, you can see that after this you can see yes, the colon. This is the, you can see that colon proximally is massively dilated. Then there is a transition zone, and distally this is the contracted segment, you can see it. So then we start dissecting the mesentery of this. आगे चला इसको थोड़ा, आगे चला इसको. आगे थोड़ा चला. आगे चला. आगे चला. नहीं रहेगा. Anyway, this is the, I just want to show you a little. This dissection is at, or you can see the spleen is there because this patient had a, transition zone at the splenic flexure. Again, I can show you that there is a proximal segment of the bowel is dilated, and we have contracted segment. Then we start the dissecting this mesentery. We make sure that since there is a very little space inside, you don't have to injure the organs around it. As posterior urethra, ureter and then bowel is in the vicinity, so we have to be very careful. It's just 2 minutes. When we start dissecting, once we see this transition, usually we go to 3 to 4 centimeters above this transition zone. We make the first proximal dissection, then we go down to the level of peritoneal reflection. Yes, what do you say? Yes, if we have a doubt, we definitely do it, but to be honest, wherever we have found the transition zone, we carry on with the procedure. And in our series, we never ever had discrepancy between the transition zone and this histopathology. That is actually encouraging. Although in the literature people say that 8% of patients it is not matching. Okay. So you can see whole of the colon now. You see it has been mobilized after the peritoneal reflection. From splenic fracture to the peritoneal reflection, this colon has been over. Anyway. And then these are some static pictures where you can see that these are different patients where you can see that So coming to the perineal part, we put the patient in the supine position. We just do dilatation, the Hager's dilator. Then we put some evating sutures. Then we start our perineal dissection at around 0.5 to 1 centimeter from the dentate line. We lift the mucosa separate from the underlying this muscle, which is around few centimeters. After that, we divide the muscle, go around the rectum, and divide all the these adhesions, and finally we pull down this colon. Here you can see that this patient. Sorry, I have to go back. You can see the clear transition zone and the dilated proximal and the distally contracted segment. This is just half a millimeter. This is how we do. This after we already mobilized the colon by laparoscopy.
Video ready?
But this is how we deliver it out. Okay. Because it was already mobilized. So these are some of the specimens what we have retrieved from this from time to time. Okay. So this is the final anastomosis. So every surgery has its complications, but to be honest, we had minimum possible complications, except 3 complications. In one patient, we had anastomotic dehiscence. This patient was managed with that ileostomy. Later on, we did the dilatation, and we had not to repeat this pull through, and we had to just close and he did that.
Excuse me, sir.
We had 2 patients.
We are running short of time. So
I'm just. This is not actually my talk. I have just 3 slides. This is very important for you. So need for exploration was in the 2 patients, and there is a cough-related issues in another 3 patients. So when I see these complications, it led to the innovations. What I did, actually one of the patients, we found that the patient turned back all the symptoms, but he had a long muscular cough. So just the first innovation was to just leave the small muscular cough. As we had been already taught by our mentor, Professor Gupta, he was all along doing the Swenson's procedure. So then came the, then we had another 3 patients who, in the first 20 to 30 patients, we found even 3 patients that these patients had rolled down this muscular cup around the pull-through colon. Okay, we could feel that very tough, that stricture-like thing. 2 of the patients got, treated by the simple dilatation, and 1 of the patients had a tough cuff. So we had to use the PSRP approach to divide that cuff. But luckily that patient did well post-operatively. Then came that to avoid this cough-related obstruction, then came the another modification. We started, giving a transverse longitudinal slip in the posterior rectal wall. But then another few patients, good number of patients, we found that in the 2nd to 3rd week of life, these patients, they come with the symptoms that patients, they cry during the defecation and they have paste-like stools. Okay. Then usually these patients I put on my own follow-up and I assess them myself. And when I put the finger, what I see that all along the top, I found there is a narrowing. And while putting the finger inside, I could feel some, difficulty and narrowing. But when I put some little force, I found that these edges going, just splitting apart. Okay. So actually, it was the adhesion between this cuff and the pull-through colon. So that helped us. But this group of patients, we put in the regular dilation for 2 months. All of them settled. So then we thought, why to have this complication? So finally, we have come out with the 3rd. Sorry. If I have a picture with me. Yes. So in my 3rd innovation, what I am doing that, I put a V-shaped cuff. V-shaped this cut in the posterior rectal wall. And that avoids all those things, like, that adhesion, then cough-related problems, and till now, rest of the patient, they are doing fine. So this is just a comparison, you can see the that ugly abdominal scar and without scar, and this is the final appearance. So in conclusion, primary pull-through is a feasible and a safe operation with excellent results in neonates and infants with the Hirschsprung disease. Thank you very much.
Any questions from the audience?
Yes, Dr. Gupta, sir. Take a comment.
Chief, certainly in the beginning we use the endoscopes to mobilize the bowel first annually. And pull through. These complications are known ones. First, length should not be more than 10 centimeter. Usually 8 centimeter, 7 centimeter is good enough. Second thing, you have to slit it either interiorly, because posteriorly the vessels are there, so it is safe to anteriorly. It becomes a V shape, and because the proximal bowel is dilated, so it fits very well around it. And then you have few stitches all around the edges of the dilate possible. Pull the valve below, the labral still be inside to check that bowel is not rotated. We had one case like this, but happened only 1 in 200 or so cases, where the bowel got rotated, pretty constipation, and you put the finger, but stool will not come. So we did the barium, it goes in, but barium stayed, so it was very difficult to decide disease or something. But then we suspected possibly a problem. Ganglion cells are present. Some resident, if he was there at that time, I think that shape up. Surgery and child became all right. So these are the 3 main complications what you highlighted. Thank you very much. Excellent results.
Thank you so much, sir. Both the talks were indeed very interesting. I thank our chairpersons, and I request our chairpersons to kindly felicitate our speakers, Professor Dr. Nisar Ahmed Bhatt, sir, Professor Dr. Sanjay Bhasin, sir, had to unfortunately leave, but in spite of the death of his maternal uncle, he kept his promise and came. So I request Dr. Satish Parihar, sir, to kindly collect the memento on his behalf. We thank all our chairpersons for chairing the session and for the smooth conduct of the events. As a token of gratitude, we would like to felicitate our chairpersons. So I request Dr. Vijay Upadhyay, sir, to kindly come up on the stage and felicitate our chairpersons. Professor Dr. Archana Puri ma'am, Dr. Hamid Wani, sir, and Dr. Anand Pani, sir.
second part of this session, may I call upon the stage the chairpersons, Dr. Sandeepika Dogra, Assistant Professor, Department of Anesthesiology, AIMS Vijaypur, Jammu, Dr. Sanjay Raina, Senior Consultant, Pediatric Surgery, GMC Jammu, Dr. Deepak Agarwal, Senior Consultant, Pediatric Surgery, Shri Ram Multi-Specialty Hospital, Haldwani, Uttarakhand. The speakers for the session are Professor Abdul Rashid sir and Dr. Radhika. May I request all the chairpersons to please be seated on the stage. We now pass on the proceedings to the chairperson.
Good afternoon, ladies and gentlemen. Can I call upon Professor Abdul Rashid? Professor Abdul Rashid for his talk on Hypospadias, bridging the gap between research and clinical experience.
Respected chairpersons and the respected audience, very good afternoon. So whatever topic I have been given, I made it just short. I can't call them it's a research or their innovations, because the subject is like that. I think each and every setup in the development of hypospadia surgery has been part of research and innovation. They might be the procedures which are abandoned now, but they have always guided us to come, to develop newer and newer procedures. It's a journey of a late entrant to pediatric surgery and developing interest in the subject. First, I should be thankful to my teachers, particularly Professor S.N. Kuril. And secondly, I should be very thankful to Professor Nisara Mambat, the present head of the Department of Pediatric Surgery. I remember the days when I would not get even an OT to operate in, but he was the person who would take me to his OTs, give me cases, and I would try my hands on them. So in hypospadias, if we say research and innovations, I think the basic and more important research are the subjects which we the pediatric surgeons hardly ever go in. So in basic research, presently in all subjects and similarly in hypospadias, we will have to read about genetics, embryology and development, and more importantly, which is very, I think the latest one, if you have some advancement in tissue engineering to replace the tissues. So our innovations as pediatric surgeons will always be only and only surgical. And those innovations will be, I think, only around these three things. Either you modify a surgical technique, or you think of draining the bladder in a different way. That is what I have seen over the time, people presenting as innovations. Or maybe sometimes that, separate a different type of dressing you use. We have nothing to innovate in surgical, techniques. So the goals are always these five. The first and the foremost I would put is orthoplasty. So I believe if you have a straight penis, wherever the meatus lies, it's always functional. You can nutrate, you can have sex, and if you have a tilted penis, rotated penis, doesn't matter even if you wipe from the meatus, it won't work. So orthoplasty I would put at number one. And second, the most important, which the parents and the surgeons were always interested in showing, is that, okay, this is the meatus at the tip and the child is widening through that, so we do a urethroplasty. And the length of the tube may certainly differ as per the severity of the hypospadias. Then the glanceplasty and meatoplasty would add to the cosmesis of the procedure. and the skin cover many times is very challenging. The ending and in doing a very good urethroplasty, but it takes a long time to cover it correctly, and many times we fail in it. So our journey in the middle, I think in the initial period of our journey, I remember the days when I was in Sher Kashmir Institute of Medical Sciences, and I think the second issue was going to be conducted in London. So I don't know, maybe Professor Gupta was the president or it was the next that. Myself and Professor Nisar decided to go and present in London our experiences with Hypospadias, but unfortunately I couldn't get a visa, and everything was presented by Professor Bhatt. This was the first thing which we thought must be innovative in our minds, that where we presented, that glans is never fused on the ventrum. So why close the glans on the ventrum when it is not naturally closed? It always gaps, and it creates a gap which we try to name as glans, say symphysis glans, because it does work as a symphysis. So how to prove that it works as a symphysis? You can take the example of micturition, you can take the example of ejaculation. It gives you a space, and then even if you do some instrumentation, this is the space that allows you to do all this. So in this case, to prepare this paper for presentation in London, I remember we in Srinagar didn't have the facility to have cadaveric dissections. I traveled to Delhi, spent 5-7 days in Maulana Azad Medical College, and I should be very thankful to Professor Satish Agarwal, who arranged everything and became part of it. Unfortunately, we couldn't publish it so far. That time the only weakness was that we didn't have MRI findings. And very interestingly, just 2 years later, I could find a paper published from Turkey. 100% the content was same, and the present, everything was same. Professor Gupta must be remembering the person, Mr. Hussain. But the only thing he published was our deficiency, what we had presented, that we couldn't do our MRI corroborations with this study. That was the only thing left. So he went to Turkey, did only MRIs, and published a paper. If you go through that, you will see the sentences also are the same. Because I remember when I asked Professor Nizar, Hussain was a judge in that poster presentation, if I am correct. So this was, first thing. And regarding Dr. Agarwal, Delhi, who now works in Gangaram Hospital, he still continues to work with this concept. Almost 99% of his cases, he works, the Hypospadias on, based on the same concept, which he always acknowledges in all the presentations. Although we changed it much, we had some more modifications, in the rest of our life, but he still sticks to that and is creating wonderful results. Second, this was the second presentation in the same sheet, by Professor Bhatt. Single stage repair. Now, why do I mention it here? I remember the days when it was the Snodgrass era, and I was still, learning in my MCH. And we attended the first conference in Indian Institute of Medical Sciences. And our, main stars that time were Mr. Snodgrass, Mr. Braca, and we had on antenatal malformations, Mr. Pena. So it was a wonderful, workshop. Everybody would feel impressed. And it was for rest of the 20 years, rest of the 15, 16 years, and before that, it was all around Warren Snodgrass. You would see all chapters written in the books by Warren Snodgrass. You would see all workshops being conducted by Mr. Snodgrass. So now I have a recent experience. जैसे मैंने कई बार बोला, ये मेरी आदत है, आपको अगर देखना है कि भाई कौन क्या करता है, दूर से भरोसा मत करो, घर में घुस के देख लो. What is he really doing? So I always try to, see if you see very good results being produced somewhere. It's always good to go and spend some time. I got a chance to visit your Mr. Sonograph last year. Very interesting. So if you go through that, in those 10-15 years, I would see a publication. And next year, I would see the same publication being refuted after 3-4 years by the same sonograph. And sometimes he would write, I was quite impressed by Mr. Anil Albert. And now I am doing, an extended urethroplasty. And then after 4 or 5 years, you will say, no, absolutely, you should never do it. Last year, what I could see is that SETAC and STAG is rampant in the center. It's a place, a very small hospital, 2 people operating, no admissions ever. At 4 o'clock, the hospital, I'm sorry, I'm not opposing anybody. This is an encouragement for all of us. How do you become stars? It's a very small hospital. So the hospital closes at 4 o'clock, nobody there. 2 cars, 3 cars, they're outside that. And the 2 people leave in the evening with 3 or 4 patients operated who come across the world, paying huge amounts. And if you see the procedures now you don't see that typical tip. You don't see extended tip. And you see stag and stag. So what you see now is, for example, if the patient is, all of you might have gone through those papers. If you see now, you see, rather sometimes it is, you get frustrated. You have to correct the curvature, ventral curvature. You see multiple incisions being given, and the penis just hangs, like this. It becomes such a lazy tissue. And then you get diatos tissue wrapped around it, sickened around it, and the patient goes home. Patient comes after 5-6 months, then the second stage is done, then the third stage is done. So all that first stage has now changed into typical 3 stages. So इसीलिए अगर हम कहीं किसी भी से सुन भी लेते हैं, please जाइए और देखिए कोई झूठ बोल रहा है सच बोल रहा है. Till then I think we should not believe. This is what I could observe. So I too was impressed. With Dr. Bhatt and other people, other colleagues, we started doing single stage repairs and presented. And we presented them really with excellent results. That time, I could feel that they were good results, till we found some complications which stops us from doing that. So this was the presentation which was done there. I presented it in Agra also. It was a prize-winning, presentation that time, which is no more relevant. But if you see this, everything looks wonderful. Very good, where we basically impressed more on spongioplasty. How does it, help us in gaining the length and gaining a very good cosmesis. And we also discussed, I'm going quickly through the slides. We also discussed in this procedure the geometrical aspects. How is it helpful? And how to mobilize corpus spongiosum and do a very good, I'm sorry, I think it is repeated, but it will end somewhere. Okay. Third presentation that was done, this was our initial periods, but still very good. We were happy with this. We would feel if we cannot do, there's a picture, this one. Suppose you have a case like this and we cannot do sonographs, what should we do? We were confused. So we went through the literature, I remember. I was very much impressed with Barcut procedure. Nobody was ever mentioning it. So I thought it's a very good procedure, why shouldn't we do it? And then modified Barcut was done, I don't remember the people, I think Rama Jayanti was one of them. So we thought, no, Barcut is a very, when to choose, when should do a sonographs and when should we do a Barcut procedure. If you see the dissection and the procedure we did, the Barcuts, wonderful, very nice, everything looking so good, and a wonderful cosmesis. But we could see even so nicely done procedures, why you would never feel that something would happen. They would develop fistulas, they would develop retractions, and they would develop cystinosis. And now, a lot of time has passed now. Here is one person in the other corner of the world, Mr. Hadidi. Last time he was with, in AIMS for I think for a few days. It was a beautiful workshop. So we used to go through it and we would hardly even understand what he's doing.
Professor Rashid, sorry for interruption, but
I have to go quick?
Yeah.
Sorry. So these are the last slides. So again we thought of why should we modify the same labo and do all sorts of procedures, because there is a scope. There is a scope of doing it. If you see this picture now there, it is a sort of labo dissection where you are using the lateral flap to use it at only. But if you have to do a single stage procedure in a severe hypospadias, you can do even a single stage procedure. I will show you just a few slides and go. So this is the labo. If you see one picture on the left top, even if you have to do a prepucioplasty in a patient, it becomes very easy. You have to just leave it there. And Mr. Hadidi, what he does, he always does not, he never does a circumcision. He does it on demand if some patient comes back. Now, for example, this patient, what would one imagine? You would always think of stages and multiple stages and what the result would be. Here is the end. This is a two-stage procedure. We call it as dysprox. But whenever we think of, this means distal first approach proximal hypospadias. It's a severe hypospadias with severe coding. But we ended in doing a very good urethroplasty, completing the whole distal urethroplasty and just leaving a fistula proximal to be closed later on. But you could get very good cosmesis. But again, as I said, we think that we have done something, but people have already done it. When I went through the literature, I found a procedure named as Ulaanbaatar. I never understood what it is. Probably it is a space in Mexico. Some people have already done it, but they would not do it to this extent. They will just correct it at the level of the glands, and the rest they would do in the next stage. Now it is a thesis with my DNB resident, how to do Byers flap the same way. Use half of the flap in, repairing the distal half and leave half of the flap to be repaired in the second stage. So then you would modify the labo. Imagine, for example, this case. What would one understand? That we would do so many stages and then we would reach somewhere. Here it is, completed in single stage. Then dressings. Now this is probably the last one. Here, we used to have bulky dressings. We are now often using just, this is cyanoacrylate from Johnson. What's it called? Dermabond Premium. That comes with this net. If you put this net around, apply it, you don't need bulky dressings. We are happy with this. This is another thing which will be very helpful. If you usually try to lateralize your suture line and could bury it on the other side of the glans, so you have good cover. It is never in the midline. So this was another thing which, again, you can call it, it is a mini labo. So it is not a complete labo.
Professor Rashid, I just request.
Thank you. I am finished. Again, this one was done in Lucknow. Again, you can see that, at the end, the last slide, how it was a single stage. And conclusion, we should know the science, but we are the surgeons. We should learn the art. Thank you very much.
Thank you, Professor Rashid, for such a wonderful display of all the slides.
Excuse me?
I said, thank you very much for such a wonderful description.
Thank you.
And we all know that this topic is such a complicated topic and full of complexities and full of complications, but still you try to elaborate everything in detail. Any questions, please, from the audience?
One question, sir. For your experience, what should be done with the glandular type of hypospadia? It should be operated or not?
In my belief, you should never operate it. Never try to go into glandular hypospadias. If you earn a small complication, even a skin breach, and let the child void the two streams, they will be always on your head. So I personally never encourage doing a glandular hypospadias.
Thank you.
I think that is a totally different, we will not go into the psychological, we will go into the thing which relates to you and me. That is our anesthetists, like you, would always give a caudal block to these patients. But sometimes it is quite prolonged. It may take even 3, 4, 5, 6 hours sometimes. Sometimes, we start a case, in our setups, you start a case and caudal block has not been given. We would always try to, because you have already developed the pins, we do a subfacial block. You have to just put it, directly on the neurovascular bundle, on the dorsum of the pins, right under the buccal fascia. So you can give it at the beginning and you can give it at the end. That is, usually there are no complaints. And after the surgery, you can put them on oral analgesia. We do these cases and often, because our private practice is allowed. So if we do it in private sector, the next day patient is home. They will go with the catheter and they will come after 5, 6 days if you have to change the dressing. But in hospitals, usually they may stay for a few days. No complaints regarding analgesia. Psychological aspects can be, discussed.
So caudal is a mandate, caudal napkin.
Hello. Chairpersons, if you permit, can I just make a comment?
Yes,
Because I know you are pressing with time, but Dr. Rashid made very big points obliquely, and quite often my assessment situation at the international level is the same, but I try to avoid to make the comments public in the large gatherings because they are not so pleasant to make on any. But yes, number one, whenever there is a workshop with international participants, take it with inches of salt. Do not accept what they say and what they try to show. The background information is totally different and what you have vouched. I know from the first-hand information, so it is very important you pointed it out about the center in Dallas. Number two, there are other surgeons who are doing the procedure same way, who have also abandoned after a few years. And I always say that it is almost spoiling the English literature for the sake of publication. And you are misguiding, misleading the younger generations who just follow these either by seeing the workshops or by reading the literature. It is criminal. And after 10 years, you find that whatever was said, written, and taught is all rubbish. Hence, it is very important that the new generation who want to the art, science of especially this procedure must make a contact with a good mentor, remain in touch with him, learn the art from him, see the cases, then assist him, and then operate upon and discuss about the possible conflict, which is important. Otherwise, you are spoiling not only the patient, but also your own technique. Hence, master one technique, follow your own cases, find out what are the complications, and then improve your results. And I would not like to make a comment about the last person who came to Delhi about some time back. I was not party to it, but there are also many points and reservations that must observe. All is not gold, what is seen on the scene. Thank you very much.
Thank you, sir. Sorry, I just, that was wrong, but I confess. But there was a good message in that, saying what you said. जब तक आप जाएंगे नहीं देखेंगे नहीं, भरोसा मत करो. That's all.
Thank you, sir. Now I like to call upon Dr. Radhika from SMGS Jammu. His topic of talk is peri-operative management for non-cardiac procedures in babies with congenital heart disease.
A very good afternoon, everyone. Thank you for giving me this opportunity. So I have chosen this topic because many a times, because I am in GMC Jammu, So we are doing pediatric surgery, setup is there, and they are doing the best of their surgeries on the babies. But in and out, on odd hours, I am getting calls that every patient or every child who has to be taken for surgery, they need to have an underlying echocardiographic examination to rule out any CHD. So today we'll discuss about CHD, its preoperative assessment when you are taking a patient for non-cardiac surgeries, and then what is the risk stratification, any anesthetic modifications, and the post-operative management in ICU of these babies with CHD who have undergone non-CHD procedures. So as we know, this congenital heart disease is a structural or functional heart disease which is present at birth, and it is commonest of all the defects in any child, which is around 8 to 10 out of every 1,000 live births. And definitely, if they are going for any surgical procedure, if there is an underlying congenital heart disease, they can lead to an n number of complications. But there is a complexity of these defects, and we have to be very sure, and we cannot stick to any single protocol, whether it's regarding the perioperative care, regarding the anesthesia which we are using in these patients. So early recognition of the risk, the underlying CHD, underlying physiology of this congenital heart disease is very important, and to involve the whole team. So broad classification, as we know, this congenital heart disease is whether it could be because pulse oximetry in a checklist we are doing in all the children who are undergoing surgery. So broadly it is classified either into acyanotic congenital heart diseases or cyanotic congenital heart diseases. So further it is subdivided into acyanotic, it could be shunt lesions, or it could be like we have regurgitant lesions, we have shunt lesions, we have flow lesions, and we have obstructive lesions. And in cyanotic CHD, the most commonest is the tetralogy of Fellow or Fellow-like physiologies, and other like transposition physiologies and other admixture physiologies. Then comes the preoperative assessment. So any child who has any other malformation going for anorectal correction or any other surgery, we have to rule out underlying congenital heart disease. So we have to see the physiological status of the patient and to see for whether it's a cyanotic CHD. If it is a grown-up child, like after 6 months, we have to look for presence or absence of clubbing, or presence of any sweating episodes, which are very common in top physiologies. Then we have to see for the signs and symptoms of cardiac output and heart failure. Like if the child is a failure to thrive or not gaining weight, so we can assume that he has an underlying shunt physiology or an increased pulmonary blood flow-like condition. Then we have to have a cardiology review. We have to have a baseline investigations like a ECG also to rule out the arrhythmias, because many anesthetic drugs we have to modify when we know there is an underlying conduction disorder. Then also we have to review the current medications the child is on. If it's a top physiology, they must be on beta blockers. If it's a shunt physiology, they must be on anti-failure drugs. And most important is any syndromic association. So in a child who is going for any surgery, like any genitourinary surgery or any anorectal malformation, any TEF surgery, congenital diaphragmatic hernia, especially in the newborns, we have to rule out the underlying congenital heart defect. So there are n number of these, I would say, chromosomal anomalies and syndromic association, but we should be, the major ones we should pick up, and we should be careful, like the Down syndrome or trisomies, out of which the trisomy 21 is the most commonest, where along with the CSD underlying endocardial cushion defects, VSDs or ASDs associated, we can also have the atlantoaxial dislocations. So we have to be very careful while giving the anesthesia. Then other common associations, mostly which we are seeing in the newborn period or the early neonatal surgeries, is the vectoral association or the vector association, where we have a combination of vertebral anomalies, anorectal malformations, renal anomalies, and underlying congenital heart disease. So in pre-operative assessment, all the baseline investigations which we are doing, that is the chest X-ray, recent echocardiography to see the underlying congenital heart defect, and its physiology is more important. Its hemodynamic concept is more important rather than the structural heart defect. And then we have to see for the preoperative medications which they are on, because it would affect the anesthesia and the perioperative care. Then risk-wise, the patients are coming to me that they are going for non-cardiac surgery. Then we have to give on checkup we have to give what is the risk, whether it's a low risk surgery, moderate or a high risk. So all the congenital heart patients who are undergoing non-cardiac surgeries, who have single ventricle physiology or who have underlying pulmonary hypertension, they are all come into the high risk surgeries. Then if they have a physiologically normal and well compensated lesions like moderate to large VSDs or PDAs or underlying ASDs, they all come in the intermediate risk surgeries. But if they have a very small VSD or a small PDA or a small PFO, very small ASD, they all come into low risk surgery. So this risk stratification is very important for the child when they are going for non-cardiac surgeries. So then come the anesthesia management. So definitely we know that good pre-medication is very important to reduce the anxiety, to reduce the catecholamine release and avoid hypercyanotic spells which are very common in TOF physiology. So we have to give a very good pre-medication. Then we must avoid the hypoventilation and hypercarbia because it can exacerbate our pulmonary arterial hypertension. And we have to maintain a baseline hemoglobin level. We must avoid this increased hematocrit, and we must avoid the anemia because these both are very dangerous in PH situations and in shunt lesions. Then for inhalation anesthesia, sevoflurane is the agent of choice, and for IV induction, propofol and ketamine. And maintenance anesthesia, we must have a stable hemodynamics. That is, throughout the procedure, we should not have that the child should not awake, there should not be lot of bradycardia or tachycardia. The temperature must be maintained because this, if they have underlying congenital heart defect, this all will affect their systemic vascular resistance and pulmonary vascular resistance, and the whole pH and the whole perioperative care will differ. Because the whole of the physiology depends on the balance between this systemic vascular resistance and the pulmonary vascular resistance. And specifically in neonates, we must have a blood sugar monitoring. So as we can see here, so all the shunt lesions like in TOF physiologies, we must try to decrease the pulmonary vascular resistance. So all those factors which are increasing our pulmonary vascular resistance, that is the hypoxia, hypercarbia, hypothermia, or increased hematocrit, or intermittent positive pressure ventilation, acidosis, or catecholaminergic stimulation, this all must be avoided. Otherwise, they all will go into hypercyanotic spells. And on the other hand, in these TOF physiologies, like in TOF physiologies, we must increase the SVR, which we can use with the vasoconstrictors. So like I am giving an example, we have anesthetic drugs, all are affecting or have different effects on our systemic vascular resistance and pulmonary vascular resistance. Like in case of TOF physiology, which is the commonest of all the cyanotic CHDs, we can use ketamine, which is increasing our SVR, that is systemic vascular resistance, which is very much required in cases of TOF. Because TOF physiologies, we have to decrease the pulmonary vascular resistance so that the blood, very much little of the blood which is going to the pulmonary circulation in TOF, it should be maintained. And on the other hand, we must avoid the drugs which are increasing the systemic vascular resistance. So ketamine is a good drug because it is increasing our systemic vascular resistance, and on the other hand, it is not affecting our pulmonary vascular resistance. And also the most important point is de-airing, because they have shunt lesions. So even the smallest of the emboli, air emboli, it can be fatal to the child. So de-airing of the intravenous line is very, very important in cases of any underlying congenital heart defects. So we must be doubly sure when we are giving any IV drugs that there should not be even smallest of the air embolus which should not be given through the IV lines. And we must avoid the excessive tachycardia and bradycardia, like in cases of pulmonary arterial hypertension. And avoid the inotropes which are increasing the infundibular spasms. Like in cases of single ventricle physiology, where we are using our Fontaine procedures, we must avoid the fluid overload. Because what happens in our single ventricle physiology patients, there is only one ventricle which is contracting, other is only a reservoir. And our IVC and our superior vena cava are directly connected to the ventricle which is contracting. So we must avoid the fluid overload because it can be life-threatening to the child, which will not give us the time to rethink. Then comes the role of endocarditis prophylaxis. So there are clear-cut indications in what cases we need the endocarditis prophylaxis, like in all patients with prosthetic cardiac valves, with prior infective endocarditis, in all unrepaired cyanotic CSDs. So all unrepaired cyanotic CSDs, we must give the endocarditis prophylaxis. But we should not give the endocarditis prophylaxis in unrepaired acyanotic CSDs. So all patients of VSDs, all patients of ASDs, all patients of PDA, they don't require any infective endocarditis prophylaxis. But after any surgical procedure, if they have undergone and they are going like in staged surgical procedures, if they are undergoing another surgery within 6 months, they require infective endocarditis prophylaxis. So it must be given 1 hour before the procedure for all major dental or genitourinary or any other procedures. So now comes the post-operative management. So what is important in the post-operative management? In adults, what we do the bedside echo and we give the ejection fraction. Yeah, ejection fraction is more than 50%. That means, cardiac output is maintained. But no, in a child, in a neonate and in infants, the RV failure, right ventricular failure, comes very early and the left ventricular failure comes very late. So till the time we are picking up the ejection fraction, it's already the late stage. So we have to be doubly sure, that is, we cannot rely on the ejection fraction. Because the diastolic dysfunction and RV dysfunction is the first which comes in the neonates, which comes in the infants, and the systolic dysfunction comes very late. So for the cardiac output, we have to maintain in the ICU, it will be a multidisciplinary approach. We have to involve if it's in a NICU, we have to involve the neonatologists, we have to involve the pediatricians, and we have to maintain a proper preload, afterload, heart rate, hemoglobin. We cannot afford polycythemia, we cannot afford anemia. And in case of mixing lesions, we have to maintain a balance of pulmonary vascular resistance and we have to maintain a balance of systemic vascular resistance. So the baseline is adequate analgesia, adequate sedation, not much increase or decrease or variation in the heart rate, not much increase or decrease or variation in the temperature. And the base, that CRT, and what we have to see, if we are doing the regular ABGs, we have to follow the serum lactate levels. If it is elevated by a value of 2 or more over a period, then that means that we have to look for that the cardiac output is somewhere compromising. And on echocardiography, this LV ejection fraction, it comes very late. I am saying again and again, in adults and in children more than 5 years, it is important, but in infants and in neonatal surgeries which are going for TEF repair or aeronectal malformation, which cannot rely on the LV dysfunction because the RV dysfunction comes very early. And what is the most dreaded complication is, we have seen that the surgical repair is done very well, TEF repair is done very well, baby has come out, tachycardia, bradycardia, everything is under control, but still the child has pulmonary bleed and he died. So what is the cause? The most important is the pulmonary hypertension. So the word about this, we have 3 types of pulmonary hypertension, that is where the pulmonary arterial, it is defined as pulmonary arterial pressure more than 20 millimeters of mercury. So in shunt lesions where we have ASDs, VSDs, large shunts, AP windows, we have dynamic type of pulmonary hypertension. That means it is because of the increased shunt. So once we reduce the shunt, this pulmonary hypertension is reversible. Another is the shunt reversal, that is Eisenmenger physiology. If these shunt lesions, they are not operated in time, then over a period of time when we have the grown-ups with congenital heart disease, they come with Eisenmenger physiology. So this is irreversible PH. But what is we worried more about in our setup, that is in neonatal surgeries and in infancy, is reactive PH. So what is reactive PH? It is a very difficult variety and it is very challenging to control. What it happens? It usually happens in a perioperative period. And where it happens in a baby who has underlying CSD like total and ominous pulmonary venous connections, partial pulmonary venous connections, where they already have underlying, like in cases of Down syndrome, where they already have idiopathic PH. So what happens in the perioperative period? Whenever there is additional insult in the form of hypoxia, hypercarbia, hypothermia, acidosis, pain, agitation, whatever, so what happens? They have this reactive PH. And suddenly, if it is not picked up at this stage, they have pulmonary bleed and they die. So this pulmonary hypertension, reactive pulmonary hypertension, is the most common variety which we are seeing in our daily neonatal and this infants period, which are undergoing for non-cardiac surgeries. So what is the management of this PH crisis, reactive PH crisis? We have to have an adequate airway to provide adequate oxygenation and ventilation. And what is adequate ventilation? That we should not target our PO2s very high. That it should not be like 150 or 200. It should be very optimal. Like PO2s on ABGs, we should be chasing around 80 to 100. And PCO2 also we have to keep around 35 to 45. That is more PCO2 washout will also cause reactive PH. Then we have adequate sedation and analgesia. We can keep round the clock, we have to plug the ears, keep the eye patching, we should not stimulate the baby unnecessarily. So adequate analgesia, unnecessary stimulation should be avoided. Then in high-risk patients perioperatively, like in cases of babies who have underlying total and anomalous pulmonary venous connections or single ventricular physiology like truncus, we have to have prophylactic INOs standby, which we can use. And what is the more important? As I earlier said, that they have RV dysfunction. So milrinone is the better inotrope which must be used in the perioperative period. And we have a gentler mechanical ventilation. We should not be target PO2s very high and PCO2 washout. And then sildenafil in a reactive PH situation is a wonderful drug. Nowadays it is not available here IV, so we can give it orally. It has a similar action. And nowadays,
Dr. Radhika, you may like to conclude. You exceeded your time.
Okay, ma'am. Just one slide. So we have newer modalities also. Like we have ECMO, we have ventricular assist devices, and in this picture I can depict that ECMO is indirectly it is increasing our LV function. We are cannulating the right atrium. But whereas the ventricular assist devices, like in this picture right side, this is an Ampella. This is a ventricular assist device which is directly placed in the LV apex. So in a perioperative period where the heart function is low, we can use these ventricular assist devices also. So take home message from my side is, whenever you are taking the baby for a non-surgical procedure, we must rule an underlying CSD, and it is not the structural CSD. If it is a ASG or BSG or shunt lesion, we should not be worried. It is the physiology which is going to affect, whether it's a single physiology, whether it's a cyanotic, whether it's an admixture lesion. That is very important to know. And we have to stick to the anesthesia modifications. Time to time we can vary depending on which lesion is this, and perioperative care we have the, as I told, we have to prevent this PH crisis. Thank you.
Thank you, Dr. Radhika, for a deep insight of the anesthesia management in the, especially we are non-cardiac surgeons. So this is all day-to-day surgery done by the pediatric surgeons. So thank you so much.
Any question from the audiences, please?
So, Dr. Radhika, I have a question for you. So, in the complex cardiac lesions, or if the baby is having a cardiac failure and he is high on the severity of this with regard to CHD, so what are your recommendations of forming a multidisciplinary team within an institute, and more importantly, meeting before a complex case? What are your recommendations? What do you do in your institute?
Yes, ma'am. That in case of complex cardiac disease, but if they have to undergo for surgery, like I'll say like in a neonate or infant going for anorectal or a stage procedure, we cannot deny a surgery. Definitely they have to go for it. So we have to, like I said, we have to look for the physiology. We have to continue with the pre-medication. We must avoid the drugs which are, like in case of TOF, we must avoid the anesthesia drugs or the factors which are increasing their pulmonary vascular resistance. So it is the team, that is the operating surgeon, that is the cardiologist, that is the anesthesia, they should meet up, they should discuss, and they should like tell the family also that it's a high risk surgery, but we have to go ahead and these are the risks involved. But most of the times, if it's a multidisciplinary place, definitely we can do well with the patient. Yes ma'am, yes ma'am. Definitely they are the high risk patients, as I told.
Thank you so much.
Are there any predictors by which we can predict that which baby would need more intensive monitoring in the post-operative period?
Definitely, sir. There is a, like I said, in cases of reactive pH, if we know the underlying CSG and its physiology, we can predict. We know that these patients are going to have failure, these patients are going to have pH, these patients are going to have, definitely if we have a baseline echo, we know that these are the perioperative problems which we are going to face.
Thank you. Thank you very much.
Thank you.
A big thank you to our chairpersons and our speakers. It was indeed a very enlightening session. We request our chairpersons to felicitate our speakers. I invite Professor Dr. Abdul Rashid sir and Dr. Radhika on stage, please. Yes, I request Professor Dr. Nisar Ahmed sir to receive the memento on behalf of Dr. Abdul sir. And Dr. Radhika. Our heartfelt thanks to our chairpersons. I would request Professor Dr. Meeta Gupta ma'am to kindly felicitate our chairpersons. Ma'am, please. Dr. Sandeepika Dogra ma'am. Dr. Sanjay Rana sir. And Dr. Deepak Agarwal sir. Thank you so much. It gives me immense pleasure to welcome Professor Dr. Shilpa Sharma ma'am, the Chairman RIPSS, and Professor Dr. Sumitra Kumar Biswas, President IAPS, for the BHU Alumni RIPSS Oration 2024. And Dr. Vijay Upadhyay sir, the President-elect.
So RIPSS is honored to award Professor A.N. Gangopadhyay the BHU Alumni RIPSS Oration 2024. This is the first time this oration has been started by donation from the BHU alumni. May I request Dr. Vijay Upadhyay, who is a BHU alumni, to kindly give us some history of BHU, followed by introduction of Professor A.N. Gangopadhyay by President IAPS, who is also a BHU alumni, Dr. S.K. Biswas.
Thank you, ma'am. Good evening to all dignitaries and our IAPS
and to the organizing team of IPSS. There is a brief, just brief introduction of BHU. Initially, it was started at Central Hindu College, when it was renamed as Banaras Hindu University. It was established on 4th of February in 1916. The main man behind the BHU was Pandit Madan Mohan Malvi, who tried and facilitated and organized the land for the BHU. Then there is Madam, which most of the people are not knowing that Madam Animation was the lady behind bringing the curriculum and all institutes, all other facilities at the BHU. And Rameshwar Singh is the person who donated most of the land to the BHU. It is almost more than 60% of the land was donated by Rameshwar Singh. So the total area of BHU is almost 1370 acres. And now we are coming to the IMS, that is Institute of Medical Sciences. It was established in 1960. It has three parts. First is medicine, that is faculty of medicine. Second is faculty of dental, and then the Ayurveda. It has 45 departments, and it was ranking, IMS was ranking almost 5th in recent past 2-3 years. The Department of Pediatric Surgery was established in 1965 by Professor G.D. Singhal. He was the first pediatric surgeon who joined the institute and started pediatric surgery in the institute. Later on, in 1971, Madam 71-72, Madam Chudamani Gopal joined the department as a assistant professor, and from there the department take off. And the first MCH was started in 1976, and at that time Dr. Dinesh Gupta sir, and after that Professor N. Ganguly sir has joined the department as a MCH candidate. In 1998, by the efforts of Madam Chudamani Gopal, the dedicated building and operation theatre was given to the pediatric surgery department. Since then, till 2010, one or two seats of MCH has been awarded by the department, and after 2010, the seat has been increased. That is the brief introduction for Institute of Medical Sciences, BHU. May I request Dr. S.K. Vishwas to give a brief introduction for Professor A.N. Gangopadhyay.
Dr. Gangopadhyay and myself both belong to Kolkata, and we are postgraduate from Calcutta University. He was only 4 years senior to me, but Dr. Gangopadhyay, I met him for the first time in BHU when I had to pursue my MCH course in BHU for some reasons, not in Kolkata under Professor Suri Chatterjee, under which I worked for more than 1 year. I first met a person who was a confirmed bachelor and almost 24 hours dedicated to the department. To all of us, in his absence, he was our Ajayda, that is elder brother, and that was what till I call him outside faculty. I first met a person whose philosophy, we asked him once day that why did not he marry? He told us that to be a good surgeon you should not marry. That's what his philosophy, because you will be bogged down by other family things and other things. So he was available to us almost 24 hours a day. Whatever problem is there, we can approach him and he will solve. He will allow us to work, but he will supervise that even in the middle of the night. That was he, and Professor Professor G.D. Singhal and Professor Chudamani Gopal are a distant planet, but he was very close to all of us. That's, in short, I should say about him. And I am fortunate, very much fortunate to have him as my teacher, and my thesis was under him, and I still call him my guru. Thank you.
As Ganguly sir was unable to come, this gives us a chance to talk about him. So he was a great mentor. He was one person who will stand behind you when you are doing surgery. When I joined BHU, before that I had done MS from RNT Medical College, and after that I had done 2 years of job in a village where I was a full trained surgeon. But I had never focused on what other people are doing. I would do my surgery, I would not bother about how the other person is holding a needle holder or forceps. So when I joined BHU, what I used to see is Ganguly sir would take the forceps and tuck on his assistant's knuckles. Hold it properly. Why did you hold that tissue? Why are you wasting time in holding a needle twice? Just hold it once, and wherever you have to place it, just in one go you place it, and next time you again do that. And he had been doing that for 20, 30 years or maybe more for each and every person, and I adapted that habit from him. So now when I have my juniors and I don't leave the case and go that you close, I'm going. I see how they're holding the forceps each and every place, and they really learn, whether it is a MBBS student or a MS or even post MCH or even a junior faculty. If you teach people how to hold things, and even senior faculty, which I'm working in ILBS now, so they are quite senior, they are doing transplants, but if you tell them that this is not fine, they will also learn. You know, there are particular things that you have to adapt. You must have, we are having this suturing class there, even the new MBBS students are learning. So this is one thing which I learned from him. You have to be perfect in your suturing and how you do it. So even Hypospadias surgery, he would let us do it as residents, give us full hand, but keep an eagle's eye where we are placing each and every needle tip. And all the erythroplasties, most of them went very well. I don't remember that we had so many fistulas or whatever. That was just because continuous supervision was there. And when you do it independently in front of a teacher, you feel that you are like a machine and the voice is coming from somewhere else. So even when you leave those institutions and you are operating, you will hear Ganguly sir's voice coming in the ear and telling you what to do. I think all of us has experienced that kind of a thing. So a real guru in true sense. God bless him, and I hope he will deliver the oration soon. So in his absence, we will just take a photograph in front of his photograph here to commemorate this event. Thank you, sir.
Thank you so much, Professor Dr. Sumitra Kumar Biswas sir, Professor Dr. Shilpa Sharma ma'am, and Dr. Vijay sir for giving us a glimpse into sir's journey. Now it's time to move on to the next session, and let's dive into our discussions and make the most of the rest of the session. It is my honor and privilege to welcome our respected chairpersons who will be guiding us through this session. So I welcome on the stage Dr. Ashish Sabra sir, Professor Pediatric Surgery, Baba Farid University of Medical Sciences, Faridkot. Dr. Salim Naski, sir is Head of Pediatric Surgery at Government Medical College, Jammu. Dr. Smriti Gupta ma'am is Associate Professor, Department of Pediatrics, AIMS, Jammu. And Dr. Satish Parihar sir, Professor and Head of Unit, Department of General Surgery, GMC, Jammu. We welcome you all, and I invite all of you on the stage, please. We look forward to a fruitful and engaging session under your guidance. Thank you. The speakers for this session will be Professor Dr. Meeta Gupta ma'am, Dr. Tanveer Roshan sir, Dr. Vijay Upadhyay, Dr. Harshit sir, and Ms. Dheeja.
We hand over the mics to the chairpersons for further proceedings. Thank you.
Good evening, everyone. So we have the first speaker for this session, Professor Meeta Gupta from AIIMS Jammu. Ma'am will be presenting on antenatal diagnosis and counseling, a multidisciplinary approach.
Good evening, everyone. With the permission of the chairpersons, please may I proceed? I'll be very quick, and I know we are in the last session. Everybody is in a hurry to go back for the dinners. So, the next 15 minutes, I'll be talking about antenatal diagnosis and the counseling approach required in patients presenting to us in an antenatal OPD, because I'm an obstetrician, so this topic was given to me. How do we justify and counsel these parents who have come to us, and what multidisciplinary approach we take in counseling these patients. My presentation would be antenatal diagnosis, who should undergo screening, what are the methods for first and second trimester screening, what are the diagnostic tests, counseling before we offer a prenatal screening, multidisciplinary approaches, and newer advances that are in the market. These are some case scenarios so you can understand the dilemma that we are facing as obstetricians in our OPD. These are all patients who had presented to us in our OPD. She was a 30-year primary gravida with spontaneous conception, presenting with a level 2 scan showing a choroid plexus cyst. Patients were apprehensive that the baby they are going to have should be absolutely normal. The second patient was a first trimester pregnancy with a level 1 scan showing large omphocele and increased nuchal translucency in the baby. This patient was successfully managed in our department and discharged last week. Another patient presented with singleton pregnancy with a level 2 scan showing unilateral renal agenesis with left kidney absent. The patient is still under our follow-up. And another patient presented to us with singleton spontaneous pregnancy with a level 2 scan showing a larger choroid plexus, 8 mm, with a single echogenic cardiac focus. The dilemma for us is, how do we counsel these parents? So, by all these case scenarios, we all understand that antenatal diagnosis is foremost important, because this leads to early detection of congenital anomalies in the fetus. Once this is diagnosed, we go to the second part, that is counseling of the parents, and this helps us in making them well informed and make a well-balanced approach in the management of these patients. And finally, the multidisciplinary approach to ensure comprehensive care. So, coming to the components of antenatal diagnosis, we have a screening test. Once positive, we offer the diagnostic test, and then the use of emerging technologies. But what is most important is timely and accurate interpretation of all these tests. So, who should be screened? The current recommendations is that 100% universal screening should be offered to all the antenatal patients. So, coming to the screening test, that is the first line of investigations that we offer these patients: ultrasonography, maternal serum markers, and sometimes a non-invasive prenatal testing. This helps in making a risk assessment as well as maybe diagnose any fetal anomalies on ultrasonography. But we have to understand that these are all screening tests and they are all associated with limitations in their sensitivity, specificity, the false positive and a negative test. So, for a lay person, we have a first trimester and a second trimester screening. The first trimester screening, that is in the first 12 weeks of pregnancy, the maternal age, ultrasonography, along with serum markers, that is known as the dual marker because we have two tests to be done, dual marker or a double marker, that is known as. Just in case the patient does not come to us in the first trimester, the patient is offered a second trimester screening in which a TIFA scan, that is a targeted anomaly scan, ultrasound is done for the patient along with serum markers. So if you do 3 tests, it is known as a triple test. It is not in use now, but because it was done for an academic reason, so I had mentioned it. Likewise, if you do a 4 marker, it is known as a quadruple test, most commonly used. Sometimes for a research for research uses, we are using 5 markers, so it is known as a penta screening. This is how we do a screening for antenatals presenting in first or a second trimester pregnancy. Once we talk about the serum marker analysis, what we have to understand that they are always mentioned at multiples of median because we take a data of a large population and then the median levels are taken into consideration. In a simpler way, we can understand that we compare the individual to the entire population if screened. But what we have to understand that these markers are always gestational age specific. So if you calculate your gestational age wrong, you will do the wrong interpretation of these MOM levels. This is one of the best markers as best slide for as an obstetrician because this we have it in our OPDs as a guiding tool to evaluate the patient. Once we evaluate a patient, she would be either low risk, an intermediate risk or a high risk. If she is a low risk, then we do a level 2 scan that is known as a TIFA scan for a targeted anomaly scan between 18 to 22 weeks. If a TIFA scan is absolutely normal, the patient is absolutely at no risk of any anomalies. Coming to the intermediate risk, these patients have to be offered an invasive testing because we need to have a diagnostic tool. But if the patient is coming to be screen positive, there is a high chance of having an anomaly in these babies. So we will have to go for a diagnostic test or if we have an option of to refer to a genetic or a fetal medicine people. Likewise, if we miss the first trimester and the patient comes to us in the second trimester, we offer the quadruple test. If she comes in the low risk, likewise, the detailed scan is also normal. The patient is a low risk and she is followed at a routine antenatal. But if she comes out to be screen positive, she has to be referred to a fetal medical specialist. This is what we know as a targeted scan or a TIFA scan, in which we look for very congenital anomalies, major anomalies like congenital heart defects, duodenal atresia, omphocele in the fetus. But what is difficulty are these pure or soft markers, which are further categorized into minor and major markers. We have a slide, you don't need to remember them, we can put it in our OPD charts. But what we have to understand that these soft markers themselves generally are not of clinical importance, but they have been seen to be increased prevalence in patients associated with aneuploidies. As a result, these babies have to be monitored and may require further testing. Once you have screened a patient to be positive, we will have to go for a diagnostic test because this is confirmatory. They could be an invasive or a non-invasive. As the word says, invasive, we will have to do an intervention like amniocentesis or chorionic villus biopsy. A non-invasive is a cell-free DNA or a fetal MRI. But please understand that these diagnostic tests are the final confirmatory for any for any confirmation given to the parents, and this will guide us how we proceed with this pregnancy. NIPT is very clear. As such, the obstetrician, we have a very clear-cut guidelines for NIPT. It is usually offered in patients who have a history of previous pregnancy with trisomy of 13, 18 or 21. So normally, even though it is a non-invasive, but its sensitivity and specificity to an invasive is nearly equivalent in diagnosing these trisomies. Coming to the invasive, that is the chorionic villus sampling or amniocentesis. As you know, chorionic villus sampling is what is done under ultrasonographic guidance. We take a small piece of a placenta, usually performed between 10 to 12 weeks. The advantage with this is because it is done early in the pregnancy, in the first trimester, these patients, if coming positive, can easily be terminated. But the only problem is because a placental bit is taken, so there are increased chances of fetal loss as compared to amniocentesis. Amniocentesis is offered in the second trimester, around 15 to 18 weeks of pregnancy. The problem with amniocentesis is the fetus is well formed, so in case it comes positive, the termination process is associated with lot of psychological impact, as well it takes time for the baby, as well as the results usually take 2 weeks till we have a result of amniocentesis. This is what we know as the pre-genetic diagnosis. This is the latest kit, or maybe the kit that has now fully established in the market. We have a session tomorrow by Dr. Shabab, who would be discussing on whole genome sequencing, so I will not be taking much on this. Now we have screened, diagnosed. The parents are apprehensive, looking to you for guidance. Now comes the role of counseling. Now where we have to have patience and time for these parents. Once you are providing counseling, this is important because we are giving psychological support to the parents. We have to explain the risks, the results, and the options, whether they want to continue or whether terminate this pregnancy. We will also help them manage expectations regarding the prognosis and the treatment options in case they deliver this baby. Please understand that the medical facts have to be balanced with the ethical sensitivity of the gender of the parents that we are dealing with. So, once the counseling is associated with a pre-test counseling, a post-test counseling, emotional support to the patient, as well as cultural sensitivity. Sometimes we also offer pre-conceptual counseling in parents who come to us who have already delivered a trisomy or an inaugural pregnancy, because they are very apprehensive and they are usually offered a direct diagnostic test that is an invasive test instead of going a screening. So these are the only category of patients in which we offer a pre-conceptual counseling. Otherwise, if the patient comes to us with a diagnostic test showing a fetus to be affected, then we have to make the parents understand what is the risk of the fetus that they are going to deliver, the consequence of the disease in the baby, the risks and limitations of the screening, the time required, because usually they give the test today and they expect the results to be tomorrow, but it is associated with a time interval, and if required, these screening tests have to be backed by an invasive diagnostic procedure. So before we offer a pre-test, we have to make the parents understand why we are offering this test, what is the possible disease that we are trying to screen or diagnose, what are the advantages of early detection in the fetus, the risk and the limitations of the test that we have offered, as well as the time interval that we have to wait for the results to come to us. So whenever we are approaching these patients for a documentation, we always have to have the detailed history, the biochemical maternal markers, the ultrasound or any other detailed imaging 3D or 4D scan, the risk estimation, and also the option of invasive testing all has to be documented. So please remember, once we were studying, we were taught that once the mother is more than 35, then only we offer these screening tests. But over the last 20 years, this thing has changed, and now we are offering screening tests to all the mothers irrespective of the age that they are coming to us. The counseling, the parents have to be counseled that they can have a screening test, a diagnostic test, or they may not accept any screening or testing. But they have to be made aware what they are missing if they do not take these screening tests. Please understand something else, that once you say that the patient is of low risk, it does not mean no risk. There is always a 0.1 or a 1%, depending upon the test that we offer, in which we may miss these diagnoses. So, despite having a screening test normal, the patient may still have a baby which may be affected by any anomaly. So, no pregnancy is no risk as compared for aneuploidies, despite undergoing a screening test. Now, we have screened, we have counseled, we have done everything. Now comes the role of everybody. So, this is what we want, a multidisciplinary approach. We have an obstetrician, we have a genetic counselor, a pediatrician, a psychological or a social worker, and a fetal medicine specialist. The entire circle, but still it is not closed. Anybody can take a guess who I am missing? Next, we had a fetal medicine. That is part of a pediatrics. Something else. See, this circle has started because the radiologist, this is an approach is for the patient only. See, we have to understand the circle is supposed to be closed only if the ultrasonologist advised. So, this is what we are missing. So, radiologist or the sonologist is the main part for this entire multidisciplinary approach. Please remember that collaborating ensures better outcomes for the fetus, family, and the entire care team. There are some challenges because once everything has been diagnosed, informed, still the patient refuses to go for termination and wants to continue with the pregnancy. In that case, just the documentation part is to be taken care of, and we cannot force the patient to have a termination. Just to be on the safe side, our documentation process has to be very good. We also have to understand that maybe the screening test is not universally available. So maybe the patient comes to us very late, maybe at the time of delivery or late second trimester, where we cannot offer these screening tests or diagnostic tests to the patients. There are new challenges, that means new ethical dilemmas we have already talked about. Access to the patients is definitely a cause, especially in our region, because we have far-flung areas. The patient may not come to us early. And of course, the psychological burden, once the patient comes to us late in the pregnancy and the parents are made aware of these changes. Coming to the innovations and future directions, there has lot many advances in non-invasive diagnostic. AI has come for prenatal imaging and interpretation. There is a role of telemedicine, probably in near future, in next 1 or maybe 5 years, because so much of screening that we are making everybody aware, people can just make a phone call anywhere and ask this is the screen positive coming, how do we manage this patient? So this is how we are talking about telemedicine. So last slide, I hope I am on time. We offer screening to all patients. Maternal age alone should not be the criteria for offering a screening blood test. Please remember that one prenatal screening approach is usually advocated. Echocardiography may be advised in patients with increased nuchal translucency, even if the karyotype is normal. Cell-free DNA is the most sensitive and specific screening test for common fetal anomalies. No method of aneuploidy screening is as accurate in twin pregnancy as in singleton pregnancies. Remember, antenatal diagnosis and counseling are critical for comprehensive prenatal care. A multidisciplinary approach ensures accuracy, ethical handling, and emotional support. Please focus on the innovative and the equitable care to improve outcomes. Thank you. Yes, sir.
I agree that different systems function differently. Really, if a fetus has a problem, pediatric surgeons, say for the pediatric surgeon as part of the counseling protocol. Now, we come across one situation which is usually unexplained by science. So, there are diseases which we know. And there's one category we know this is PUJ, it is manageable, so there's no possibility. But then there are diseases in between where science doesn't have a distinct answer. Say for example, cerebral wall or pineapple with no gross evidence of neurological deficit, but then there is always a possibility. The risk expectations of the parents. So I wanted to talk about this E. They have taken three categories, E1, E2 and E3. So E1 they say is a high risk pregnancy, maybe the child is born with IVF. E3 is when the parents are like, no, I don't want this pregnancy.
Sir, you are the other side of the table. We as obstetrician are the other side of the table. The minute, sir, at our problem with us is we have very clear-cut guidelines if we are offering a termination of pregnancy. We cannot, because we are under the strict code of law, in case we violate, we are bound to be under behind bars. So, in case we do, if it is till 24 weeks, we do not have a problem, because in that case, we take a pediatric surgeon on our prescription slip. They say it is not compatible with life, we can offer a termination. The minute it goes beyond 24 weeks, our hands are tied, sir. It is the medical board who takes, and it is the medical board who will tell us whether to terminate or not. So, whether the patient, in case they want to continue, it's okay. But if they want to terminate, we are sorry, sir, but our hands are tied. Whatever be the guidelines, sir, because ultimately it is the government laws that, that are actually hanging as a dagger for us. Dukh bhi hota hai, but we cannot help the patient, sir.
You're right, ma'am. I will to add one more dimension.
Yes.
Thank you, Dr. Rohit. Thank you so much, ma'am. Ma'am, a very nice algorithm you gave us. Just a very small question. Does it change for a twin pregnancy with one having a congenital anomaly?
With one having?
Congenital anomaly, a severe congenital anomaly. Severe.
Yes.
With
See, if one child is having, there has to be a reason. ऐसा हो नहीं सकता है कि एक बच्चे में anomaly हो दूसरा नहीं हो. See, you have to understand whether it is a monozygotic or a dichorionic. If it has two different placentas, maybe the other pregnancy would be absolutely normal, and which you cannot terminate one pregnancy. Either you go for an intracardiac fetal demise in which you inject a KCL, but that too is associated with something, with the other baby being affected. Once you go on so much of risk analysis with the parents कि आप ऐसा करेंगे तो दूसरे बच्चे को ये हो सकता है, they will usually run away. See, how can one, it's very rare if you look.
I had one of the patients had a neural tube defect.
Sorry, what? Neural tube defect?
The other one was normal, so I had to.
At what weeks? Which weeks? Kitne weeks of pregnancy?
It was around maybe 20 weeks, something like that. A gynecologist has sent to me.
You cannot do anything.
So that's even I was confused there.
sir, this is what we are talking once you have delivered. Sir is talking once it is 20 weeks intrauterine, sir. Now is the dilemma for us whether to terminate one pregnancy and continue with the other pregnancy.
Sir, D.K. Gupta sir,
Yeah.
yes, please.
Uh,
20 weeks you can do it, but the problem is even if you do it 20 weeks, the toxins that are released from one twin will affect the second twin. That is what the parents ask us. Aap guarantee lijiye. Who will take that guarantee? And once you start putting it in words, they will run away. Because see, everybody wants to have 100. The thing is, we have come in an age where everybody wants 100% diagnostic accuracy, which we cannot offer.
Thank you very much for your very crisp presentation, which I have heard from a gynecologist after several years or decades rather. Just to add to this dynamic dimension, almost 70% of the anatomical diagnosis which needed correction or intervention are beyond the realm of intervention of the fetus. So that is the disadvantage, at least in our setup. So we are left with 30%. In this group, I think the main discussion should remain between the gynecologist and the surgeon who are diagnosing to first with and who are practicing with the congenital malformations. Others who talk more theoretically have really caused so many times the disasters. I'm using the word. And two examples I give, which are very glaring. Simple unilateral hydronephrosis in a fetus around 14 weeks. Advice, termination. Now parents, little educated, they will roam from place to place and ultimately come. I pick up a phone to a geneticist. Sir, give me one reason why do you recommend, okay, yes, I approve termination. What the gynecologist has suggested, geneticist who is about 80 years old, geneticist. He says, no, he is at a loss. Why did I say so? Not even a single reason. All right, child, we allowed the pregnancy to happen, and obviously, so hydronephrosis is absolutely correctable condition, and if it is that, and this is one of the commonest conditions, so there is no need for any intervention. If it is bilateral, only 1 or 2% are there, and this is lethal. But again, there is a lot of misdiagnosis. It is usually because of posterior valve when this is bilateral hydronephrosis, because the ureter, which is dilated, but it's so short between kidney and the bladder that it can easily be missed. Hence, even bilateral hydronephrosis does not mean always that it is a for termination, unless posterior valve with hydronephrosis, with other associated lethal anomalies are associated, then yes, termination. Third, almost 10% cases that you miss the anomalies, even detectable anomalies are missed, 10% cases. Third, 5% it is a misdiagnosis, especially like a diaphragmatic hernia or CPAM or CCAM conditions, which really overlap, and you miss 5% cases. Duodenal obstruction missed sometimes. So 5% cases are missed. 5% cases are overdiagnosed, where there is no condition, but they are diagnosed. So that's also something one has to keep in mind. And the last point, sir, I want to make is on abdominal wall defects, which is easily diagnosed, whether it is omphalocele or the gastroschisis. And again, the advice by the other groups that you put in the circle, all four, they recommend termination. Because they have never seen it, what the baby means, or how these are managed in the present day world with 60 to 80% survival in most of the centers. So unless this pediatric surgeon has been contacted, the condition will not be told, no, with the pregnancy, and we will be able to manage with almost good results. So these two conditions, at least I wish to communicate that hydronephrosis, unilateral or bilateral with query, and omphalocele or gastrochasis have no place for termination. Thank you very much.
Thank you, Gupta sir. Dr. Shilpa Sharma wants to say something.
Sharing the views of pediatric surgeons Prabodh and Gupta sir, I just want to make a comment on the changing scenario and how we have to be careful, not only pediatric surgeons, the neonatologists. I'm on the medical board for AIMS, so all the court cases which are delayed, I'm a part of that. So I've seen many parents come beyond 23, 24 weeks coming and asking for termination. So I'll talk about two such babies, both congenital diaphragmatic hernia. The prognosis of one was worse than the other, but they had already crossed the thing. So we had told them, let the baby be born and then we will decide after that. They agreed. But the neonatologist had told them 70% mortality. He had told to one of them, and the other two, he had told 100% mortality. Okay? So we have to be very careful of our words. Even as a pediatric surgeon or the ones who are dealing with the patients, if somebody has said something into the ears of the parents, even though they carry on with the pregnancy, that remains for life. So both the babies were delivered in the neonatal ICU of AIMS, supposed to be the best in India, with good neonatal care. The one that was told 100% mortality, I told them we will operate and he will be fine, hopefully. And the SRs there were puzzled, ma'am, we have already said 100% mortality, why are you taking up for surgery? I said, we will, and the patient survived, and today the child is 5-6 years old, doing well. The other child, whom they had told 70% mortality, we said, we will operate. They refused surgery. They said, not going to get our child operated. And that patient died. So, as pediatric surgeons, once the baby is born for such conditions, if they are operated and they remain well for the first 3 months, they have overcome their ICU stay and gone home, they remain fine. We don't see mortality later on unless it's a bilateral CDH with pulmonary hypertension developing and all those things. So there are conditions where the decision is made within 3 months of birth in congenital diaphragmatic hernia and it's presenting up to 20 weeks of life. Similarly, biliary atresia, they are counseled so badly by the gastroenterologists, even if they come within the 2 months. There was one who was 55 days of life. Nice child. We want to do the surgery. No, they refused. They waited till the child died at 8-9 months, but they were strong in their brain and they don't want to get the surgery done. So we have to be very careful. Times are changing, advances are there. Tomorrow you never know what cure you have for which disease. Thank you.
Thank you, ma'am. Thank you, Dr. Mita. You enlightened us from everybody. Thank you. Now the next speaker is Dr. Tanveer Roshan Khan from RML Institute of Medical Sciences, Lucknow. He will be speaking on innovations in fetal surgery, discussion on in utero surgical interventions like fetal endoscopic procedures and their implications for postnatal care.
Good evening, respected chairpersons, respected senior teachers, colleagues, and all my dear friends. I am humbly gratitude for the organizing persons who have given this opportunity, and I will try to fill the gap of the discussion, what happened just before Meeta ma'am has created. It is really important to keep the pediatric surgeons in loop just at the beginning of detection of these anomalies, because I know this is missing and we have created a separate OPD for antenatal clinics at our center. And we do get antenatal references, almost 2 or 3 per OPD. So it's really important. So the topic which is given is fetal surgery, pretty off the routine what we do in normal practice. But I will divide the talk on brief history, the development, the normal, the routine cases we do in these cases, some innovations and the ethics related to fetal surgery. So basically the things revolve around pediatric surgeon. He was Michael Harrison, who considered to be the father of fetal surgery. He founded a treatment center in 80s and started doing some open fetal surgeries. Vesicoscopy was done for congenital hydronephrosis. Gradually the enthusiasm grew, and some human and animal trials were taken. But as we all know, in the beginning fetal surgery was controversial, often misunderstood. It was not decided whom to take for surgery.
So to regulate, a group of people came forward. They had specialists in fetal medicine, pediatric surgery, radiologists, physiologists. They all met in California in 1982 and they formed a group which is known as International Fetal Medicine and Surgery Society. And the purpose that they made certain guidelines how and when to treat and do a fetal surgery. So they published that the fetal surgery was to be considered only in cases of simple fetal structural defects and with a predictable clinical course. But at that time only CDH, few hydronephrosis and hydrocephalus were candidates for fetal surgery, and they developed a criteria to whom fetal surgery can be given. This is important to know. These criteria, they guide us to whom we can apply fetal surgery. So the defect or disease could be accurately diagnosed and distinguished from other anomalies. The USG imaging was able to determine the cases of, they are serious enough to warrant in utero intervention. There was good understanding pathophysiology and natural history of the disease. That is what I am saying. Natural history of the disease, especially the congenital anomalies, cannot be completed with the involvement of pediatric surgeons. So animal models had shown the benefit from fetal surgeries and the maternal risk was low. So unfortunately, open fetal surgery carried significant morbidity for both mother and fetus. And the advent of MIS in the field helped to create two main collaborative research groups. They were basically European and American, known as Europe Fetus and NAFTNet. So we need a team to actually do these extensive procedures. The problem is multiple. First is there is a complex disease and we are dealing with two patients. So it needs a careful planning and open communication before and during after surgery to the members of the team and the team, as I said, should involve all possible who are being involved in the management, especially pediatric surgeons, obs gynecologists, pediatric anesthetists, obstetric anesthetists, cardiology, radiology, ENT, neonatology. So it's a huge teamwork. But the use of modern radiology, modern ultrasound guided techniques have helped the surgeon to consider these surgeries. So the surgical approach remains three-pronged. We do with open fetal surgery, we do MIS in these cases, and the exit procedures. Open fetal surgeries are performed during second trimester of the pregnancy. Highly organized team of specialists are needed and they used to intervene, resect life-threatening tumors during mid-gestation. And over the last decade, it has been most often used to perform in utero repair of MMCs. Their unique operation requires GA for the mother. Anesthesia relaxes the uterus, allows placenta to keep delivering the oxygen to the baby. Anesthesia also passes through the placenta to the unborn child, allowing the fetal surgery team to perform necessary procedures without causing pain or discomfort to the baby. Open surgeries can be done spina bifida repair. They have shown that fetal repair decreases the need for a shunt or improve movement or prevent neurological damage. Large CPAM lesions can be repaired by open surgeries. If the mass continues to grow despite steroid or medical management, open surgeries can be considered. Obviously, removal of large sacrococcygeal teratomas, they have been done by open surgeries. So once the procedure is complete, the fetal remains in the uterus and the pregnancy is continued under observation, obviously by the gynecologist and the fetal medicine people, and they need to be monitored for uterine contractions and signs of premature membrane rupture. So MIS has taken advancement. Now fetoscopic procedures have come. They use all the patients submitted for fetoscopic procedures are often pre-medicated to tocolytics. Local regional anesthesia are usually used. The instruments that are used have diameters between 1 to 2 mm. Sharp procars have developed to accommodate the wide range of diameters used for different operations. So in operative fetoscopy, surgical team can see the ultrasound and the fetoscopic images simultaneously, and that guides the appropriate entry point and trocar into the amniotic cavity, avoiding the placenta and the fetus as well as the maternal organs. However, some operators have documented the safety in their hands. The transplacental approach, despite this, most operators still avoid to hit the placenta. So fetoscopic procedures are usually used in twin-to-twin transfusion syndrome, where fetoscopically you can. We'll discuss in later slides how specifically we can do. So in obviously Lutos we can use fetoscopic procedures and congenital diaphragmatic hernias. So there are procedures performed using smaller endoscopes and very narrow working channels. So this is one image of fetoscopic laser ablation of abnormal chorionic vessels in twin-to-twin transfusion syndromes. Coming to the third method of doing fetal surgeries is exit procedures. Exit procedures are highly modified kind of cesarean deliveries, which requires obviously experienced team. The goal is to partially deliver the baby but maintain the placental support just before the planned cesarean and perform the surgery before the baby is completely delivered. So instead of stopping the blood flow and separating the placenta from the fetus, from the uterus, you can do a C-section, and exit procedures allows the oxygenation continuing in that baby. So that maintains the circulation and the surgery can be completed. Exit procedures in principle to perform controlled delivery, allow fetal intervention with established airway. Indications include severe airway obstruction with cardiopulmonary insufficiency, cervical masses, some CPAMs, or some high airway obstructions or pulmonary agenesis. It is performed under general anesthesia, fetal anesthesia, uterine relaxation with maintenance of circulation. The steps include fenestrial incision, then hysterotomy based on the placental location, and partial delivery of fetus, the placement of monitors, fetal airway establishment during the surgical intervention, and delivery is completed. So basically it's a huge team that is needed and very careful planning for these surgery to be done. So orotracheal intubation can be done during the exit procedure to maintain the airway just after completion of the procedure. So as we all know, anesthesia has been already discussed, but there are certain things which you need to be careful, like tocolytics, how to give them. There is chances of vertebral compression, and the doses of anesthetic drugs, they all need to be discussed before planning the exit procedures. And when multiple ports or cesarean section could be necessary, regional anesthesia epidural can be planned. Fetal anesthesia is indicated only for endoscopic procedures performed directly on the fetus. So all fetal anesthetic drugs are typically administered through intramuscular route and consist of opiates and non-depressant. So as a surgeon, we should discuss it with pediatric anesthesia beforehand. Now coming very important issue in doing fetal surgery is the ethical considerations. The ethical issues are very complex because we need to explain the procedure being done in two patients, that is fetus as well as the mother. So there has to be strong evidence for benefits of fetal surgery, and it has to be explained and should not be experimental in nature. So the overall goal for fetal intervention should be clear: to improve the health of the fetus by intervening before birth and to correct a treatable anomaly. Mother and fetal that undergo these interventions must have the same protection afforded to other study participants. I mean, this has to be explained. So coming to common conditions which can be treated, the first, as I have already discussed, is twin-to-twin transfusion syndrome. Gynecologists must be knowing. So that is one way you do it with now fetoscopy. Laser ablation is being done to treat those vessels, chorionic vessels, which are done between 16 to 26 weeks of gestation, and usually a single uterine access site is available. Very important to do fetoscopic procedures in lower luto or lower urinary tract obstructions because of posterior urethral valves, urethral obstruction distally. So in all these, it can be done, but the PUVs, they do much better in long run because of, I think, better understanding of the disease or better prognosis than proven value or other causes of urethral disease. At the moment, we can do it by VAS, that is vesicoamniotic shunting. That is done under ultrasound guidance where double pigtail stent is inserted, usually combined with amniotic infusion. Fetal cystoscopy again can be done where the scope is inserted into the fetal bladder to diagnose the source of obstruction and to ablate the PUVs. The commonly used methods to ablate the valve includes the guide wires or the hydroablation or the laser ablation. So main complication of shunting include failure to insert, occlusion of the catheter, dislocation, and sometimes the fistula formation. So there was a study done in UK that was percutaneous VAS called Pluto study, and they performed the cases in 31 cases, and 16 submitted to VAS, 15 were managed, and the report was that it has advantage. Fetal surgery or the VAS has advantage of confirming the diagnosis of PUV and more accurate in selection will benefit from the valve percolation. So long-term renal function is less encouraging, but overall survival when compared to expectant treatment has definitely improved. Myelomeningocele repair, MMC repair is has been historically treated with open fetal surgeries. Now this is again one condition that is amenable for fetal surgery, although it was associated with very, not encouraging results in the early part of, so now it is being tried at very advanced centers. So CDH is one disease that is being managed by fetoscopy, usually now replaced by feto, where there is a tracheal occlusion that is being done intrauterine. So that studies have reported that the pulmonary arterial hypertension definitely has reduced than the cases which were operated postnatally. So fetal surgeons prefer MIS procedures as I discussed in these cases, and fetoscopic endoluminal balloon occlusion is the choice to be done for CDH. So usually done between 26 to 30 weeks of gestation, and as we all know, trocar is placed and maternal abdomen and amniotic cavity is guided by ultrasound. A fetoscope is inserted through the fetal mouth and advanced into the fetal trachea. Once the carina is reached, the balloon is inflated and left just above the carina, so that it remains occluded and inflated by the amniotic fluids, so that expansion of the lung can happen and a better prognosis is expected. So there are studies that have shown that there is definitely improved survival in cases of feto. There are cases of amniotic band syndrome which can also be treated by fetal surgeries, where the release is done and can help in preservation of the limb. So that has also been tried at various centers, and obviously SCTs are there. They are being treated by in utero surgeries or fetal surgeries. Resection of tumor can be done, or there is ablation of the vessels or the feeding vessels. So removal of external part is usually done, and that leads to feasibility of delivery and better management in post-operative period. There are certain studies that have demonstrated improvement in perinatal outcomes for hydrops in cases of SCT, but still very few centers are doing that because of mortality was quite high in certain papers. So it is all decided by the team to be overweight by.
Can we conclude?
Yeah, bilkul. I'm just so CPAMs are another way of another particular set of problems that can be treated. So they all have shown improved survival if done in fetal surgeries. Now the topic was innovations. Definitely fetal surgery is also going for certain innovations, and the role of radiologists is very prominent in these innovations. So development of ultra fast MRIs, very helpful for the fetal surgeries. They are very helpful in precise volumetric measurement and a better imaging of intracranial structures. Improvement of image processing and reconstructive softwares are also coming up, so that there are better understanding of fetal diseases, and you can now think of creating a 3D generated, computer generated models, so that a better planning can be done. Surgically, better scopes are coming. You have thinner scopes, so that fetoscopy can be done easily and without damaging the other organs. There is another approach now that has come up, is use of gas to repair spina bifida, or a mixture of gas and half amniotic fluid to create the space. So that is all coming up with fetal surgeries. Now there is a development of biocompatible adhesive that pre-seals the amniotic membrane before fetal surgery to prevent the early rupture of amniotic membrane. That is known as AmniSeal. And the biggest innovation that is coming, this is a photo of recently 2024 only, when fetal robotics are coming to treat the fetal anomalies. So this is again very important, but definitely has challenges. This has high cost. We don't have clear directions to whom to hit. There is lack of funding. There is narrow niche area. Animal studies are still mandatory to prove the benefit of doing these fetal surgeries, and additionally performing strong RCTs are needed. So, but there is always a future of surgery, especially fetal surgery. So we can rely on advancement of MIS and better technologies. So India is not lagging behind. So we have All India Institute of Medical Sciences that is doing 4 to 5 shunt procedures, and exit procedures have been performed. Few centers in like Chennai, Kochi, Bangalore, they are doing fetal surgeries. So exit procedures are mostly done, and fetoscopic are also coming up. So technological advancements and minimal exposure are one reason, because we know more centers to come up with these. So this is again very recent news. Lilavati has, is collaborating with foreign universities to start with fetal surgery programs. And for the purpose of knowledge, for all audience, I will definitely recommend this paper in JIPS, and it is wonderful to know that people are coming up for fetal surgeries in India. So do read this, and I definitely like to conclude from this article only that the standard of treatment for most fetal anomalies remains planned delivery at a tertiary center with appropriate neonatal intensive care facilities. Few conditions may benefit from fetal surgical intervention. As MIS will improve, definitely we are looking forward to have more facilities in different centers. So fetal surgery should develop hand in hand with fetal medicine. Thank you so much.
Thank you, Dr. Tanvir, a very nice and elaborate presentation. Just that I have assisted to fetal surgeries in West UK. So there are a lot of ethical issues and medical legal concerns in UK. So how easy is it in the Indian subset to convince the parents for this? Because 2 lives at stake. So how easy would it be?
See, what now I am trying at my center, we do get antenatal references. We have some MMCs which are being diagnosed antenatally by T5 scans or not. So we convince that the child you are going to have may not be socially useful, or you have a child that is dependent on others, or may have not many problems. So if you can explain the severity of disease, the parents may come up with an idea so that we can have a fetal surgery, or at least they can give a consent. Ethical issues, they are there. We need to explain both the parents as well as the child, and I think institutional ethical board should have a role into giving these facilities to the surgeons so that they have a closed door discussions and a meeting, and ethical clearance can be taken after that.
Question from audience?
Fetal pain.
At what point of time fetal feels the pain, or how you measure?
So as a surgeon, it's very difficult to analyze the pain because surgeons are, they are not into, they are pain givers actually. So, but for that reason, we need to give the anesthesia this part, how to, manage the during surgery or after surgery, they have to be controlled by, tocolytics for the mother part. For the fetal part, I think this has to be, understood how to know their pain.
You can measure it indirectly by means of blood levels of endorphins.
Yeah, endorphins or heart rate or measuring the, oxygen levels.
Second thing, the basis of foundation stone was I think laid in 2011 by MOMS trial.
MOMS
Successful first trial in fetal surgery.
Yeah, MOMS trial was there, yeah. I skipped few slides just because it was getting too long. Yeah, thank you.
Thank you, sir, for comprehensive presentation. What is your experience about the exit procedure? Those children.
Frankly speaking, at my center of training as well as the center I am working, we don't have any exit procedures. It's all theoretically, but I have seen, people doing, and as Salim said, he's worked with certain centers who are doing. So we just watch them and learn how it is being done. So, but we can plan exit procedure. It's not a big deal. Actually, we need a team that is dedicated to that work. So exit procedures obviously can be done before planning a cesarean section, having taken into confidence of anesthesiologists and the gynecologists. So personally speaking, so I'm trying to do one, very soon, maybe. Thank you. Thank you.
So the next speaker is Dr. Vijay Upadhyay from SGPGIMS Lucknow, Ethics in Pediatric.
Good evening to Chairperson, dear seniors and my dear colleague. Greetings from SGPGI Lucknow. And first of all, I will thank the organizer, especially Dr. Vijay Kundal, for inviting me to the IMS Jammu. So nothing to declare, no conflict of interest. So ethics is a broad term that covers study of moral and specific moral choices to be made. It may be common morality or particular morality. Common morality, that means pertaining to the whole state, whole country, that do not harm the hospital, do not create problems. And the particular morality is particular to the patient or to the community or to a tradition. And second term, which is commonly used, is primum non nocere. So non nocere is a primary dictum for the ethics, which means do not harm. When we say do not harm for the patient, do not harm of the society, and try to make no harm. So ethics is defined as a philosophical discipline concerned with what is morally good and bad, and morally right and wrong. And it is an inherent and inseparable part of clinical medicine. Why? So clinicians have an ethical obligation to benefit the patient, to avoid or minimize the harm to the patient, and respect the value and preference of the patient. So Coming to the history, I will not go into detail, but the oldest document of ethics in medical sciences is from the Hippocratic Oath. I'm skipping these slides because I know we are all getting running late. So, the foundation of ethics has two things: fiduciaries and best interest standards. So, fiduciaries is a person or a group of persons or an organization which take the responsibility of the baby. So, in pediatrics or pediatric surgery, the pediatric patient, parents or a legally authorized representative of the patient and a pediatric surgeon are involved, so they are known as co-fiduciaries. Second, we know that best interest in standard. So we have to work in the best interest of the patient. That is the dictum for ethics. Now, what are the core principles of ethics? There are four core principles of the ethics. First is beneficent. That means to do the good thing for the patient. So, always do a good thing which will help the patient and to recover the patient. But at the same time, do not harm the others. So, first is beneficent. Second is non-maleficent. That means do not harm the patient. Third point is autonomy. Autonomy means the patient has a right to choose, patient has a right to know, patient has a right of choice, and patient should have a right what will happen to his life after a procedure or after an intervention if it is done on it. Then later comes the justice. Justice is not related to the patient but is related to the public. So what is evident? So for the justice, each patient has the equal right whenever it is possible. But due to lack of the equipment, lack of the infrastructure, it may be possible, some may get it or some may not. So when we say an non-malfeasance can be traced down to the time of Hippocrates. But the autonomy and justice were added to the core principle of ethics in 19th century, in which the justice came at the last of the late 19th century. So the first, when we say non-vegetarian and autonomy relate to the individual children health, and justice is more relevant to the public health. So in children, the principle of beneficence overrides all other principles. So the patient who are under 7 years, the beneficence is the foremost guiding part for the ethics. As the patient grows, the autonomy takes a role. And as the patient goes to the adolescence, the autonomy takes the major role. So there are 3 C's of the ethics, that is consent, capacity, and confidentiality. So consent is an instrument of mutual communication between doctor and parent, or legally allowed or authorized representative with an expression of authorization and permission to take the choices on the behalf of the patient. So the consent may be of several types: implied, blanket. The most important consent which we take is informed written consent, and it is valid legally. We will come to the informed consent later in the subsequent slides. So second is capacity. The capacity is defined as a being able to understand and retain information relevant to the decision, use or weigh up the information which is given to the patient or the LAR. Communicate the decision by the patient or the LAR must be able to communicate the decision by any means, by verbal, oral or written, in any way. Then there comes the confidentiality. The facts should not be revealed. That is the confidentiality between the patient and the treating physician or the surgeon. But nowadays, because of the n number of referral level, there is a breach in this confidentiality. So the clinician should try to maintain the confidentiality, but there is certain places where you need to vary from this. Suppose the patient is suffering from a sexually transmitted disease which may cause a difficulty to a lot of the patients, then we have to disclose these things. Similarly, sometimes, as I told you, basically is the truth telling. The important link between this, the patient and the clinician or the physician, is the telling the truth. Truth which should be revealed to the patient or the legally allowed or advised or the person who is taking care of the children if patient is children. So coming again to the informed consent, there are the certain requirements which we should take care while taking or giving, or when we are saying we are giving or taking an informed valid consent. First is patient must be competent to understand. The patient, if it is minor, the things to be explained to the caretaker or his parent, he should, or the patient or the caretaker should understand the things which are being explained to him. Second, patient must be committed to decide. When I am saying the patient, if it is minor, the parents or the caretaker will be the responsible person. If it is adolescent, the patient himself takes the decision. One thing is important is that if we are taking or explaining anything before 7 years, we call it assent, not the consent. And if it is, patient is between 7 to 14 years, he can give an oral assent, and if it is more than 14 years, he has to give a written assent. This has to be minded and to be taken with the point. So patient must receive full disclosure. Third point is the patient must know all the facts about the intervention if we are going to do, all the disclosures about the nature of the disease, the prognosis of the disease, and which intervention is going to be done. And the last is patient must be able to act voluntarily. It should not be like that the patient is non-conscious and you have told everything to the patient, but he is not able to understand and he is not acting voluntarily, not deciding, not able to tell you that he has listened or understand the things. So, should able to give consent to the proposed action. These are the 5 points which should be included in the informed consent. So, the informed consent should have the proper knowledge or the details of following, that is diagnosis, nature of the treatment, prognosis, risk involved, prospect of success, alternative treatment, and finance involved. Now come to the patient-doctor relationship. There are 4 models of patient-doctor relationship. That paternalistic, that means the doctor is taking all the care as the father is taking the care of his son or daughter. So he will decide on the behalf of the patient. Second is informative, that means the doctor or clinician will inform all the things and then the patient has to take what he wants to do. Third model is deliberative, that means the physician will deliberate or inform all the things, but he will say this is better or this is not good for your future development. And the last, which is now most commonly used, is interpretative model. Interpretative is the clinician and the patient will discuss point by point and everything will be explained to the patient, and if the patient have any cross questions, he will ask and the clinician will answer the questions. So this is the most common and most widely used model nowadays for patient-doctor relationship. So there, as we say, if there is something 2 persons involved, there must be conflict. So there may be a conflict between the patient and the doctor, maybe minor, that has not a good relationship, not want to listen, the patient didn't want to listen to the doctor. Moderate when he is saying that he doesn't believe on the treatment, or the advice which he is giving. And the severe when there is confrontation, there is quarrel. So all these things, if we again go to the interpretative one, if we are dealing with a patient with interpretative model, all these conflicts can be minimized. So fertility. Another thing is fertility. That means interventions that are taken unlikely to produce any significant benefit to the patient. That may be quantitative. That means if this intervention has been done, the patient will gain something, but the amount of gaining is not that good. So whether we should go ahead with this intervention or not. Second is qualitative. There may be benefit, but qualitatively it is not that good. So there are two things, medical fertility is quantitative or qualitative. So ethics behind withholding the therapy, there is no chance situation. That means when a patient is sick and which is not very commonly used in our scenario, but may be used in the Western, whether we have to continue the support, life support or not. So no chance situation, that means even we support at any cost, the patient is not going to survive. Second, no purpose. That means if we put a support, patient may survive, but the quality of life is not good for the patient and the relative. Third is unbearable. That means the patient attendants are not able to bear the cost of the treatment. Thank you for patient listening.
Thank you so much, sir. So just a small question. So like still in today's world, I've seen the children like minor. So consent being given by any paternal uncle, maternal uncle, and we still rely on that. How reliable is that consent? So
that's why I say there should be legally allowed representative of the patient. If he is legally allowed or advised, then you can take. We cannot say what he is saying is right or not. That is not our perspective. But you will be in court, in front of court of law, you will be saying that you have talked to the person, and that I told you, if it is minor, you have to be with LAR. If it is between 7 to 14, assent should be taken from the patient orally. He must get. So at that time, a clinician should be there, medical staff, some staff must be there, a representative of the patient should be there, and a third person should be there when you are taking informed consent. I skipped that slide because it will be too large. So informed consent, I have told you these points, and these points are important, that there should be a doctor, there should be staff, maybe it may be a technician, maybe a nursing staff. Third is the child representative, and fourth is any other person which is not of these three.
this question was just for that. We have landed into the time now. Like we are no less than West. So the people are coming with ethical issues and everything. So we should be very cautious. It's not right that now.
Yeah.
Thank you so much. Any questions from the audience?
Brought to casualty by some unrelated person, and the patient himself is unresponsive, unknown.
So that I told the capability. So if patient is unconscious, we cannot take consent for him. Then we require a person who will take the responsibility of the patient, or a medical board, or a team which has been created in your institute or any organization. We cannot take consent if it is of the mind, if it is semi-conscious also. We think that he is not able to give you a proper answer, we cannot take a valid consent from him. So for that, there should be a thing that he should understand, he should act voluntarily, he is able to take the option, he should communicate, he should be able to communicate with you. So the person who is previously conscious, but at present is not conscious, we will take the previous mode, when he was conscious.
Sir, I would like to hear. No, but the point here is, if the patient is unresponsive and if it is a life-saving procedure, do you need consent?
I didn't get it.
No. The question was, the patient is unresponsive. So, in such a case where there is a life-saving procedure, do you need consent?
So there come the two principles. First is beneficiary, to do the good thing. And second is autonomy. Here there is conflict between autonomy and beneficiary. So beneficiary says that do the good thing to the patient. Now autonomy, because we are doing the thing for the good. If a team, there should be a team which will give you a consent, you can go ahead. What I can understand is this.
I'll add one more point to your.
Yeah.
Little bit. about ethics in the morning. During the day. See, whenever we do a research, we take approval from the institute ethics. To you, straight to the point. I want to change that. My understanding was title of
author list.
ma'am, ethics committee doesn't do.
Even because it doesn't, because we have to register all the. We have to write.
Ma'am, you can come here. You're audible. Madam, I think what he change in methodology.
We are designing a study, and a study has been approved from the ethics. Then study is different thing. Writing a paper is different thing. So he can add or delete the name of the author if he has not contributed. Suppose I was a researcher. I was contributing him in the research, but in manuscript writing I am doing nothing. Will he include my name or not?
Prabodh sir, can we have the discussion poolside at the dinner party?
This is an ongoing discussion. We have to discuss it.
Thank you. We have a poolside discussion. Something to talk there as well.
Thank you.
Thank you.
Thank you, Vijay sir, for enlightening with this topic, which is least touched. Thank you so much, sir. So next we have advances in psychiatric care in children and parents with surgically correctable birth defects. Dr. Harshita Hemant from AIIMS Jammu.
Good evening, chairpersons and the audience. I am in a position where amongst surgeons and pediatricians here, I am more of a medical professional. So without further ado, I'll talk about the psychiatric aspects of in children with congenital birth defects, especially the correctable ones as well as the ones which are difficult to correct. Now, if you go back into literature, even if you go into PubMed, even if you go back to 3 decades of pediatric surgery research, which is even there in your pediatric surgery seminar articles, there is only 1% of the research which is related to mental health or psychosocial aspects. So clearly there is a paucity of research regarding to mental health and psychosocial aspects. So within that 1%, whatever justice I can do, I'll try to do it. The outline of my presentation would be on the introduction part, a brief on it, impact of these birth defects as well as their corrections on children, impact of the same on parents, as well as the current, what's happening about it, and the future directions regarding it. So if you go into different articles, be it from pediatric surgery, be it from pediatrics, be it from psychological medicine, you will see a varied percentage of comorbidities of psychological aspects, be it trauma, be it anxiety, be it depression, be it developmental or cognitive impairment. So the incidence varies from amongst different articles from 29 to 55%. So usually what we have as a surgeon, what you would be seeing is the visual or the what is the visible defects, but the functional impairment is the one which is more distressing to the child. And if you even look into data regarding trauma or PTSD, the children who are having functional impairment have more dysfunction compared to the ones which are having visual, which is visible defects, because the ones which are kids which are having visible defects, they tend to have a validation from their parents as well as the physicians, whereas the functional ones do not have that validation from them. So if you look at it, even their QOL, their psychosocial functioning, mental health, both in short term and negative, long term, they have negative consequences, the functional deficits. Even it has been noticed that there is a 4 to 5-fold increase in psychiatric problems in these children as compared to healthy population groups. Now coming to anesthesia, yes, anesthesia, a good pre-op anesthesia will help in reducing the anxiety as well as intra-op also, but there are articles which are suggesting that multiple inductions of this anesthesia, exposure to the anesthesia in children below 2 years, they have found some neurodevelopmental deficits in these children, but there needs to be further more studies on this to conclusively say what type of neurodevelopmental defects are there. Again, other aspects which will be considered for difficulties in these children would be multiple hospitalization, traumatic treatment procedures, and parental dysfunctions. Now coming to the impact on children, most of these children will have trauma, which is an accepted fact, but certain of them will process trauma in a different way, which may cause post-traumatic stress disorder. Some of them may perceive pain in a more, I can say, more severe way compared to other children. Most of them will present with internalizing features, which is more of anxiety, depression, or regression for that matter. Some of them will present with agitation and also with psychosocial impairment. If you follow them longitudinally, there will be body image issues. There will be in certain children who have had stage procedures for a long period, they may have school refusal issues. And if you some of the studies which have followed them into adulthood have seen that they have a lot of them have anxiety neurosis and dissociative episodes. Now the risk factors for these kids would be the severity, visibility, and the predictability of these malformations and the symptoms of these, the length of their first hospital admission, number of admissions, repeated treatment procedures due to pain, stress, and trauma, their personal, a child, how it is made, a personal vulnerability and its coping strategies, and how the parents are, the parents' response and their functioning, and the social environment in which they grow up, maybe their peers, maybe their school, how they are taken care of. Now, another important aspect in these kids is their parents. Now, it has been noticed that 30% of parents of children with congenital birth defects, they have symptoms consistent with diagnosis of PTSD, with more than 80% having clinically significant symptoms of trauma. It has been also found that many of them have elevated symptoms of depression, anxiety, as well as some kind of distress. They say mothers are more, the research says that the mothers are more affected than the fathers, but this is with respect to handling the diagnosis. But when it comes to handling the child, probably the father's confidence also matters here. It has been found that there are higher divorce rates amongst these parents who have children with congenital birth defects, and this itself causes a vicious circle which involves the child and which can affect the child mentally. Now, currently what's happening is that psychosocial assessment is mainly at the assessment level, is mainly on quality of life and anxiety, and the management is, it's more of a SOS basis management, and it's mainly managed by the treating surgeons as well as the pediatricians. There's lack of support groups, and there's a need for a formal training approach in pediatric surgery training. Now, what I would say the future directions would be, one thing is awareness and education to the parents. Now, the awareness, how do you increase awareness? It is how you break the bad news to the parents about the surgical interventions as well as the birth defects, and educating the parents in the first visit itself regarding how extensive the surgeries will be, how good or bad the prognosis is. Once you prepare the parents, and once the parents are prepared, probably they will be able to handle the child better, and in turn the child's mental status depends on how the parents will handle it rather than how the pediatric surgeon handles the child. I would suggest that probably a formal assessment of child and parents in all cases of pediatric surgery should be there. At the moment it's not happening, probably over time it will be there. Probably pediatric surgery can have multidisciplinary team with a child psychologist and a social worker for starting. Subsequently, probably if you find there is someone with features of trauma, features of anxiety, you can refer them to a psychiatrist, but I think a child psychologist and a social workers will suffice with your team. Family therapy for parents who are having dysfunction secondary to these diagnosis. Parent support groups, which in the West they have tried this with some success, but I think probably it's just like Alcohol Anonymous. These are groups which will help them, empower them. Yes, they will come to you for the diagnosis, they will come to you for the treatment, but probably they won't get a better person to understand them than another parent with a similar child. So parent support groups are a big positive if you can have it in your settings. Longitudinal follow-up after correction for functional improvement, there I could only find 1 or 2 studies, but a longitudinal follow-up into adulthood would be ideal, which will help in seeing whether the persons that you have operated, whether they have completely been rehabilitated into the society. And as like I told, there needs to be a formal training in your training curriculum for the pediatric surgery itself, where you talk about the neurodevelopmental aspects in these children, and as well as about breaking bad news. Coming to take-home messages, I would say that birth defects are correctable, but at the same time are distressing for the family and the child. Functional impairment is the submerged iceberg, which probably we need to give a bit of impetus on. breaking bad news and educating the family holds the key in the prognosis of these mental health problems of these children as well as the parents. Support groups are ideal, and if possible within your setting with the I understand probably institutions like AIMS or larger institutions are able to do it, but when you go into private settings, support groups is something which would be really helpful. A multidisciplinary team with a formal assessment for all cases will not only help you in management but also will probably further research in this area. And finally, the inclusion of mental health evaluation in the training curriculum, which is, I believe, is the need of the hour, considering if you look at the paucity of literature in it for the last 3 decades. I think I'm done here. I did really like this T.B. Harris et al. Seminars in pediatric surgery, and the Dissett et al., which talks about psychosocial problems in children with congenital birth defects, again in seminars in pediatric surgery. Thank you. I would take any questions if anybody has.
Thank you so much, Dr. Harshit. Again, less touched and least touched topic and very important for children. So just to add a point that the books or the societies of the congenital anomalies which deal with it, they are reducing the age of surgeries for the children, and they write the first line just to reduce the psychological stress in these children. So every society is very worried about the psychological stress, and it should be done like that. That's it. Just adding that. No questions from my side, from the audience.
That I believe that would be under the purview of the.
Thank you. Yeah, yes. Thank you. Nice. Thank you, Dr. Harshit. Definitely, pediatric psychological problems are on the rise, and definitely, family plays a big role. Any question? Yes, ma'am, please. Dr. Mehta, how you do prescribe both? So from today onwards, you prescribe to both. Thank you. Thank you very much. No discussion at poolside, please. Thank you very much, sir. Thank you very much. I think last speaker? Yeah. Last but not the least.
Dr. Miss Dirja's not with us.
Dirja Nursing College, AIMS, Jammu. She's left. Then we conclude here.
Yes, so we
thank you very much.
all the speakers for those wonderful talk. As a gesture of gratitude, we'd like to felicitate the speakers first. I request our chairpersons to to please kindly felicitate the speakers. First of all, I'd like to call upon stage Professor Meeta Gupta. Now I call upon Dr. Tanveer Roshan Khan. Dr. Tanveer Roshan Khan. Dr. Vijay Upadhyay. Dr. Harshit Hemant Salian. I would like to call upon stage Dr. Vijay Kundan to felicitate our speakers, our chairpersons for the session. So I would like to felicitate our chairpersons, Dr. Salim Laski, Dr. Smriti Gupta and Dr. Satish Parihar. We thank everyone for your gracious presence and patient listening throughout the day. Before we break for the general body meeting, I, on behalf of our organizing committee, would like to extend a warm invitation for the banquet dinner at Ames Guest House today at 7:30 p.m. Also, I'd like to bring to your kind notice that we begin tomorrow at 9 a.m. So I request all of you to be please seated by 8:45 a.m. tomorrow. Thank you all. Thank you so much.